program, which has been used to disproportionately to incentivize the closure of intermediate care facilities, which are often disparagingly referred to as isolating institutions. Yet our most fragile citizens are served there and in states across the nation. The committee may not be aware that money follows the person for 1 year only. Quality measures do not include mortality rates, abuse incidents, transfer trauma data, or unexpected deaths. The blatant disregard for this subset of the IDD population is widespread. Nationwide, we have an ongoing crisis of a diminishing pool of direct support staff. It was identified in Kansas in 2003, yet remains largely unaddressed. We have a fragmented abuse reporting system, which obscures the quality of care issues within the community. ARC, the national organization, is currently pushing permanent funding of MFP before Congress, even though rebalancing the system has already occurred across the nation, and only a fraction of the DD population now live in ICFs. ARC continues to ignore mounting community tragedies in scattered settings and claim that my loved one and others live in the dark shadows of institutions. Incomplete and selective data continues to give the impression that there are active COVID-19 clusters at KNI. I think we could all agree that employers cannot control what employees do once they leave the workplace. Pop-up cases continue to occur at KNI, but as of 3/10 yesterday, there were 0 residents and only 6 staff currently testing positive. Over the entire span of this pandemic, only 17 KNI residents have tested positive, and there have been no deaths occurring at KNI due to COVID-19. Our families are grateful for the compassionate care our loved ones receive at KNI. It is the least restrictive environment for them. So in closing, I would just respectfully like to ask the committee to help us answer one question. Why do community advocates continue to push the most vulnerable into scattered settings under a system which continues to fail at building capacity for them? Thank you very much, and I'd be happy to answer any questions.
All right, thank you. We'll take questions at the end of all the testimony. Next, I have Haley Ordone. Did I pronounce that correctly? Legislative co-chair with Kansas Adult Care Executives Association.
It's Ordone. One of these days we'll get it right. That's all right.
It's been one of my weaknesses forever. Thank you for bearing.
Yes. All right. First and foremost, good morning. Thank you for having me here. I am here on behalf of Kansas Adult Care Executives. We represent long-term care, senior living, assisted living, independent living. We're one of the hardest hit sectors right now with COVID, and a lot of my testimony is going to focus around that. First and foremost, though, I need to start with an appreciation and a thank you for everyone's part in the 3 following things. First and foremost, the Sparks funding has been vital in assisting us both past and hopefully in the future for providing aid of all sorts of financial support. It's been vital for our survival. Secondly, the PPE portal that we were allotted, that it's been our Christmas gift. So thank you so much. And then finally, for the assistance with the unified testing strategy, we appreciate that. However, I am coming before you because we have problems, and further my testimony, I know better than to present before you all without solutions. So let's get to that. First and foremost, the staffing, number 1. Staff is the biggest issue. They're leaving at industry high rates for multiple reasons. Top reasons being the mandatory required testing. Based on our county positivity rates, some of us are testing twice a week. All of our residents and all of our staff, we are having staff leave and go to hospitals and clinics where that is not mandated and required. Another reason we're losing is just the stress, the trauma, and the responsibilities. We are having to do additional responsibilities such as testing, supply ordering, reporting systems to both state and federal, writing and training staff on all of these policies, visitation reopening plans, and the ever-changing scheduling needs due to quarantine and positive cases. Staff have also left our industry due to being on modified quarantine. We have members that have not lived in the same household as their children for 6 months. Really take that into perspective, 6 months. We also have staff that have worked for 16-hour days for 10 or more days straight. constant, and we wonder why their immune systems get compromised and they contract this virus. Unfortunately, there just doesn't seem to be an end in sight. Hazard pay rates are at double and triple the normal hours due to these COVID outbreaks. And I want to reference this chart. I tried to make this as easy to understand as possible. Look at those rates that we are being charged and paying to provide staffing in our industry. It's not sustainable. So below, I come with solutions. And I know I'm going to run out of time before I address them all, and I pray that you have questions about them. However, future coronavirus funding, it's going to be vital for our survival. State wage pass-through dollars, there's a couple of different options there that we propose too, with our Medicaid reimbursement rate that we could directly apply to staffing wage increases. The third I really want to support is the National Guard. We will utilize anyone willing to come in. Extending and instilling the temporary aid position, that goes away with the emergency disaster declaration status, and it will cripple us even farther than we are right now. We would also like to hold virtual CNA training courses and work together to support collecting samples and some better resources from our lab. The testing is taking up a lot of our time, and we would like to come up with a solution with the state to minimize that so that we can focus our efforts back on the actual patient care that we're there to provide. We're in dire needs, and like I said, I know to come with solutions, so I will be happy to stand for questions at the appropriate time.
All right, thank you very much.
Thank you.
Next, we have Matt Johnston, Director of Business Operations of Maximum Healthcare. Welcome to the committee.
Thank you very much. Chairwoman Landwehr, committee members, thank you for allowing me to speak today. I'm here to advocate for a rate increase in specialized medical care provided through KanCare. I've stood in front of you many times in the past advocating for this same issue. We've been requested to work with the departments to come up with unique solutions to try to fix this issue. Specialized medical care is provided to some of the most severely injured pediatric and adult patients in our community. And at the current reimbursement rate, families are struggling, providers are struggling. MCOs are doing their best to try to come up with unique solutions, but the fact is it's just severely underfunded. And as this was all occurring before COVID, but as we're seeing more and more nurses not being able to provide in the home setting. We've had families testify. We've had several people throughout the community come in and explain why they're struggling. We've worked with KDHE and KDADS to come up with those unique solutions. So it's not just saying we're going to fund everything. We've looked at caseloads, transfers between budgets. We've tried to come up with the outside the box thinking. So at this time, I really do ask this committee to make a recommendation to the legislature to increase the specialized medical care rate to $47 an hour. I think with this change, you will see a level of care that's provided in the community that we've never seen before. It will really create the solution that so many families are struggling with, wanting to be in their home and not being able to because just lack of services. So I want to thank committee members here. I want to thank the entire legislature as over the past 3 years, you probably heard me talk a few times. And I want to thank the departments as well, KDADS, KDHE, who've really dug into this issue. And I think we do have the data at this point that we can come up with a solution to make sure everyone's taken care of. I know we're on a time crunch, and I'll go ahead and wrap up there and I'll stand for any questions.
All right, thank you. We're going to take questions at the end. Next, I have Keith Pancras, Chief Executive Officer of Sunshine Meadows Retirement Community Center. Welcome.
Hi, good morning. I'm not Keith Pancras.
You're not. I looked up. I was like, okay.
Yes, unfortunately.
Let us know who you are so we have it on our records.
Sure. Rochelle Marting. Unfortunately, Keith is tending to a matter at the facility this morning. Thank you for the chance to be here.
How do you spell your last name?
Marting, M-A-R-T-I-N-G. Mr. Pancras had hoped to share with you an example from Sunshine Meadows Retirement Community that reveals a kind of loophole, so to speak, in legislation that left the facility uncompensated for 9 months and about $40,000 of care to an MCO member. In those 9 months, the facility billed the member's MCO each month, but the MCO's claims system had an error. It had the wrong date of birth for the member in their system. That came from the state's claims system that fed to the MCO. That error prevented all 9 months of those claims from being paid, and the facility spent a year working with the MCO trying to get that fixed, trying to manually push those claims through to be compensated. And ultimately, the error was corrected about a year later, but by then, those 9 months of claims were outside of the normal about 180-day time frame that facilities can typically file claims and get paid. And the outline that Mr. Pancratz shared with you highlights some of the basic concepts of our state's prompt pay rules, where MCOs are required to pay providers timely once the MCO receives a clean claim. And a clean claim is one in our regulations that includes an error in the state or the facility of the MCO's processing system, right? So a claim that has no fault of the provider. But what I want to talk about is the receipt of those clean claims, because today providers bill electronically. And they send those claims through a middleman, a clearinghouse that checks the provider system and the payer system to make sure basic data match. So in this example, it was checking patient's name and date of birth, and they didn't match. So it sends that claim back to the provider. It's rejected. It never even gets in the door of the payer's claims processing system, so to speak. It's never received. So in this instance, because it was never date stamped, marked, received, the facility has never been paid for those claims, even after that error was corrected. Now, the MCO did give the facility to correct its, to resubmit the claims. The facility followed the instructions, gave it to the representative who had been assigned to this special case and still was left uncompensated. Now, while the facility is obviously very frustrated about its situation and the amount that it believes it was owed and never compensated as a result of that error on the state and the MCO's claims processing system, it really hopes that this example will be helpful to the committee to help reinforce really the spirit of the prompt payment rules that we have in Kansas. And Mr. Pancratz asked 2 things of the committee: to please consider legislation or recommending legislation that would close that gap about the receipt of claims by the MCOs when it cannot be received because of that middleman that most providers and payers use. And also consider exercising your authority, your existing authority under contracts with the MCOs to instruct the MCOs to make special payments in these very unusual situations where the error is not on the provider's end, but on the MCO's end and otherwise would have been paid. Thank you very much for your time.
Thank you. Next we have, okay, so is Keith also going to testify?
He's not here today.
Okay, thank you. Then we have Leslie Anderson, Executive Director and Aging Disabilities Resource Center Administrator, Kansas Association Area Aging's on AAA's. Let's just go there. Welcome to committee.
Thank you. Thank you, members of the committee, for allowing us to come to you with challenges and issues and some solutions. Today, I want to talk to you about the correlation between the aging and the home and community-based services and highlight the services that the AAAs provide as the single point of entry so people can age in place. So this extraordinary year has brought a lot of challenges. And when we look at some of the services that are provided by the AAAs and the program of the Aging and Disability Resource Centers, I've highlighted some of those, and I wanted to bring your attention to the significant increase in the crisis exception applications. So lately, since August, there have been 206 that have been submitted, and 146 of those are currently in process. This allows a person to bypass the wait list and go onto the waiver or PACE instead of entering into a nursing home. And in response to all of the calls, the call center, which is a service under the ADRC contract, they have responded to over 5,000 contacts within a matter of 2 months compared to the 11,000 in 6 months prior to COVID. That is a substantial increase, and that shows us that there is a lot of concern in the community. And how do we respond to that? And in my recommendations, there are some solutions to respond to some of these critical issues. In May, the ACM, the Administrative Case Management Program, started, and during that month, 113 consumers were served. And in October, 481 were served. That's a 326% increase. People are trying to navigate to the Medicaid system, and they need help with documentation and support along the way during the eligibility process after they've been functionally eligible. Then one of the last things that I want to talk about is the satisfaction rate of these services. The ACM has a satisfaction rate of 95% in helping the individuals, and the ADRC in general has a 98.5 satisfaction rate. So we know these programs are very helpful and they're effective. And so we are comfortable in making the recommendations that the legislature, by recommendation of the committee, appropriate adequate funding to eliminate those wait lists and to start looking at programs and evaluating the impact on the communities related to social isolation, social determinants of health, including studying the aging population and how we are going to be prepared for the number of individuals who are going to be aging in place, and then to study the workforce. Because as more people want to live in the community, there has to be a workforce to support that and to make it more palatable to individuals to enter into an industry that is very difficult. Thank you so much for your time. I appreciate it, and I will stand for questions at the appropriate time.
All right, thank you. Next, I have Sean Gatewood, Co-Administrator of KanCare Advocates Network. Welcome to committee, Sean.
Good morning. Thank you for having me here today, Madam Chair and members of the committee. I'm here today to talk a little bit more about some of the things I've addressed this committee before. We've had a global pandemic, and it's brought a few things to light. And it's been one of those things that's been sort of paradigm shifting events in the world. And so frankly, my greatest fear is that as the vaccinations have been rolling out now, they're going to be starting to move in our country, potentially by the weekend, is that, in 6 months, we kind of proceed with business as usual. And that's what worries me. This legislature acted 2 years ago, session before last, and increased the protected income limit. And I think that has shown itself to be wise beyond what we knew at the time, because of its ability to help people stay in their homes and stay in those sort of community settings as much as possible, particularly in light of how this virus has functioned in more congregate living type settings. With that in mind, there is more work to be done with that program, as well as potentially others, in building capacity for living in the community when it's so appropriate. And so we have waiting lists that are out there for 2 different waiver programs. And as my colleague from the AAA has talked about before, there's been sort of this uptick in some of the other programs. And quite frankly, we need to build that community capacity to help people live in their homes and again, when it's fit. So we're open to those suggestions, but I think that increase in the protected income was a huge step forward, and we'll be looking for other opportunities in the future. And I'll stand for questions at the appropriate time.
Thank you. Then we have Mitzi McFatrich, Executive Director of Kansas Advocates for Better Care.
Good morning, Chairwoman Landwehr and members of the committee. My name is Mitzi McFatrich, and I am the Director of Kansas Advocates for Better Care. And I'm here with a few ideas and also some concerns. As you all are aware, older adults that are living in congregate settings have been at the highest risk of death and illness and the devastation that COVID-19 has been wreaking this year in Kansas and across the nation. And so I would like to ask you, as you prioritize funding and legislation in the coming session, and as you make recommendations for the KanCare and HCBS oversight program, that you consider a few things. One is immediately assuring the constitutionally guaranteed rights and the civil liberties of older adults that live in adult care facilities. You may not be aware that the governor's order and CMS guidance didn't actually formally suspend individual rights for residents in nursing facilities to associate freely and to have visitors. What it did instead was reduce the ability of people to come into the facility. But older adults are not having any voice in that choice. And so that's one of the ways that I think that we can address this in terms of a solution. And that is making sure that in policy decision-making, older adults do have a voice, their own voices, and through the long-term care ombudsman program. I would also encourage you to think about creative ways to support staff that can facilitate visits, whether those are in person or virtual, because many facilities don't have adequate staff to make sure that's happening. When Haley was talking about staff who haven't seen their family for 6 months, let me tell you, there are residents who have not seen their family or friends since March of this year, far longer. That is having deeply concerning results and consequences for older adults in care facilities. I would also ask you to stay the course and make sure that older adults have a right to access the courts and pursue justice as the Constitution guarantees them when they are harmed because of lack of maintaining defined health safety requirements by facilities. And I would also ask that you continue to focus on marshaling and distribution of the resources that are needed to stop the spread of COVID in adult care facilities, but also in the community through home and community-based services, by making certain that there is adequate protective equipment and staff to be able to address the needs that older adults in care facilities and receiving long-term care at home have. And that would include medical strike teams. I also would ask you to consider a solution for essential caregivers and authorizing essential caregivers, which would be a designated family member, to come into the care facility and help with the care of residents. It would be a way to relieve staff.
Time is up.
Oh, I'm sorry. Thank you, Chairwoman. And I would just ask that people look at the rest of my testimony in written. Thank you so much.
All right, thank you very much. We have Christi Wells, Policy Director for Oral Health Kansas.
Good morning, Madam Chair and members of the committee. Thank you for the opportunity to testify before the committee this morning, as well as the option to join virtually. As you said, my name is Christi Wells and I'm the Policy Director for Oral Health Kansas. We are the statewide consumer advocacy organization dedicated to improving the oral health of all Kansans. I'll keep this brief. Our ask of the committee today is really to recommend an oral health briefing in both of the Senate and House Health Committees in the first 30 days of the 2021 legislative session. At previous KanCare Oversight hearings, we shared some work that we've been doing around new studies and reports on oral health in Kansas, and we're excited to share that some of those are ready to be shared with all of you, and we would just love the opportunity to bring together national and state stakeholders to share that information with both of those committees, along with an update on the dental reimbursement rates. I will share just very briefly that the dental reimbursement rate increase that was approved in the 2020 legislative session did go into effect in November and is retroactive to July 17th. And I believe you have a list of those codes that were included in that rate increase in your response packet. There is further information on the rates and the studies in our written testimony, but I would be happy to answer any questions at the appropriate time. Thank you.
Thank you very much. Next, I have Mike Burgess, member of Kansas Developmental Disability Coalition.
Howdy, Madam Chair.
That's not unusual for me not to be able to spit the words out.
Well, I'll change it up this time just to throw you off. All right, so as the chairwoman said, I'm Mike Burgess, and I'm actually with the Disability Rights Center of Kansas, but we're a member of the Kansas Developmental Disability Coalition. And here today, just to share some news, a number of us have talked, and you guys have all been very interested in the waiting list as well. One of the things that's just been an ongoing challenge is what we don't know about the people on the waiting list. So the state knows where they live and how old they are. And we know that there's just under 4,400, I think 4,394 individuals on there. And we also know that it's currently upwards of 9 years that the person who just came off had been on the waiting list. So that's what the folks have to look forward to who just are getting ready to sign up. So unfortunately, what we don't know is we don't know what their needs are today. We don't know what their needs are in 3 to 5 years. And so those are some questions that I think would help all of us if we can work on that. And so here today, well, and one of the things we know is that a lot of people are now entering service not because the waiver spot came up, but because of a crisis. And unfortunately, it isn't the best service for those individuals, and it's not best service for us as taxpayers either, because people entering via crisis typically have higher needs than those who would come off organically. So today, I'm here to share on behalf of the DD Coalition that all of our members are committed to bringing back a proposal to share with the state agency and share with the legislature on how to conduct a study and look at both what it will take, potential funding sources, and the action steps to accomplish that. Part of that too will be building a tool so that we can maintain this going forward, because a one-time study would be great, but if we actually build a tool that we can utilize going forward, that's going to help the appropriations and Ways and Means committees build a better plan how to serve folks. And secondly, it's going to help providers. We have a capacity challenge, so that will help them to be able to better strategic plan on what the needs are going to be going forward. So in a nutshell, that's what I'm here today, is to share that good news that we're planning to commit to do that for this coming session and bring that back. And with that, Madam Chair, I'd be happy to stand for questions at the appropriate time.
Thank you very much, Mike. Appreciate it. Next, we have Michelle Monger, Vice President of Government Affairs with Leading Age Kansas.
Good morning, Madam Chair. This is Rachel Monger with Leading Age Kansas, the State Association for Nonprofit Long-Term Care. And I'm going to talk really fast so I can get through a few different topics that are going to be kind of just a preview of what we're going to talk about next week, much more in depth. And that is time that we are so grateful for. And you'll be able to speak with 4 different nursing home providers across the state about their experiences, issues with COVID, and some possible solutions. So again, thank you for that opportunity next week. It is hard to overstate how bad our staffing situation is. Thank you to Haley Ordoin for coming here this morning and sharing her experience with staffing. It is very similar to what we are hearing from our providers all across the state, and it is dire. And there are few solutions out there to help our providers at this point. And it has been going on for months. It's not new. You guys have seen the number of outbreaks we've had throughout the fall season, and that has really exacerbated everything we've been going through. And that includes PPE supplies, which are still a stressor. In the beginning, it was masks, then it was gowns, now it's gloves. And then, of course, with the increase in outbreaks, it leads to a much higher burn rate for PPE. So it just keeps that negative cycle of not having enough PPE and just always struggling to find it. And as you might imagine, it becomes more and more expensive. And it is frustrating. It's frustrating for us. I know it's frustrating for you guys to keep hearing it 11 months into this pandemic, that we still have supply chains that are so shaky. Testing, it is not universally good. The majority of providers are managing, but it is, as again, Haley mentioned, it's a huge logistical, financial, and staffing lift that, again, we're going to talk about more in depth next week. You'll hear that from members. And then the last one is the nonstop questions we are getting from our members about the COVID vaccine rollout, and there not being very many answers. We know in general that long-term care workers and residents will be in the first phase of vaccine distribution, but there are a lot of unanswered questions beyond that. We will note that although nursing home residents are in that first phase, they are not at the top of the list. They're still behind hospitals staff, prison COVID unit staff, safety net clinics, pharmacists, EMS workers, state of Kansas continuity of operations, which I haven't actually heard that term before. I don't know what that is, but we do know that other states are coming out with plans and they have prioritized long-term care residents much higher than we are in Kansas at this point in our distribution plan. So I'm going to go ahead and stop there. I try to talk as fast as I can, and I'll be happy to answer questions at the end, of course.
All right, thank you very much. All right, committee, we do have in your packet 1, 2, 3, 4, 5 pieces of written testimony only that you may want to review at a later point. Are there questions for the conferees we just heard from? Representative Carpenter.
Thank you, Madam Chair. This is for Aileen. On the second page of your handout here, you've got pre-COVID hourly rates, and then you've got COVID agency hourly rates. So what agency is that requiring that, or?
Yes. So, sorry, to try and put this in perspective, what I did here for a visual for you was on the left-hand side, that's state average or regional average. I understand some more rural and urban areas are going to have a variance, but I took our average of what our hourly rates were for those based on also our per patient day reimbursement through the state, what we're able to pay normally. During the time of this pandemic, we are doing everything we can to try to adequately staff. Part of that solution has been to reach out for agency support. It's not ideal because we have brand new people stepping into our facility that do not know our residents, but at this point, we train them the best that we can in order to provide the care that we are needing. The agencies, this is the average that they are charging if they're even willing to come into a facility with COVID. Most of them do not want to, and when they do, they have to have a separate COVID contract in place that we agree to pay this hourly rate, this hazard rate. I have utilized a regional or a local staffing agency, the nurses company, Trinity Agency, and Cascade were the ones I was able to get communication to respond back to me to provide staffing. And even at that, it was almost a lag time out before we can start getting people in.
So these are temporary agencies that you're dealing with? Yes. Okay. Thank you. Thank you very much.
Representative Ballard.
Thank you, Madam Chair. I just want to note something, and part of it is from the testimony from Joan Keller, where she talks about how he follows the person, but but she's also referring to a policy that we have of being totally inclusive and making sure that they're out in the community. On the other hand, I'm looking at Mike Burgess, and part of what I'm looking at this is his paragraph that says, we can help ensure people can remain in the community and be able to intervene for those in crisis. Unfortunately, if we do this the right way, ultimately, if we do it the right way, we're reducing the number. So actually, when you look at it, you're saying that your person needs more special care. And you talk about K&I, the services provided, and all of that. And then the other part that the state has been promoting for many years is that we should go into the community and be more independent, the money should follow, and everything else. Have you advocated for your grandson to go to K&I or other places that have special services that the community cannot actually provide?
Yes, I have. We raised our grandson in the community, and we had numerous crises and failures within the community system that was fragmented. We placed him at K&I in 2008. where he was stabilized, and then the community providers found creative ways not to serve him and gave excuses not to serve him. He's high risk, high need, and high cost. So venture to say that the economies of scale that would be possible at KNI, which provides a tremendous service for the most profoundly disabled, is not being allowed to operate properly. Even though there's no mandate for the institutionalization, there's an unfair portrayal before this and other committees regarding the care that people receive at KNI. And I visit my grandson regularly at KNI, and I know what goes on there. So I don't know if that answers your question, but I think that there's a compete for money, obviously, and there's an economies of scale that can operate without unduly putting people at KNI, and it's not being allowed to operate.
Is that true?
He's been there for 12 years, yes.
Okay, so
the community doesn't want to serve him, and they have not since we tried to have him transferred back in 2009.
Would it be correct to say that you're talking about some of those that served when he was out in the community that will not serve him within KNI?
Nobody will. We can't transfer him out. We want him at KNI because they provide oversight, but we tried to move him back in the community closer to us, and the community providers will not serve him. They will not.
Okay, that's what I was trying to get to. Okay, now, Mike Burgess, would you come forward, please?
Madam Chair?
Yes.
I've got a question for the Bueller Sunshine Home. What remedy would you like?
Okay, Representative Ballard has a question for Mike Burgess, and then we'll come back to you.
Okay. Okay, now, Mike, you heard the whole scenario. Is your organization or any other organization you sponsor or know of, what would be their reasoning other than those services are not available to that level in the community, even though you are promoting community involvement, and so is the state? How would you respond to Ms. Kelly?
Well, and I guess I'm not sure. I mean, I think part of it comes down to choice. So the components I'm talking about, there are people who want to remain in their home and want to remain in the community and are feel best served in the community. We're trying to enable that. There are folks with significant needs who are being served in institutions, and that's a great setting for those folks. So I think at least what I'm talking about is different than what Mrs. Kelly's talking about as far as that. So we're talking about the folks who are currently in the community on a waiting list. A lot of them, transition aged youth would be one, big group of folks. If they don't get on the waiting list when they're 5, and parents aren't necessarily thinking about that at that time. Their spot may not come up, they may not be able to be on the waiver, and so they may graduate from school to their parents' couch. And that's not a good service for the individual. They lose abilities, they lose skills during that time, and the best thing, if we can help them to have a good transition into employment, competitive integrated employment, they'll have fewer needs, they'll have better health outcomes, and they'll have fewer needs down the road. And so it's a win-win-win situation that we're trying to set up. And the challenge is we don't know the current needs of the individuals. So even if you approve the slots, it would be a big challenge today to serve folks because the systems aren't ready to provide those services today. So
I appreciate the response. I just think it was important that we sort of get that portion of it straight, because if somebody's listening from the outside and say, well, gee, over here they hear it, over here they can't find the services, and that's where they are. You're talking about really a different population in many ways, even though it could be disabilities, it could be whatever those services are. All right, thank you.
Madam Chair, if I may make one more statement. Families in crisis are not permitted to access the ICF care option under KDAD's gatekeeping policies, which go beyond federal law, and they're not even following their own CMS assurances. And I would appreciate a further discussion on that at a future time. Thank you.
Thank you, Madam Chair. All right. Senator Berger.
Thank you, Madam Chair. I'd like to ask the representative from Sunshine Homes what remedy she would like the committee to provide to help solve the problem that you're dealing with the $40,000?
Good morning. Thank you very much for that question. I recognize this is not a forum for necessarily specific solutions in every case, but there are mechanisms already in place in these really unusual claims. There are contract provisions between the state and the MCOs that require the MCOs to make payment when the state directs them or instructs them to in special claims, I think is the term that's used. There's also a mechanism through KDHE to instruct the MCOs to make payments timely with the interest that's due in unusual cases and claims, including those that involve timely filing. Both of those mechanisms could be appropriate here.
Further questions, Senator?
Thank you.
I guess one question that I have is, it's my understanding in trying to become familiar with this case, is that the agency has said that there is no route forward to make this payment. Is that correct? Not the MCO, but the agency.
I'm sorry, when you say the agency?
KDHE or KDADS, whichever one's doing it.
I'm not familiar with that statement.
Okay, I think we're running into a set of rules that may prohibit because of time deadlines that were not met by whomever, and we're not going to go into all of that today.
Well, sure. So in terms of the normal appeals process, right. There would be factual disputes there because the facility actually has filed some appeals that they never received a response to. So they have not pursued the state fair hearings process, if that's the process that the agency is referring to.
I just want everyone that's involved, because I'm sure we'll hear about this again when we have more time to deal with it, is that the timeline of deadlines is what's going to be important in the discussions. All right. Are there further questions, committee, for any of our conferees? Oh, I'm sorry. Representing KanCare.
Thank you, Madam Chair. My question is for Matt Johnston. And while you're walking up, I think to save time, can I just tell you what I think I hear from your, and you tell me how I'm wrong?
Sure.
Because there's a lot of numbers here. And so you're requesting, you're proposing an increase of up to $47 an hour. What is it currently?
$31.56.
Okay. And then you went through all of these figures, and the bottom line is that you believe that increase would reduce hospitalization days by 2.5%.
To cover the entire cost of the funding, both either state general funds or all funds, it would be a reduction of 2.5% of all funds, or I believe 1.8% of state general funds.
Okay,
so,
and then you've also figured that in order to make that budget neutral, it would only need to be approximately 1%.
Yeah. This is my analysis of data that I received from KDHE. I'm not saying that the departments support my analysis, but I wanted to show the committee exactly how I came up with my analysis.
Well, it's exactly shown.
I apologize if it was a little much, but I wanted to make sure you saw my whole thought process.
Just my brain this morning's not absorbing all that. Okay, that's all I needed.
And I do want to say with the different funding mechanisms is, this was a breakdown as you've encouraged us to work with the departments, and we try to think outside the box. There's obviously, if we wanted to fund it with new money, we could do that. I know where the legislature is at. I know that's more difficult. I wanted to make sure you had all the kind of different ways we look at it.
Thank you.
Thank you.
Thank you, Madam Chair. I do have another question.
That's it. Go ahead.
For Mike Burgess.
Representing Ballard already had 2 or 3. I might put her on a limit here shortly.
Mike, I'm really inspired by this proposal, can you, because I'm always trying to figure out why that was just always just a big glob of numbers and we didn't have any knowledge of what the needs are. Can you tell me what the timeline is? Are you thinking that you will have a proposal for this coming session or next year?
That's the hope. I mean, obviously we've still got to get a lot of folks together, but I think, some other states have done similar things. And so we'll look at that. We're not going to model it exactly because I think we've got a lot of experts right here in Kansas who know how to do it. But I think we've got the right partners in the room to begin having that discussion. And then, like I said, our plan is to present it to KDADs. And we've had some discussions with KDADs as well. I mean, they've said, bring us a proposal. So we've said, okay, we'll bring you a proposal.
So what would you need legislatively? Just funding?
Funding will be certainly part of it. And I think we're going to look at a variety of funding sources too. I think we're not just planning to come to the legislature. I'm a little bit out on a limb here because I'm just one member of the coalition, so I don't want to speak for all of them. But I think that's in general our plans to try and look at it and figure out a good way to help solve this and make meaningful progress.
And then just my final one is, I'm making this all one question.
Thank you. And she was talking about me.
It's a follow-up. Once you start work on creating that list, how long do you anticipate that'll take?
I think it'll be relatively, probably within 6 months or a year, hopefully, for the process. I mean, it's part of it's setting up the system to collect the data, and part of it's the process. It will likely be some surveys and other mechanisms as well to do a full study of it. But there's a lot of experts, a lot of smart people that we want to engage and help solve this and make meaningful progress.
Great, thank you.
Something the data is out there. Representative Ballard, last question. Final answer.
If I keep on dragging it out with question after question, it'll be one question, okay? All right, yeah. That's how we do it. All right, Rachel Monger, please. This is a question that I think is a general question that the legislature is going to have to deal with. In many ways, she indicates that staffing agencies are short on workers, and almost all agencies that I know of have reported that to me, and have quadrupled their charges for nurses and nurses' aides, right? So we look at all of that, and as a result of this shortage, hospitals are having the same, with no options left for providers, but to go with CDC emergency measures, which then allows asymptomatic COVID positive staff to care for COVID patients as well. My question is, at which point, even though it is a private source, free market, all of that, at which point do we step in as to how much they can quadruple or charge that cost? Because that puts the people providing those services that by federal law must provide, and yet could be financially not able to even support that.
So yes, we agree. And actually last session, we did have a bill that Chairwoman Concannon did allow for a hearing to talk about staffing agencies and the amount they charge and the huge problems they cause even pre-pandemic in our workforce struggles and workforce dynamics in healthcare. And so, yes, we agree, and we would be very happy to talk about, and actually did plan on bringing that up next week, a lot of the issues we have with staffing agencies that have only, as you noted, have increased exponentially during a crisis. And it does cause real problems.
Thank you for that response. And for the agencies that are providing this, just so you understand, I understand that supply and demand is what we operate on in this country in many ways. But at the same time, I think a person should be able to make a profit, should be able to have their business, grow their business, but at the same time realize that on some levels, this is a health issue, this could be a debt issue, this could be the worker has to work and they have rights as well, that we should be able to work out something that financially it's feasible for them to do, but at the same time provide these services that we must provide. We can't decide that we're not going to provide them. Thank you, Madam Chair.
You're welcome. Thank you, committee. Any further questions? All right, seeing none, we're going to advance forward. One thing I might note, I forgot to mention, committee, on the written testimony, the first individual, Roxanne, on your list was not submitted. So if you're looking for it, it does not exist. Next, I'll welcome Kerrie Bacon, KanCare Ombudsman, to the committee. Kerrie, are you on?
Okay, I'm unmuted now. Thank you for the opportunity to talk with you today. I will be brief in my report. You have a copy of the full report before you. I do want to let you know at the end of October, we had 2 volunteers in Olathe who were back in the office and volunteering. Since then, we now have additional volunteers that are mentoring and training in the offices in Wichita and in Olathe, Johnson County. And we have a couple more that are going to begin training. So we're pretty excited about that. I will also let you know that we have our position for volunteer coordinator posted right now and are hoping to get some good candidates for that. If you look at the bottom of the testimony page, it shows a chart that shows that we have an increase in contacts since second quarter, and it has a comparison to the clearinghouse because a lot of times the calls are connected to applications. The clearinghouse is pretty much maintaining their call volume since second quarter, so they're still down. We are down compared to first quarter, but we are not down as much. So if you have time to go and look at our basic issues, Medicaid related issues, that's on page 14, it shows that Medicaid eligibility issues has almost doubled in calls from second quarter to third quarter. And our Medicaid information update or status update information has almost tripled from second quarter. We're still not up to kind of the average of what we were before the COVID, but it is increasing. The other thing I would want to draw to your attention is that we are trying to use Facebook more as a way to let people know about things that are going on. And we have done a test. It's in our appendix on page 25. Wichita State, that contracts with us for our volunteer program, boosted one of our posts. And it was basically just to let people know that we're out there and available. And we boosted it for about a week. And we did get an increase in people who saw us. But we didn't really see during that time period, during second quarter, an increase in calls. I took a look at it over weeks, every week during that quarter, and it seemed to maintain about the same. So we're not sure whether the increase for this time frame is due to the new system that we're using for referrals, which is IRIS, or if it may be connected to Facebook, or just an increased need, but it is increasing. And I think I'm going to leave it at that unless anybody has any questions about something they've seen in the report.
Committee, are there further questions? And if you haven't had time to skim through it with speed reading, which I don't do, she's always available to answer any of our questions that we have. So are there any committee members that have questions? Kerrie. All right, Steve, thank you very much for being here with us this morning.
Sure, thank you.
All right, next committee we have, oh gosh, what's this guy's? Oh, Jay Ummer, the Attorney General's Office, our Medicaid Inspector General. Welcome to committee inspector/senator.
Yeah, there are a lot of has-beens that could be put on there.
Hey, we're kind of an elite group.
You are definitely, and there's definitely a really elite member of the group here. It's a Rokar Stokar.
I'm gonna run everything.
The rest of that is Torah on Spokar, Chirium, Chirium, Choo Choo Choo. But Tanya.
So you got to explain this thing.
Bethany grads.
Okay.
Chair for Bethany College. Now that we've had that educational, I'll try to put a little more perspective on the Attorney General's Office of Inspector General. As you stated, Madam Chair, my name is Jay Emler. I am the Deputy Attorney General, Chief Information Security Officer for the Office of Derek Schmidt. I also serve as the Administrative Officer for the Office of Inspector General. And that is because I'm not a certified Inspector General, which is what's required. When Sarah resigned and went over to KDHE, a search began, a national search began. First interviews were held during the week of November 22nd. Final interviews are being held this week. The General believes that he will have a candidate ready to present to the legislature very shortly. Again, as we mentioned in the past, the purpose of the Inspector General's office is to solicit and receive fraud, waste, abuse, and illegal acts, comments, complaints, and those, to that end, an email address has been established and is used frequently. The bulk of the complaints come from the Department of Children and Families, and the complaints primarily allege beneficiary eligibility fraud. So the staff currently screens every one of those complaints on a daily basis as they come in, because almost every day there is a complaint that comes in. And if there's further clarification needed, it's sent over to the clearinghouse for additional information. Since the last meeting, which was in September, the office has received 136 complaints. And then you might guess, as the department matures, more and more complaints are being received because people become aware of the ability to talk to the department. As the number of people enrolled in Medicaid increases, certainly under the most recent circumstances, more money is being spent on Medicaid, and that certainly increases the possibility and the probability that we will see some Medicaid fraud. One of the things that I talked about in in September when I was here, was the TA waivers. And those TA waivers are for specialized equipment in the home. Unfortunately, there really hasn't been a tremendous amount of change to that, because as you heard just moments ago, there is a shortage of both RNs and LPNs. And in order for this program to function properly, we have to have LPNs and RNs. And unfortunately, they just aren't out there. So this program still really has some problems, and we really can't present to you anything that's viable until it can be fully staffed. So the other thing that you had asked us to look at, and we told you we would look at, was some of the COVID monitoring that's going on, and realizing this is not real time, because there's a lag between the time the test is done and the information is put into the Medicaid Management Information System. As of December 4th, however, the testing appears to have peaked in July of this year, with 7,420 Medicaid beneficiaries tested. The number of beneficiaries tested decreased in August, and it seemed to plateau in September. It began to trend upward in October, and we anticipate another significant trend upward in November and December. We don't have that information as yet, unfortunately. So the top 3 providers for testing during that time frame were Quest Diagnostics, University of Kansas, and Children's Mercy. I thought that was interesting, but there is a difference in the type of testing, and you'll see 2 types of tests. One's a U0002, one's a U0003. If you move to the U0003, instead of Children's Mercy being one of the top 3 testers, it turns out that Cotton O'Neill top 3. The cost for the tests, as you heard in June, ranged from $35.92 to $920.24. That seems to have come down to sort of an average of $100. And that's on the first type of test that I mentioned. The second type of test, which is the one that Cotton O'Neill takes Children's Mercy's place on, the average cost the average bill, I should say, is $108. The average payment is $82. The next thing that the office looked at was the capitation payments. As you know, we did an audit on capitation payments to people incarcerated, which is against state and federal law. We found that there had been $184,997.43 paid to MCOs inappropriately for incarcerated people. The question then arose, do we have the same issue with decedents receiving, the MCOs receiving payment for decedents? And there's good news and there's bad news. Bad news, and I'm paraphrasing my testimony to move it along here. The bad news is, yep, it happened. And the bottom line is there are 4 MCOs that were reviewed, 3 that are current, 1 whose contract expired in December of 18. We believe the entire universe of these overpayments was 25 individuals. And what we found, long story short, was that once the letters for voter registration went out in September and came back as not deliverable, it triggered a review, and it was found that there were these 25 people who were indeed no longer eligible to receive because they passed away. And as soon as the appropriate steps were taken, and I outlined those in my testimony, the amount identified was $1,313,175.55. The good news is that of that amount, all but $190,975.71 has been recouped from the MCOs. That amount of money, however, went to the Amerigroup MCO, and so consequently, to the best of our knowledge, has not been recouped. We believe, and this is also in the testimony, and I'm trying to paraphrase it here, I'm sure I'm past 3 minutes. The trouble really centered around the KEYS computer system, and the KEYS is Kansas Eligibility Enforcement System. That began in 2011. It was supposed to be operational in 2014. It did not become operational until October 21st, 2018. However, when it became operational, it did interface with vital statistics, so that when a death certificate was filed with vital statistics, it went over to Keys, and KDHE was able to pick it up. Now that there's some processes that they do, but verifying and all that sort of thing. But the bottom line was there'd been no time in between the two before, and the program was significantly late in getting into practice. And so we believe that these 25 people probably fell through the cracks during that time frame that we looked at, February 2015 to September of 2020. And as I said, all of those have been recouped except the ones with the AmeriGroup MCO. So our conclusions were that we believe that, yes, there were improper capitation payments made for as long as 5 years, which if you look at the Keys development, goes pretty much along with that. A review of KDHE's current policies and procedures in comparison to the office's testing results validates that improvements have been made and that there is a significant reduction in the risk of capitation payments being made improperly to deceased persons. We do recommend that KDHE take a look at this report and review and verify the information that we found. But we believe at this time that their policies and procedures are working. The only other issue then remains what to do about AmeriGroup. That is not obviously something we were looking at, but it is something probably the KDHE may want to take a look at. With that, I'm happy to stand for questions.
You know, AmeriGroup's been a thorn in all of our sides for quite a while now. Right now. Anyone have questions for Jay? Anyone on Zoom? All right, seeing none, thank you very much for being here. We appreciate it. Appreciate it. Okay, now we've got our responses from state agencies on unresolved issues. And the first one that I have up, and I believe is coming in via Zoom, is Sarah Fertig.
Thank you, Madam Chair. Sarah Fertig, State Medicaid Director, KDHE. Good morning, committee. I am going to be working off of an Excel spreadsheet that we have labeled in the lower left-hand corner as KDHE responses. So I'll give you a moment to make sure you've got the right spreadsheet. Okay, excellent. The first page of the spreadsheet contained the specific issues that we addressed at the September meeting. So those have all been closed. So the first issue, which requires a response from us, is item number 3, which I believe is on page 3 of the spreadsheet. And this was, we wanted just to provide some follow-up information on this. This was an issue originally brought to the committee's attention by KHA and some providers about some outstanding accounts payable on AmeriGroup's front. We had a meeting with KHA in August of 2020, and based on the information they had at that time, the $14.3 million outstanding accounts payable amount had dwindled to $4.1 million and continues to dwindle. So this is an issue that's kind of slowly going away. And Madam Chair, if you like, I can pause after each one, or if you like, I can keep moving forward.
No, I think we'll go on each one. And this is awful, we were just trying to figure out what sheets that you were operating off of. And
sure.
So not have them in front of us.
Have you found it?
Yes.
Okay.
So were you discussing number 1?
Number 3.
Number 3, okay. I want to make sure I'm caught up there with you.
And I will say, whoever's suggestion it was at the last committee to label these spreadsheets for which agency they're coming from, that was brilliant. So hopefully that's helping everybody follow along a little easier.
Yeah, the problem is that we've got another one that's got KDHE responses, so we may have to start putting the presenter's name on that. So thank you. Okay, committee, are there questions on number 3? Representative Bowden.
Just want to make sure this one familiar still oath providers. That's what we are. Yes. All right. Thank you.
Any further questions? You may proceed, Sarah.
Okay, thank you. The next one for KDHE's response is item number 9, which is a few pages over. It is on page 9 of my spreadsheet. And this was requesting an update on the status of the supported employment pilot. And we're going to talk about this more this afternoon on our agency update, but just for a brief update on this particular spreadsheet, we've hired a contractor to start working on building an implementation plan for this pilot and help speed up our implementation. And the contractor began work in early November. And I'm happy to answer any questions now on this, Madam Chair. Otherwise, I'd be happy to go into it in more depth this afternoon.
I think we're just going into it this afternoon, so.
Okay. All right, so the next one for KDHE's response is on that same page. It's item number 10. And this relates to community service coordination to assist KanCare beneficiaries. And our December update is basically that the project is still on hold. We don't really have any updates at this time.
All right.
Okay, the next response, item requiring a response from KDHE is item number 17, which is on page 13 of my spreadsheet. And this item concerns the protected income limit. Again, this is an item that we're going to go into more depth in this afternoon on our agency update. But just so the committee is aware, yesterday we submitted the regulation to the Secretary of State's office for publication. It's scheduled for publication on December 17th. And the effective date of the regulation is going to be January 1st, 2021. So that is all but completed.
On that one, it looks like we probably need to put some legislation out there, or you guys are going to handle the continued protected income.
Are you referencing the protected income limit?
Yes. It's a one.
Well, I mean, once the regulation is published, and 15 days after publication, it's going to have the same force and effect as a statute.
Okay, all right, that's what the process was. Did you have
Thank you, Madam Chair. I still plan on introducing a bill to codify that.
Yeah, because I think what the discussions had been, Sarah, now that I had my brain go back a little bit, was that we felt more comfortable with it being legislation versus rules and regs, but it's good to have it out.
Absolutely. I understand that, because theoretically a regulation could be changed by the state agency. So I understand that.
All right, thank you. Go ahead.
So the next item for KDHE's response is item number 18, which is the next page over. And this particular comment came from a couple conferees, basically expressing concern about the difficulty in maintaining personal care workers in the workforce. And there was a comment that Medicaid expansion would assist in that. Obviously, that would require legislative action. And so we don't really have any update on this particular one.
Okay. Are there questions, committee? Go ahead.
Okay, so there are a lot of KDADS items following this. So the next one for KDHE is not until item number 33, which is on page 24 of my spreadsheet. And this particular item concerned a comment by Mike Burgess on the need for benefit specialists for beneficiaries. And I'm pleased to report that we are in the process of filling 2 new extra benefit specialist positions. So we hope to have those positions filled in the coming weeks.
Questions, comments? Seeing none, proceed.
All right, thank you. So the next for KDHE is item number 45, which is on page 29 of my spreadsheet. And this is a comment from a couple of the advocates concerning COVID-19 data and how it's reported for congregate living facilities. And for the committee's information, as of late September, KDHE has been reporting the names of congregate settings with 5 or more Kansas resident COVID-19 cases with symptom onset dates in the last 14 days. So it's kind of a rolling update of where current outbreaks are. And that report is updated regularly and it's available on KDHE's coronavirus website.
Sarah, have you got, has the agency been, you know, because I know that they said this was done as a, they felt it was critical information and important for the public to have this. What benefits have you shown, has been shown in doing this process?
You mean in terms of reporting the outbreaks?
Yes.
Well, honestly, Madam Chair, I'm not sure. That's not something that Medicaid monitors. I would probably defer to Dr. Norman and our Public Health Division on that, since they were the ones who were responsible for making this change so that Kansans could have more recent updates on where active outbreaks are. So perhaps this afternoon as part of our agency update, that might be something that Dr. Norman could share some information on.
Okay, you might let him know that that question's been asked.
Okay.
Can you?
Will do. Okay, the next item for KDHE's response, these were the new items that came about in the September meeting, and that's item number 50. That is on page 31 of my spreadsheet. And this was a comment from Oral Health Kansas expressing concern that one of the dental codes was not included in a dental rate increase that went into effect recently. And KDHE's response to that was basically that we were given a $3 million appropriation and the decision was made at that time to try and impact the greatest number of Medicaid beneficiaries, because we all know there's been some strain on the dental provider network for Medicaid beneficiaries. So they decided to affect the greatest number of codes that would affect the greatest number of Medicaid beneficiaries. And that particular code didn't make the cut. We only had so much money to go around, and we would support an increase of that rate if we had some appropriations to allow for it.
Any questions? Representative Carpenter.
Thank you, Madam Chair. We're back on page 29. We have it's number 42. Is that more? Is that you haven't discussed that? Is that because that's stated as the top page there? Is it labeled improperly, and are we going to discuss that at some point in time? It's the law exempting nursing homes from liability that we passed in 2016. Mm-hmm. So is that mislabeled? Is KDA's going to discuss that, or?
I'm not sure if they will, Representative Carpenter. I think, well, I'm not sure that either agency could really speak to that, because those facilities were expressly excluded from the liability protections and House Bill 2016 during the special session. So neither agency can really do anything to build those protections back in. That would require legislative action.
And that's what I thought. Mm-hmm. We're going to have legislation to correct that.
Well, I believe, Representative, on the KanCare meeting that is scheduled for next Tuesday, there will be room for discussion of that. I believe in the afternoon session. Isn't that what I have set up on? You're welcome. Proceed.
Thank you. The next item for us is item number 51, which is on page 31 of my spreadsheet. And this was a request from the Association of CMHCs that we cover code number 90846. Our response for December is that we're having some internal discussions to see if we can cover that code. Kyle Kessler, I've had a number of discussions with him about it, so he's well aware of our process and what our concerns are. And the long and the short of it is that we've received two very, very different bits of advice from CMS on this. And we're trying to figure out if this is something that we could cover and be in compliance with CMS's requirements. And the first step to figuring that out is nailing down what CMS's requirements would be. They have told Kansas something very different than they have told other states. So we are trying to figure out what the rules actually are. And so we're treading lightly on that. We don't want to start covering it until we know whether or not we could comply with the kind of program integrity aspects that CMS might require of us. But we are in ongoing communication with the association on this issue.
Any questions? I would just, make sure, Sarah, that we stay on top of this and try to figure out, that concerns me if they've given other states one definition and now we're hearing a different one. That's kind of a big deal. And I think it's important for us to do everything that we can to address in this situation. Because I know, just in my community, in the city of Wichita, we've got a 70% uptick on suicides. It's not a number I'm proud of.
I would concur, Madam Chair, and we are going to keep an eye on this, and I can promise you that Kyle Kessler would not let us put it on the back burner even if we wanted to. So it is something that we're actively discussing, and I hope maybe by February we might have some more information for you.
This tenacity that matches mine, I kind of like that.
I think so, I do. Okay. So then on the last page of our spreadsheet, items 52 and 53, starting with number 52. And this also related to the reporting of COVID-19 clusters. The DRC suggested that we might be able to release more specific data. I would refer back to the earlier response that KDHE is now reporting clusters and congregate settings within the last 14 days. And I would suggest if the committee has more specific questions about why we report things the way we do, that might be reserved for Dr. Norman this afternoon.
And I think, Sarah, that's something that members want to try to understand a little bit better, because we'll know that there's, okay, I'm using hypotheticals. There's 10 clusters out here, but you want to report 5 of them publicly. Why does that occur? So I appreciate that comment. Further questions? Representative Ballard.
Dr. Number 53 on 32. We'll have that opportunity to cover that.
Is that no? Yes.
No, it's never technology. What I'm talking about, because this is extremely important.
Well, it says for KDHE response.
Well, see, that's what it is. I was thinking it was KDAS, but I saw KDHE, so I just wanted to know what we'll do with this. For those of you who may not know what I'm talking about, if Kansas seniors, both in facilities and aging at home, need internet access and technology devices to connect with loved ones and doctors, healthcare providers. And that's an important issue because we've heard people talk about they haven't been in their homes in 6 months, or they haven't seen their families, no one's come to visit and everything else. And that is an important issue. And I bring that up because we've discussed that a little bit in mental health, that have some kind of access. I just want to make sure they're going to cover it.
Jan is nodding her head now. Yes, that will be part of what she covers.
All right, thank you, Madam Chair.
It just, that's sometimes hard. I think, not only for legislators, but those that are trying to follow this process is the things that touch KDAS and the things that touch KDHE, and then at some point they may be together on the same. It gets a little bit confusing, and even for the legislators.
Thank you, Madam Chair. Just want to
Further questions or comments for Sarah? Looks like you did a great job and answered all of our questions for us, Sarah. So we appreciate you being with us.
That's what we endeavor to do, Madam Chair. Thank you.
All right, thank you very much. Next, we have Janice DeBoer, Deputy Secretary of KDADS. Welcome to the committee.
Thank you, Madam Chair, members of the committee. I would suggest maybe we start with that very last item because I'll be happy to address it. This is our handout. It has KDADS and red at the top, so you've got it. Did I not put that on? I don't know. But I will start on page 1, issue 1, but we skip then all the way over to page 5. For our first item, which is managed care system does not fit the IDD population's needs. And Madam Chair, members of the committees, the next couple of these comments are very directly linked to targeted case management. We did continue our work group. Amy Penrod and her team met with the group on October 13th and the 14th for via Teams. And we are very focused at this point in time on targeted case management and how we can work with Roxanne and others on their concerns regarding conflict of interest when it comes to care coordinators and targeted case management. So we are very pleased to report that effort is underway. And that's our same response on the continued item number 5, continuing at the bottom of page 5. And I think it's mentioned again here later. On the bottom of page 6, the same answer.
So your discussions are with the providers, stakeholders, and the MCOs, correct?
You know, I'm not sure Amy has included the MCOs yet, but we will be. That is the plan. Right now, she's talking to stakeholders, and then we'll bring in the MCOs. And honestly, I've asked her to also bring in the area agencies on aging to talk about administrative case management. So make this conversation even bigger.
So would we have information back on that by January?
As far as who makes up the team, the group?
Yeah. Well, I guess, you know, looking at this, Janice, this has been an ongoing issue. And I appreciate the resolutions and this, because this helps keeps us on target, is August 19th, February 20, June 20, September 20, and now December 20.
Yeah, I mean, this has been a concern with KanCare's implementation in 2013. So, I mean, it has just been an issue that we've heard for years, that we have some stakeholders who believe that with managed care, we've got conflicts. And so we will bring stakeholders to the table, the NCOs, and we'll talk it through and see how we can make this work better for all, including those entities that provide targeted case management.
So we ever get to reach a resolution?
We hope so. We hope so.
I'd like to see that.
Okay.
I'm assuming I'm back. I don't.
You assume what? Oh, yeah. Well, we'll assume so too. So we will bring to you more discussion about this item in January, to say the least. How that works. So we then move to page 10, issue number 11. And again, this particular discussion item is linked to dual diagnosis individuals, very specific to those who transition from the SED waiver to the IDD waiver. And you ask us on this particular item to address how this item can be closed. From our vantage point, we will work with this particular stakeholder. We will work with Roxanne, but at the moment we do not support this policy change. So from our vantage point, this is closed. We do not support the policy change that would allow us SED waiver consumers to directly move to the IDD waiver. At this time, that is not in our plan.
That's under number 6.
On page 10, number 11.
Oh, I'm sorry.
So from our vantage point, we would request that this be closed.
Comments, questions from the committee? Representing Ballard and representing KanCare.
Thank you. I'm looking at this. So you indicate, thank you, Madam Chair, that you do not support it, but when I'm looking at it, so a dual diagnosed who are dropped from the SED waiver and are years away from getting ID service. Once a child leaves the SED waiver, he or she should transition to the IDD waiver automatically with services to be included. All right, so then that would possibly put them in this long list of the long waiting list. Why are you, I guess I'm not sure we want to close this. Would you please give me some reasons why?
Just the Congress representing Ballard of what you just said. Instead, this proposal would put those SED kids to the top of the IDD waiver, which means if you're on the waiting list, you get bumped down even further and further. So the 4,000 individuals waiting for services would be pushed down while the SED child was moved to the waiver itself, to the top of the line. So from our vantage point, we've got 4,000 other individuals waiting. So just because a child is on the SED waiver wouldn't necessarily mean they would transition to services while other people are waiting. Now we do that for the TA and the autism because of the extreme conditions of those particular individuals on the TA waiver and the autism waivers, because they are high risk, as you've heard over and over and over. But for the SED waiver, we do not feel that it would be the best policy to transition SED kids directly onto the waiver without them and pushing other people down the line.
I think the concern, I know the concern I have. That concern is we're talking about a child. We're not talking about bumping an adult and putting an adult, we're talking about a child. And we know that depending on what the disability might be, the child is more vulnerable at those early ages in order to do it. So in this case, if we do this, they would have to wait maybe 7 or 8 years or longer before they could receive services, or would it be even longer than that?
Right, and it'd be the waiting list. I have we can bring a fiscal note, to this particular option in January. We can certainly do that if you're interested in the SED waiver being modified to allow automatic transfer. It would not be our recommendation, but we can continue to have conversations.
I think, just because of the concerns that she raised, and we haven't gotten to Representative KanCare yet on her questions, is that we keep it open, and perhaps between now and then, Representative Ballard could visit and give her, more details to see what information she needs to make her comfortable to close the issue. Does that make sense?
Sure.
Representative KanCare.
Thank you, Madam Chair. That answered most of my question as well. I'm trying to recall what Roxanne's specific issue was. I mean, I understand they're losing these benefits and she's wanting them to transition over. But I'm trying to imagine what the situation was and how that would impact a specific case. So yeah, I support just keeping it open for a little while. We'll visit outside.
And we will bring some stakeholders to the table also and get back with you.
Yeah, we're not saying that you're necessarily wrong, but they just got questions that, and then maybe we can resolve this up in January. Representative Carpenter.
Thank you, Madam Chair. Just remind me how many people are on this serious emotional disturbance waiver right now?
3,000-ish, I'm thinking.
Yeah. Okay.
Thank you, Janice.
So then we move to numbers 12 13 that are very specific from Nick Wood about dual diagnosis IBD individuals who may find themselves, and not number 12 specifically, but 13, and there's another one down here also that talks about the law enforcement issues. Representative Langer, I am pleased to report we did have the opportunity to meet with Matt Fletcher and Nick on November 16th, and Secretary Howard did join us, and we did have a conversation about how do we address the dual diagnosis. Again, this issue, Representative Lambert, you know as well as I do, has been going on for years and years. Last year in the Senate, there was a Senate Bill 33 with some proposals in place. We do believe we can have some conversations with Matt and law enforcement again and determine if there is an opportunity for in Kansas for us to find gaps in our delivery system. We know they're there, but then how do we fill those gaps? Last year, you heard Matt and I both talk about a model called the sequential intercept model, which is being used around the nation to help states better understand what their gaps are, particularly with law enforcement becomes involved with individuals with dual diagnosis. We would still like to tap into that model. With COVID, we got distracted. There's no question about it. But we are having the conversation again. And I still think that we'd like to bring in an expert to help us talk through the sequential intercept model and where are the gaps so we know better how to fill those gaps with services. We still hope to get that done. It just hasn't happened yet. And to be honest with you, the facilitators are expensive. So we're looking for ways that we can find some funding and Mark's helping us with that. So we're putting our heads together and trying to figure out how best do we address this issue. It's just, it's gone on for a very long time, too long. So we agree with Nick, we agree with Matt. The secretary has been involved with this her entire career. I mean, we are interested in finding a service delivery system that can fill in some of these gaps for dual IDs.
And I'm glad to hear you say this. And yes, it has gone on for a long time. And I don't know that we ever get to a solid resolution, but I think that we can at least get further down the path than what we've had because the discussions aren't resolving the issue. Is it tough? It's absolutely tough. Every time we deal with a dual diagnosis on anything. And I do know that with the folks within your staff, including yourself and the secretary, the experience is there now, probably more than we've ever seen it in our two agencies there. So I hope that it comes to a resolution, or at least the start of a resolution.
We appreciate that.
And stop the discussions.
We agree. And we have some good ideas, but we won't share those yet. I mean, we have, what I should say is we have some good visions. I mean, we know where we'd like to go. We know where we'd like to get to. We're not quite there, to say the least. And we need some help. We need some help.
One thing that might help, Janice, would be if you guys started laying out some of your ideas. I can tell you that now it's been a much more intensive process that I'm asking you to go through, but what the mental health task force has gone, modernization, I call it task force. I mean, it's just amazing when you just start laying that out and then you get the people involved and talking about it and how you can tweak this and you can tweak that. It doesn't mean that you can bite off the whole, eat the whole apple, but you can definitely start nibbling at it and then prioritize, okay, this up here, oh, we can do that because it doesn't cost us money. It's a change in a rule or it's a change in a law, those types of things. And maybe instead of trying to eat the whole apple, what are issues within it that we can handle now? That might be a little better approach because that's helped us a lot on the mental health stuff because another complicated issue.
To say the least. And we appreciate that. And we do think Representative Landwehr that the sequential intercept model would help guide us. And I think actually we would appreciate the opportunity to see what that could look like when we have some chance to get some help with some facilitation, because we do want to do this right. It does impact individuals who end up in our state hospitals, and it impacts individuals who reside in the community. I mean, it just does. So we've got to address both issues, our state hospitals and our community-based providers and find ways to have a better delivery system than we do now for these individuals. It's not a lot of individuals. We're talking 150 to 300 individuals, but we need to fill in the gaps. We've got to find a better way. So,
well, you may reach out to KHI and see what they may have available on a smaller scale of what you're looking at for facilitating. That could also be helpful. I don't know how their staff are geared for that, but I can tell you on this, like what they've done with the mental health, man. I'm getting excited for the next few days to see what we do.
Okay.
And then you can give us an update in the next KanCare Oversight if you've been able to make advancements and taking bites instead of eating a whole lot.
Okay. I appreciate that very much. We're going to move to page 19. Item 25 was Sean. I just wanted to report that I think I mentioned this last time, but I wasn't sure, so I'll mention again. Mark Conant and Sean did agree to shift the meetings with the CAN network to Thursdays, which has helped us out immensely. We had a conflict every Sunday morning, so they did shift that, and we appreciate that. So Amy and Scott, Bruno, and I, several others of our team do meet with CAN every month. I do think that has been helpful. Then Leslie talked about on number 26, the final settings rule. Amy's actually going to provide an update during our presentation this afternoon, and I will share with you all that if you have an opportunity during the session, whatever it may look like, if you're looking for items that you'd like more information about, the final settings rule I think would interest you as far as what's going on in Kansas with the final settings rule. We are making some good progress in coming into compliance with that rule. So Amy and her team have done a lot of good work. The networks have been very cooperative working with us. I think we're finally off the ground on this issue. So certainly we'd be willing to share more with you about our progress on the final settings rule.
This might be something for staff, and I haven't, visited with Representative Carpenter, but maybe something we could do schedule on the same day and make HHS and then come to social services budget and provide us the details up on that. So staff will just need to make note to remind Mr. Long here that I made that request. Thank you.
And then on page 20, item number 28, the PEAK program from Haley's perspective. The PEAK program, I'll be honest with you, has been around for a very long time. You have, Representative Ballard and Representative Langware, you're familiar with this. We implemented it years and years and years ago. It did serve a purpose at the time. What we've done at KDADS in the last few months is we are going to shift responsibility for the PEAK process itself. We are going to shift that back to my team to program. It's been in Scott's shop for a while with survey and serve. We're going to go ahead and take that back in our program side at KDADS and dive into PEAK just to make sure that it does continue to serve a purpose. Unequivocally, the purpose has changed from years and years. If you all remember Bill Thomas, you remember all those years ago when we were all about culture change, and I'm talking 15 years ago. And I think Bill McDaniel helped us bring in PEAK, but it has changed over the years and it has matured, if you will, but we just need to make sure now that it serves the purpose that we need it to serve today. I think it does. We just need to make sure that it works well for facilities and incentivizing them to continue to make movement with culture change, if you will. I'm not even real sure that's the right vernacular at this point in time because so many facilities have already made the change. We just need to make sure that we're incentivizing the right thing. And we'll move that to program and give it some more attention.
Well, it's real easy to put a program out there and not keep it modernized. And so I think that's probably where we're at. Representative Ballard.
Thank you, Madam Chair. Was going in the direction I did. What I have heard is that PEAK serves a purpose, but the agency has not given it priority because there's been so many other things being introduced in between, and it's a program that's been around for a while, and it's been sort of taking care of itself because of that. But as new people come in, they're not had the benefit of how it developed and how it is, and it hasn't been like their priority because there have been other things that have come before that, so that peak is like coasting on what other people have done and what historical kind of things have occurred. So I think what you say here is looking at it in terms of what the goals are, what their strengths are, what has really been effective and had impact becomes an important issue because there's been so many things put on new people's plate that they don't get the whole purpose of why we started peak.
And Representative Ballard, if I may go one step further, at the last meeting, someone asked, and I'm not sure if it was Representative KanCare, asked the secretaries, what do you need? And Secretary Howard said, we need more staff in our program area. And I will be honest with you, I concur. So the nursing facility program within KDAS is probably one area that is lacking in resources. To be honest with you, we are going to attempt to bring in a new commission over long-term care, which will bring in a commissioner over nursing facility program, over the nursing facility program. Again, believe it or not, we do not have a commissioner over the nursing facility program. And the agency hasn't since 2013 or so. So it is a huge hole. We recognize it. Secretary Howard and I recognized it right when we walked in, to be honest with you. We did shift some commissions around and stood up at the State Hospital Commission. And our next step was going to be a nursing facility commission again, but we simply got sidetracked with COVID and simply haven't been able to pull it off, to be honest with you. But that is our purpose. That is our intent. We have got to get the nursing facility program elevated again. We still have survey and cert, and Scott's over survey and cert, and I'm over program for the nursing facility, but I don't have a commissioner. I don't have a director. I have a director, but I don't have a commissioner. We don't have enough staff. Peak needs to move back to the program side of KDAS, and it needs to happen so we can give it more attention again. To be honest with you, I agree with you, Representative Ballard. It needs more attention again, and we'll do our best to do that. So,
well, long-term care is kind of a big deal when the baby boomers started turning 65 in 2011.
Well, the first one will turn 85 in 2031, so that's just a few years away. The first one will turn 80 in a few years. So yes, I mean, yes, we have got to pay attention again to the nursing facility program in its entire being, if you will, not just survey and serve. We have got to bring the program side back into KDAS and strengthen it.
You know, one of the things, Janice, and I know that I think the federal government kind of dropped the ball when they did the long-term care partnership through insurance, and then Commissioner Prager was very involved in that. But we spend so much time looking at what we can do from a Medicaid perspective when we are not out there also educating individuals on how they can do some of their own planning and their own personal responsibility so that they weren't so dependent. Because if we could get, I think, these nursing homes to where they had more private pay patients, could really help them financially, to help them be able to pay more. Because I'm sorry, I don't care who owns the nursing home, even good friends. We just keep that quiet. Yep. Yes. I mean, it's a hard business. It's a very hard business. And the turnover and on staff and everything else is really, really rough. But we've got to get more out there on the education side, and that, you know, planning for our futures, and that, long-term care insurance isn't a bad product to have. I can't tell you, I know I took care of my mother the last 10 years of her life, and it was tough, emotionally, physically, and financially. And on the other side of that, my mother-in-law, who had a policy, it was easy to say, where do you want to go? And we were able to make the assisted living transition. And then when she had her stroke, then it was the nursing home. But we could say, where do you want to go?
Right, and Representative Landwehr, if I may, what Kansas has done well is build a continuum. We just have lost some of our footing with building that continuum. We do have options and choices, and that doesn't mean you start on this end of the continuum and move all the way there. But with the elderly population, that is a pattern. You do see that. That's not to say everyone's going to end up in a facility, but if we can get them meals, if we can get assistance initially in the home, and then assisted living transitions and then nursing facility, we've lost some of that momentum and even our conversations inside the agency because we just need long-term care to be all they do then.
We've got to bring that personal responsibility. I can tell you right now, in the long-term care insurance industry, the majority of what they're paying for is in-home services.
Yeah, exactly.
So that is saving a whole lot on a system out there that we don't have shored up where it needs to be.
And that's the best news of the day right there, is that we can have that option in the community. We just got to make sure.
Right. And there's just so much more out there. I don't have any idea. I'm not in that business anymore. It's just, but I know that there's just so many more products out there, and it makes it more affordable. And sometimes you have to do like my husband and I did. The first policy that we bought when I turned 40, and then we bought what we could afford. And then later on, we bought another one. So now it covers the gamut that we need. So there's paths to do that. But it takes an education and, for people to go through. Janice, on number 27, on the receivership stuff.
Oh, okay.
Have we had any new homes go into receivership? Are we sitting on the verge of any homes possibly going into receivership? I'm hearing rumors.
At this point, we have not. We have not had any facilities move into receivership. Scott and Lacey will talk this afternoon. I think they'll include in their presentation this afternoon some conversations that we've had with CMS. We have a facility here or there. We have temporary management in the building. So, but that's not receivership. Right. So, I mean, we're working with CMS to find every single possibility for remedies that don't involve receivership, if you will. So
well, I think some of this is coming about because of some of the COVID stuff, et cetera. Yeah. So next Tuesday at that meeting, we can really dive into details.
Yeah, Scott will be presenting there. So yeah. And I will share with you this afternoon, Representative Len, we are down to one facility. If all goes well, the end of this month, we will close on another facility that's in receivership. Will leave us one out of 22.
Representative Carpenter.
Sure. Correct me if I'm wrong, Janice, but that doesn't come out of your budget. That's out of the fund that's set up.
You're correct.
Okay. So it's kind of a misguided question, but that money comes out of the fines and penalties and that kind of stuff. So it's not out of KDAD's budget per se. Thank you.
And Representative Carpenter, it served us well, obviously, over the last 2 years, to say the least. And we're pretty frugal, so we're making sure we get as much money back into that fund as we possibly can. So let me keep going here. On number 29, this is the same conversation as what I had earlier on November 16th meeting with Matt Fletcher and Nick. We do want to continue to talk dual diagnosis. We do agree completely with this conquering that dual diagnosis is a tough conversation. It's a tough delivery system, and we need some improvement there. It's just really cold in here. Ooh, it is cold in here.
Okay, Eileen, you may adjust the thermostat. Carefully. Carefully. And I did not touch it when I walked into it.
I take bribes and kickbacks and everything.
On page 23, number 32, and I don't know if Sarah is still listening or not with KDH&E, but this is the increase in the TA nursing reimbursement rate. We thank the legislature for the increase and came the allotments. So We would ask KBHE and Sarah to help us out on this one because the assertion made by the conferees is that the hospital budget could come into play, which is not our budget. So we have had extensive conversations with Sarah and other folks at KBHE on this particular issue. I think they're going to talk about it this afternoon, representing Landwehr and members of the committee, I believe. For us, the issue is you tell us what you want the rate to be and we'll change the rate. Just that simple. So. Okay. Moving on to number 39, page 26. Okay, this is the retainer payments. We began the conversation about retainer payments months and months ago, probably in March and April. Representative Landwehr, you were very engaged in this conversation as far as retainer payments. And again, I'll make the clear distinction that retainer payments through the Appendix K option for HCBS waivers was a tool that we chose to use. What we have found in December that we didn't have as many providers qualify, if you will, for the retainer payments as we anticipated. We will only have dozens who will actually benefit from the Appendix K option. What we have found instead is the CARES Act relief payments will prove to be more beneficial to these particular providers, including IDD providers. So retainer payments, we work with the MCOs very closely. It took us months and months and months and months to jump all the hurdles with the MCOs and CMS, and we have found that the retainer payments in and of themselves were probably not our best strategy, representing Landwehr. And I'll tell you why, they didn't work well with a marathon emergency. They do work well with a flood or a tornado, where you need to move fast and you need to fill in the gaps for these providers who lost their payments temporarily. But months of this pandemic have not served us well, and it's because Congress provided other tools and other funding mechanisms to provide the relief. So we are not going to find that we will probably ever use retainer payments again in a pandemic. Instead, we'll rely heavily on Congress and other opportunities to bail us out, to help us out, and it probably will not be retainer payments representing Landwehr. So just a heads up, we will have helped a few, we will not have helped a lot. So
mark that on the calendar.
Doesn't happen very often. Just an FYI, we will be truly transparent, and indeed we have learned a lot from this experience in Appendix K. Retainer payments is not our best tool.
Well, and I think you're going through this whole process with this, Janice. It's you know, someone described it to me the other day, I think in a perfect manner. We are trying to repair a plane while we're flying. And our normal procedures may or may not be the proper tool to proceed forward. And so the thinking outside the box and the going outside is bigger than we've ever had to do. And I think that there is, as bad as this pandemic is, a lot of positives because we've had to push that envelope are going to come out of this. I think, you know, just seeing the service and care and with telemedicine, you know, et cetera, that happens to be one of them that's out there. It probably wouldn't advance to the level it's going to advance in this section.
And what Amy would say, and I would probably say if she was standing here, she would say, I think, if we could have accelerated and got the retainer payments available up sooner, quicker, they would have been more beneficial. But it took us long enough to figure it all out, to be honest with you. By the time we figured it all out, PPP had already been available through Congress. We already had CARES money going. The retainer payment itself wasn't as valuable when it took us so long to get it implemented. So I don't want to say that retainer payments for Appendix K aren't a good tool It's just maybe if a flood and a tornado, we'll pull it right up and say, let's do this, but it didn't necessarily prove to be the best tool during the pandemic. So
that's why you have all that experience.
Yeah.
This is Senator Petty. I have a question.
Senator Petty, go ahead.
So concerning the retainer payments, would one of the issues also be, and you can clarify for me, increased paperwork since they've already had so much paperwork involved anyway, and then that just adds another layer?
Yes, Senator, you are correct. And not only increased, but complicated paperwork. So they actually had to prove that the revenue that they lost hadn't been filled through another funding mechanism. So, I mean, very complicated proof, if you will, that they still needed a retainer payment to fill in the gaps of the revenue loss. Very complicated, to say the least. So,
anyone with further questions or comments on it? All right.
On number 40, if you don't mind, Representative Lambert, to answer this, I'm going to shift to this document. That is a spreadsheet that is attached to some questions that we answered in writing. So this is a 20-page document. Hopefully you all have it. You all have this spreadsheet, I hope, that we included with our written response. Is that going to be this one? It's a 20-page. It's attached. It's literally attached to some questions and answers.
Okay. If you look, you have a completely different folder that says September responses. And at the very bottom of that, you will see all of this put together, and then this long sheet. Is that where you're at?
Yeah. This 20-page long spreadsheet. You have one. Hopefully everyone has it on Zoom also. You all are our first audience for this, so bear with us as we present this. And I've already noticed a couple things will be different before the session. This spreadsheet is our response to number 40. So Linda Mowbray is talking about the financial resources during COVID, and this Representative Landwehr, we just simply attach this 20-page document. Within the agency, we are calling this our super tracker. So this is a 20-page document we sorted by county with the list of all the adult care homes, not just nursing facilities, but we brought in state licensed only. So we brought in the names of all the facilities who are adult care homes in our state, and we pulled in, we didn't do it, Georgiana Corral did it in our office. We pulled in all these different data sets to provide you with the facilities of who's received what. So we'll do a few things different come January because we need to have column numbers, but there are 13 columns across these 20 pages. And I'm going to quickly walk through 4 through 13 to answer number 20, item 40. So Representative Ballard, earlier you asked about communication devices. This column 4 is the communication devices that state licensed only facilities ask us for money for. So we stood up a process that allowed assisted living, for example, to ask for money. And this was the CARES Spark, what we call round 0. So this wasn't the county money. This wasn't round 2 or round 3. This is those early days of COVID money being available. We had communication devices. So this is the money that was given to facilities for tablets and laptops so they could connect with their loved ones. So these are the names of the facilities who took us up on that offer and then how much we spent.
Janice, is that the one with the 149?
Correct.
Okay.
Right. So $149,000 we gave to state licensed only facilities who applied for the money. So they actually had to make application, and then these are the facilities that took us up on the offer. So if you'll follow me through column 5, same thing, but these are nursing facilities. So this shows you the nursing facilities in your counties that actually ask us for money, and we provided it to them. And it was a very simple process, if you will, as simple as we can possibly be. These dollars, but you know, they can say to us, we want 12 laptops. The maximum is $3,000 per facility, unless there was an exception. But nursing facilities across the state did apply, and we did provide them with the money. We want to help Linda Monger and her team, and we also want to thank Deborah Zaire at Leading Age. They helped us literally get the payments out faster than we could have done at the state level, to be honest with you. So we stood up a couple of contracts really quickly and ran the money through them, which we very much appreciated their help. So then if you go to the next column, these are the communication devices that we will use the CMP fund as needed. At the moment, we haven't yet spent all of our column 4 and 5 money, so we haven't had to tap into the CMP quite yet for devices, but we think we will. We think we will before this is all over. The next column is column 7. This is, go ahead.
On each one of these is like, okay, you talked about the comm devices, is a pot of money you haven't tapped into. Did each of these others have a limited amount of money total?
You know,
that you could spend?
I think we did. Okay. CMS actually imposed the $3,000 cap and we liked it. So we imposed the $3,000 cap even on the CARES monies. Yes.
Yeah, and I don't mean on the individual. I'm talking about the total amount that you had available. Was it $3 million? And out of that $3 million, here's what you can do, and you capped in that $3 million and $3,000.
Right. It was $600,000.
On
the first 2 columns were $600,000 each total.
So 300 and 3 million.
Yeah, we've almost reached it. We've almost reached the 600,000. As soon as we reach the 600,000, we will then roll over into column 6 for nursing facilities. Here's the caveat. Assisted living and state license only facilities cannot tap into the CMP money. That's only nursing facilities. So we have just been reaching out to assisted living facilities and state license, and honestly, Linda Mowbray and her team have been reaching out for us. They've literally made phone calls to facilities and said, hey, apply at KDAT, where they've stood up this process, ask for some relief here. So they literally have made phone calls for us. When they did that, we saw a take-up rate overnight. So we really have worked hard with these associations. They've been great partners to let folks know this is available.
So what are you going to have available in column 6?
Column 6 is going to be CMP money. We've got 3 to 4 million in CMP. Obviously, we don't want to use all that for communication devices. We need to keep it for potential receiverships.
You have 3 or you have 4?
You want to know exactly how much? I don't.
You don't have it right now. You can do that.
Okay, Brad will help us with that to tell us how much. Now, we won't use all that CMP money for communication devices, obviously. We've got to keep it for receiverships. But, you know, we are going to keep the application process open, even past, you know, even when we run out of the 600,000, we'll have this money available through CMP for facility. Does that answer your question, Representative Ballard?
Representative Ballard.
Thank you, Madam Chair. Yes, it does. But I do have another question. All right, so actually Linda Mowbray and her group actually assumed responsibility for this.
Well, we had all the responsibility. We signed a contract with them to literally help us make the payments. We received the applications, we reviewed all the requests, we gave the approvals, and then we would give the green light to Linda Mowbray's team. Yes, go ahead.
That's what I was doing.
We received all the applications, all the invoices, we approved, and then we said,
we have a record of all of these facilities that took you up on the offer. How many of the devices did you actually buy? We verified that it was actually spent on this, on the machines and things along those lines. And also, since they're supposed to be used for the residents, is there any area that says they were trained on it, on how to use it, or is there anyone to assist them? So it's okay to have the laptops and to have all these other things there, but how can these individuals access it to actually be able to use it? And is that enough to circulate among the residents depending on how many they actually offer.
So a couple of answers there. Brad, when he is listening, so he will be able to give us the exact number that columns 4 and 5 that they actually bought through the process as far as communication devices. Yes. And what we did, Representative Ballard, is we reimbursed. So they literally had to send an application, we approved it. Then they had to buy the product, and then we approved it, and then we reimbursed. So they literally had to present us with invoices of buying these products before we would allow KHCA to send out a check. So yes, now as far as training, we didn't have the resources or the energy or the expertise to train facilities how to use a laptop. I mean, we just hope that they have the savvy to Zoom or to use Teams or whatever they use in their facility. We did not train facilities on how to connect people with laptop.
I'll just follow up on this. Obviously, I'm getting information from various sources, so I'm just trying to clarify. So in this case, when you got this equipment, was it actually being used by the consumer there, or the staff having access to it that it never had access to this kind of material before?
I mean, I think what she's looking for is it being used for staff or is it being used for the clients?
The laptops and the tablets should be used for clients, for residents, and that's CMS's expectation, that's our expectation, yes. As far as enforcement, I don't know for sure how we would enforce the fact that staff can't use this. It's got to be used for residents other than the survey process. And I don't know if that's going to become an addition to our survey process, is that we really have evidence that these tablets were used for connecting, reconnecting.
We'll do that one follow up on this particular one. But when the agency or the nursing home had to buy these facilities, was there anything in the contract itself to say that this purchased equipment is to be used for consumers in this facility or anything along those lines, so that we know that they had to sign it, whether they're doing it or not? Did they verify that this is what this was being paid for and you were reimbursing them for that purpose?
The CMP or the CMS guidance was clear to nursing facilities. It was clear. You can use CMP funds for this purpose, and the purpose is this. So yes, the facilities were fully aware that the purpose of applying for these dollars is to reconnect residents to their loved ones. Yes.
I will follow up another one.
They should have been doing it. So.
Okay, what I might suggest, Janice, I like this report here, is when you're coming in back in number, if you could list above these totals, because I take it that if I look at that 149,000 figure, that's what you have spent.
Right.
Okay. So if we could have above that what is allocated in that,
okay,
would be good. But this is a good sheet to have.
I can help us do that. And if you don't mind, I move on because there's even more good stuff to come.
Okay,
so on column number 7, the 33 million. So that is the 38.4 million that the Spark Committee recommended we provide to nursing facilities clear back in June. We did that. We got it done. We had a take-up rate of about 87%. So Representative Lambert will do that. We will add an additional note. The 38.4 was what we received. 33.7 is what we sent out. And Representative Ballard, in response to your question earlier, on this 33.7 million that we sent, these are called direct payments. We literally sent 308 payments to nursing facilities, thanks to Chris Swartz and her team in H&E. They had to sign an attestation form before we sent the payment that they understood the purpose of this money and it was all CARES Act related. They signed an attestation form that said they understood it. Once we received that back, then we would let Chris and her team know at KBH&E go ahead and send the payment. So 33.7 million was sent to nursing facilities. I believe it was early October. Then the next column is additional dollars that we sent to providers who are also HCBS providers, because We also had $12 million that we needed to send out to HCBS, community-based providers. And this column 8 is still a work in progress. We do not have it perfected yet because we're having a little difficulty finding a direct data link to number 8. So we've got more work to do on column 8. But to let you know, if an adult care home assisted living is receiving HCBS dollars and they tapped into part of the 12 million, they're on this list also, or they will be. That's our goal. Column number 9, this is, okay, this is Scott's portal, what I call Scott's portal. So this is the amount of PPE that we have provided to nursing facilities. This particular column is allocation, not actual. But Scott stood up his PPE portal in response to House Bill 2016. And as of this morning, right at $12 million of PPE has been ordered by these facilities on this list. Now this list is just adult care homes, but we've received over $12 million of orders. I think it was 12 million, it's down close to 11.5 or something. As of this morning, $12 million.
The keyword being ordered, not received.
Some of it has been received. It has been shipped.
I think, as you're going to hear us probably talk about this next Tuesday as well, is there's a big difference between ordered and received, and that's some of the things that we're starting to deal with. Senator Solomon.
Thank you, Madam Chair. That was basically my question as well. How long will balance take to get out to the facilities? Do you have any idea?
It is being, the orders have been shipped. So some facilities have started to receive the PPE from this particular vendor, Source 309 through Scott's portal.
Thank you.
Yeah.
So it might be good the meeting next Tuesday is as much details that you can provide us on where everything's at and the path of receiving. Representing Carpenter. I'm sorry. Representing Carpenter.
Thank you, Madam Chair. Janice, just if we're critiquing this, also if you could put over here a reference to the abbreviations in the class.
Okay.
There's nursing facilities, I know long-term care. Some of these I have no idea what they actually are as classes. And are all these folks licensed by you?
Yeah. So this 20-page report is licensed adult care homes.
So they're going 500, how many are
700.
700. Okay.
Yeah, so when Georgiana said it's going to be 20 pages, we hesitated for a moment and then we thought to do it anyway.
Oh, I think it's great information. I just, for lay people like myself, understanding these acronyms and the initials and stuff is difficult at best.
We hear yours in part, and honestly, SLO, I mean, I was even saying, what's SLO? And it's state license only. So we will create a legend so we know what SLO stands for. Because that was new to me. It's like, who came up with that? But it kind of works. Because if I see adult care homes excluding nursing facilities, state license only is what our team came up with. Okay. But we'll add a legend. And you are our first audience. So you're the first ones to see this report. I've already got a couple notes besides comments, so we appreciate your feedback. And then we're going to attempt to replicate it, but I'll get to that in just a minute. So column number 10 is, 10 and 11. These are the visitation aids that we then also stood up another process separate from the communication devices. We stood up a visitation aid process that allowed facilities to ask us for money for plexiglass, for tents, for heaters. You know, come on, what else can we do to get this visitation going again? So these two columns, and you'll see, we didn't have a lot of take-up, which we were kind of surprised we didn't get more take-up than we did, but we didn't. But we got a few. So a few facilities, once again, sent an application and they sent the invoices, then Deborah's there, is helping us get this money out to those providers who ask for some help for visitation aid stuff.
Janice, we have Senator Hildebrand has a question on Zoom.
Thank you, Madam Chair. And Janice, can you hear me okay?
Yeah.
Okay. All right. Hey, thank you. I want to go back to the PPE and the portal that you guys are using. Under HB 2016, it says that KDHE will provide, the state will provide the PPE, the testing, and the sanitizing equipment for adult care homes and nursing facilities. On that portal, who's funding that for those agencies or for those businesses that have to order their PPE? Are they having to pay for it, or is the agency providing that for them?
At the moment, we've got column 9, the agency is directly paying for PPE that's being shipped to nursing facilities and state licensed homes. So all adult care homes have been given an allocation, and we are paying for the money that you see on this sheet. Now, there is a caveat. So the answer is the agency is paying $12 million, which is the moment our cap is 12 million. You'll see 16 million here, and I'll share that with you in just a moment. But for right now, we are directly paying for PPE that's being shipped to assisted living, home plus, residential childcare, and nursing facilities based on these cap allocation amounts. So we are paying for the PPE to this contractor through the CARES and Spark money. That said, we also gave the facilities, you'll see in column 7, 33.7 million nursing facilities could have used to buy their own PPE. But for right now, we are paying for additional PPE. So I hope that makes sense, because it's really a combination answer. We asked the facilities to accept the 33.7 million. They did. We asked them to use it for PPE to buy their own. And now we've opened Scott's portal, the nursing facilities also. Now here's your column 9. Here's what we did. And Scott will explain it better than I do this afternoon or next Tuesday. Representative Langworth, I think I'm taking a lot of time here. I'll not be able to. But the 16.3 million you'll see at the top of this column is the total allocation for all these adult care homes. We've spent, as of today, almost 12 million. 12 million actually is our cap, although I just received a text from the Spark Committee office, the recovery office, that maybe I need to make a quick phone call. But we did not anticipate a take-up rate of 100% with this 16.3 allocation. We didn't expect it. That's not been our experience. Nursing facilities didn't take us up 100% on the direct payments. Assisted living providers didn't take us up on the initial PPE offer that we made them. So we didn't anticipate we'd have 100% take up. So we calculated allocation based on 16 million, but at the moment we've spent our 12 as of this morning. We've spent 12 million. So at this very moment, we need a few more dollars to completely maximize these allocations.
Okay, I'm going to take one more question here from Senator Solentrup, and I think what we might do, committee members, keep in mind, if you look at the agenda for next Tuesday, you're going to see a lot of more in-depth discussion on this issue, and there's a reason for that, because we know that there is questions out there. We're all getting your concerns, phone calls that we wanted to dive into it deeper, so we allocated an afternoon in order to deal with this. So, go ahead and ask your questions. I would also recommend that, dissect this document. If you have questions for Janice, give her a call, and then prepare your questions for, send them to her, and you can have them pre-prepared, kind of like what we do with the spreadsheet for the next meeting. Senator Solentrup.
Thank you, Madam Chair. I'm just curious, what's the formula? Number 9, is that on a per person basis?
Number beds.
Number beds, okay. How many beds do we have in 700 facilities?
20,000 in nursing facilities and about the same in state licensed only, about 40,000 beds.
Okay. If funds are not all used, then I want to rephrase that. How long until, what's the deadline on making requests for these funds? The past, it's still.
No, it's still open.
Still open.
It's still open. I mean, we can't run it all the way to December 30th. Right. That's when all the money has to be spent. But we can get close, because technically, as long as the order's placed and the shipments are happening, we get close to meeting that criteria that it's been that it's been used by December 30th. It's shipped. So to say we are hustling would be an understatement, to be honest with you. We are hustling. We are hustling this money. We are hustling to get it.
Stand up for a little help.
We are hustling. We are working hard to get as much money in the Scotts portal and let people out if we can.
Well, I think that's kind of a big question is with this deadline, because it's not just, you're not just dealing with it, our counties are dealing with it with their funding. And I know that hospitals are dealing with it with their CARES funding, and everyone is crunching to try and meet a deadline of a hard deadline of I have it in my possession and it's installed.
Right.
Well, so I guess how hard is that deadline on I have it and it's been distributed. I have it, it's been installed, it's not it has to be installed. Or is it just it's been ordered and it may be delivered in February?
We heard that we need to get it ordered and delivered by the 30th. Now, does every bit of PPE have to be used? No. Can it be stockpiled? No. So we've kind of heard this, it doesn't have to all be used. You can work into January, February, because we're still not outbreaks then, but can we stockpile a bunch of PPE at these facilities? No. So we're walking this fine line between, how do we, but Scott's formula is $350 a bed, and that's about a month's supply. So he's only giving them, a January supply is the premise here.
So December 31 is a literally drop dead, has to be delivered deadline.
It's actually the 30th. It's not even the
30th. Okay, that's fine.
March to December 30th. We got it, yeah. And our vendors working really hard to be really responsive. And that's not even all they're doing, to be honest with you. And I'll share that in just a moment, but as we continue to work with this.
Okay, Representative Ballard.
Clarification by January 30th. December 30th. Does all that money have to be encumbered so that it's accounted for, or do you actually have to have any receipt of it?
We've received all this money has already been transferred to KanCare. We have this money in our possession. The CARES Spark money, we have the money transferred to us. Then we just pay the vendor. So the money has to be to us by December 30th, and it is all here right now, although I just got another text. So the money has to transfer to us, we get it, then we can pay the vendor quick. We can get invoices still in January for what we purchased in December. But we got it. Yeah, that was your question.
Yeah.
So I can walk through the rest of this real quickly because I do want to share a couple other pieces of what I call good news for you. So the visitation aid, we saw some take-up rate, not significant. We were hoping for more. Don't know if that'll happen. The other two columns are actually these have the wrong label. This is actually CMS Binex test cards, so sorry about that. And then the CMS tests themselves. So Georgiana was able to pull in the actual CMS data that indicated to us which facilities have received Binex cards and which ones have received tests. So that is, these last two columns are actually some CMS data points. Now, what you won't see on this particular spreadsheet, besides these last two columns, which are federal data points, we haven't yet had the capacity, besides we're exhausted, we haven't had the capacity to pull in the federal direct payments to nursing facilities and assisted living, which I think assisted living material. We just simply haven't had the person power. If we can get there, we're going to do our best to pull in the federal direct payments also into this spreadsheet. But for right now, all these monies are the monies coming directly to KDADS that we then process. So we haven't yet commingled federal direct payments. And I want to close by saying, if you go back to the issues log, Luann Kibbe had asked about the very last issue was Kansas seniors and facilities and aging and home and internet access number 53. Let me just share with you what we consider to be some good news. We, on the community-based side, we recognized that we hadn't done much of anything for PPE for community-based providers, and you've heard from me, and you've heard from our community-based providers that they needed help with PPE also. And we didn't provide them with any tablets, although we were providing the nursing community with tablets. So we got approval from the SPARK committee because we didn't spend all of our $12 million originally for the community-based providers. We asked them if we could intercept $3 million of that 12 that wasn't spent and get some tablets and some PPE out to our community-based providers. And the answer was yes. So I'm pleased to report that through Scott's portal, that particular vendor had access to some refurbished iPads. So we quickly reached out to our community-based partners. We reached out to the AAAs, we reached out to Internet, a couple of the CEOs, we reached out to CMHCs and the SIL, and 4,100 tablets will be delivered this week to our community-based networks to get out to their consumers. So that's the best news of the day, in my opinion. So we will have some seniors who will get some iPads. We will get some CMHC customers who get iPads, and we'll get the SILs and the CEOs are all going to have. Matt Fletcher's going to have 2,000 refurbished iPads delivered to his office this week to help us get them distributed. In addition to that, we were able, through Scott's portal, to provide over $1 million worth of PPE to the SILs. So the 10 Centers for Independent Living, we provided them with a cap on based on the number of direct service workers that they have in their community network. So based on those number of direct service workers, we also are supplying them with PPE. So the SILs this week have received boxes and boxes of PPE from Scott's portal that I think it's all been almost delivered. So we are pleased to report it's not just the nursing facility. We don't have a spreadsheet yet to share with you on the community side. We share the adult care homes. We hope to have a community-based spreadsheet for you during the session. But I wanted to note today that we have done some good things. We hope for the community also, particularly with the tablets.
Reverend Carpenter.
Thank you, Chair. Just a quick question. On that CARES money for PPE, was it, did it go back to the beginning? Were they able to we heard a lot talk about how much they had spent in September. Up until that point, were they able to recoup those costs prior to September, or was it from?
Representative Carpenter, if I may, the reporting period for these CARES monies will be March 1 to December 30. So the providers will have to account for March 1 to December 30 for business interruption, expenses, increased staffing. That will be their accounting period. And sometime, if you're ever interested, we can have a conversation about the reporting. It is massive, it is intense, and it is detailed. So literally our providers are going to have to report March 1 to December 30th, what cost did you incur, what business interruption did you experience, report it to us, and then we will get it to folks at the recovery office who are helping us with this. It is massive.
And then just to follow up, would that have paid for testing also?
Testing, Scott's going to talk about testing, I think, this afternoon or the 15th, I think, I hope.
One or the other.
Okay. Yeah, he's either talking. Because testing is the statewide initiative, and Scott's our expert in our agency on that. So, and I think Representative Langer, I don't think I finished this issues law. I think I got close. I don't think there was too much left. If you want me to, page 29, I think was the next issue, and that was PPE, and that was, I already responded to you on that. We got some PPE. And maybe that was it. Oh no, page 29, number 43, and Scott will respond more to this during his presentation this afternoon on the infection control surveys. So we have been able to keep up with the infection control surveys that we receive from CMS every week. We get a list of facilities that we need to go survey, and so Scott can provide more detail this afternoon in his presentation. And then number 45 is the public reporting, and Sarah talked about that this morning. You'll talk to Dr. Norman this afternoon. And then money calls the person. I would be remiss if I didn't discuss on page 31, number 46. Amy Penrod and her team did reach out to CMS at the request of our stakeholders. The stakeholders kept repeating to us over and over that they thought there might be opportunities to reinstate a mental health person. We did send a letter, Secretary Howard, or maybe we sent it through Sarah, sent a letter to CMS and said Kansas is interested. We are crossing our fingers that we might be able to get our foot back in the door, and then we will apply for up to $5 million in grant funds that can be used over a 4-year period. So we're very excited to say money falls to person there might be a possibility we stand that back up. It might look slightly different than before, but that's okay too. We'll work with our stakeholders. Then Matt Fletcher, number 48, is asking for money to be restored. On number 49, this is about the spark monies, which we just covered with the spreadsheet. And then number 53 is, again, an update from the spreadsheet on what we've done for communication devices. So that is it for me, Representative Lanier, unless you have more questions.
No, I don't. I just want to reiterate to the committee that if you have questions that did not get answered today, or you think about them on this issue of nursing homes, please provide those. If we just send them to you, we'll send them, you'll send them to Janice. She will make sure it goes to the right people within KDAD, so that when we meet next Tuesday, maybe a lot of your questions may already have answers to them, which will help us move into any other areas that we have to go into detail, because the nursing home piece is a major piece for many of us that we're dealing with. So I appreciate it, and I appreciate this new report. That's going to be a good guide for all of us.
And we will date and time this actually so that Representative Lambert and we're going to do version after version. We'll update this version for the 15th, even and have Scott represented to you there as needed. So yeah, we'll keep it updated.
All right, thank you very much, Jen. And I know that we're running behind, so we'll just try to expedite as much as we can here to try and catch up a little bit. I try. Is now we have Kerrie Bacon, answer times.
It's Kimes. Thank you.
I apologize. Director of Provider Relations and Strategy for United Health. Welcome to committee.
Absolutely. Thank you. And good morning to everybody. I appreciate being here today. We just have a couple of really quick updates, so hopefully I will help us move this along. We're going to be looking at the same spreadsheet that both Sarah and Janice were speaking off of on the tab or the header that's called General Issues. We have 4 items on this spreadsheet that we need to do quick updates on. The first item is number 4 on the General Issues tab in regards to MCOs or writing individual service plans. Really no profound change since updates that have been done previously in regards to this. Has stayed really consistent on our process for doing this and no profound updates. So any questions on that one?
No, go ahead.
Okay, item number 15. The question was specific to adult care home providers and their credentialing process. There was a minor change to that process to make it more consistent with other providers that was made back in April, and that has been followed. Providers submit their information to KDADs, but then that is entered into the portal and flows through the MCOs for our processing. So that is a little bit more streamlined than it has been previously, and that seems to be working well. So I don't know that if this continues to be an outstanding issue, as they have streamlined this process with other providers.
Go ahead, unless I stop you.
Okay. Item 30 is the next one that we have where the MCOs are noted. There were a couple items on here. The first one was related to KanCare clearinghouses inaccessible. Obviously, that was not the item that was directed specifically to the MCOs. The second piece was in regards to the crisis process. Again, our response is consistent. We continue to follow the state's mandated process for submitting crisis exception, the type of documentation that needs to be provided in order for a crisis to be considered. So since that policy has not changed and there has not been a change in the process, that is a consistent response. And then item 32 is the last item I have where an MCO update was required, and this is consistent with some discussions we've had already today in regards to a request for an increase in the reimbursement for specialized medical care, the T1000 code for our TA waiver providers. And of course, we are fully supportive of that, and if that is funded and comes through as a state policy, the MCOs will do everything in their power to get that implemented quickly, so providers can reap the benefits of that increase. So we're just waiting to see the direction. So I appreciate your time, and we'll answer any other questions you may have.
Are there any questions for Kerrie? Seeing none, thank you very much, Kerrie. I appreciate it.
Thanks so much.
Next, I have David Livingston, CEO of Aetna Better Health of Kansas. Welcome to the committee, David.
Thank you, and good morning. So this is going to sound a lot like an echo of what was just presented. We have the same 4 issues. The worksheet that I'm working off is the general issues. It says Aetna in the upper right-hand corner. Starting with issue number 4 regarding service plans. We continue as we gave the update last time, and we continue to work and use virtual telemedicine and other methods so that we can make sure that these get updated and done in a timely manner. Number 15 on the credentialing, as United mentioned, we follow the same process, and so no updates there. Number 30 on the crisis processes, we continue to maintain the processes as discussed before and continue to be willing to collaborate and review the process with any stakeholders. And number 32, as was previously stated by United, we will support any fee schedule changes that are funded and work quickly to get those implemented and pass those through to providers. Any questions?
Hey, are there questions for David? Seeing none, I appreciate it, David. Thank you very much for being with us this morning. Next up, Michael Stevens, CEO of Sunflower Health Plan. Where's Michael?
Representative Landwehr, I can take this for you. I'm Stephanie Rasmussen with Sunflower Health Plan.
Yes.
Hey, Stephanie, it's Michael. I apologize. I was having connectivity issues. I am back.
Okay.
Thank you, Stephanie, for stepping in there.
All right. Good afternoon, committee and Secretary Landwehr. I appreciate it. Following up on the items that Sunflower had, as has always already been addressed by the other MCOs, first in regarding to individual service plans, Sunflower care coordinators do meet with member and guardians and DPOA when applicable to complete the needs assessment and develop a person-centered plan. We do use this process to determine the number of hours of support that are needed to be included in the service plan, and the members may choose to self-direct or have an agency provide their PCS services. All of these meetings are now remote due to COVID, but otherwise the assessment occurs in person. We do have a contractual requirement to submit a notice to the state when these waiver services have not been utilized for 30 consecutive days. And this may result in closure of waiver services. However, during the COVID-19 pandemic, the state is not closing any waiver services. The next item on which we had a follow-up report was item number 15 about adult care home providers credentialing process to be standardized. And as you can see in the matrix, our response that largely this is standardized. It must be initiated through KDADS. Each of the MCOs may have additional information that they request, and we work with the providers to get that additional information. The next item that we had was item number 30, regarding the clearinghouse being inaccessible to individuals with disabilities. In December, our response this December is that the KDADS agency has provided training to the CDDOs and the MCOs on the crisis request process for individuals who are attempting to access these services. Sunflower received feedback from at least one of the CDDOs indicating that the process is now more streamlined between the entities, and the MCO's role is to offer other potential services that may meet the members' needs and to mitigate or resolve the crisis situation. And if there is any, and make a recommendation to KDADS about crisis access. And then the final item to follow up, item number 32, is the increase in provider reimbursement rate for specialized medical care. That request, and our response is that we support any rate request approved by the state for this service, and if approved, if we are ready to implement it. The COVID-19 emergency protocols have allowed us to pay parents when the providers are not able to provide a nurse as a part of making sure that all needed services are provided. We implemented this and have recommended the member also have monitoring visits provided by a nurse when the parents are providing the primary support. So that concludes the items on which we had follow-up.
Questions for Michael? All right, seeing none, thank you, Michael, for being with us this morning.
All right, thank you very much. Bye.
No, it's not for you, never mind, go ahead, thank you. Okay, Representative Cannon has a question for him.
When we hear responses on these from the agency or from the MCOs, and we feel like, I mean, they've answered it, how do we know that the satisfaction of the person who brought up the issue? Are we just waiting to see if they bring a complaint to them, or I'm just wondering how you know, if it's addressed, I don't know that that is enough for what they, you see what I'm saying, for what they were asking for.
Well, we are operating under the assumption, and those assumptions are always dangerous, is that the agency or the provider comes back to us telling us that they have talked with the individual and worked it out, that they're giving us factual information. And I think it would do a disservice to not only us, but also to them if they provided us with false information. So
I'm not accusing anybody of bringing anything false. I just don't know if it goes far enough.
I see what you're saying.
So
no, I think we wait to get, you know, because there's you got to remember sometimes the limitation that we're dealing with staff too is, I think if the individual sees it as important enough to appear before us, then they also have a responsibility to stay on top of it. And if they don't feel it's been satisfactorily addressed, then they have the opportunity to come back to us again.
Okay, thank you.
Okay, next I have Megan Leopold from Legislative Research on, the one we all love, consensus case loading students. Welcome to committee.
Yeah.
We like you, we just don't always like the topic.
I actually have two pieces of testimony today. The first is an overview of the implemented business caseload estimates, and that's the PowerPoint. And then the second piece I have is the actual estimates that I'll go over. So I'll start with the overview. Human service caseload estimates take place twice a year. And they're modeled on the consensus revenue estimating process, which is in statute. They take place in the fall and the spring. So in the fall, we just completed the fall estimates last month in October. And in the fall estimates, we adjust the estimate for the current fiscal year. So in these past October estimates, we adjusted the estimate for fiscal year 21. And we also create a new estimate for the upcoming state fiscal year. And in the spring, which generally takes place in the April break, we create a final estimate for the current state fiscal year, and we adjust the estimate for the upcoming year. So each time we're making an estimate based on more information. The process consists of a team of people, Kansas Legislative Research Department, division of the budget, and then each of the agencies whose budgets are impacted by the caseloads. So that includes KDHE, KDADS, and DCF.
You know what, Megan, I think what I'm going to do, and I apologize for interrupting you, unless there's objection from committee members, rather than going through if you don't feel like we have a need to go through how all this process comes, because a lot of us have dealt with it for many years, that we could bypass that, but at least we have the information available to us and then get to the important information that you have to share with us today. Is that good?
Yeah, absolutely.
Is there any objection from anyone on Zoom? All right, seeing then, let's proceed. I'm just trying to expedite, but I don't want to shorten the important stuff you have.
Nope, I understand. So I will move on to the gold memo that you have in front of you. And those are the caseload estimates from October. So I'll go ahead and I'll start with fiscal year 21. The revised estimate for caseloads for fiscal year 21 is 4.1 billion, all funds, and that's 1.2 SGF. This is an all funds decrease of 20.3 million and a state general fund decrease of 167 million. And what we're comparing this to is the amount that was approved by the 2020 legislature. And that has been adjusted for both reappropriations and also for the allotments. So for fiscal year 21, the TANF estimate is 14.1 million, and that's all from federal funds. That's an increase of 1.5 million above the 2020 approved estimate. And that's largely due to an increase in applications due to COVID. The foster care estimate for fiscal year 21 is 268 million. And that includes 185 million SGF. This is an increase of 8 million all funds and 3.7 million state general fund above the approved amount. The SGF increase is due to a decrease in available Title IV funds, and that was offset by the increased FMAP. So because of the public health emergency for COVID, the federal match was increased by 6.2%. That's in effect for every quarter that the public health emergency is in place for. So for the purposes of caseloads, the 6.2% increase in federal match was implemented for the first 3 quarters of fiscal year 21. For KanCare medical, which includes both medical expenditures for KDHE and KDADS, that's estimated at 3.8 billion all funds, and that's 996 state general funds. This is a decrease of 9.3 million all funds and 160 million state general funds from the approved amount. The all funds decrease was largely driven by changes to the Healthcare Access Improvement Program. We reduced the provider assessment to the current rate because the increased rate was not approved by CMS. There's also a decrease due to the disproportionate share hospital allotments, which were, cuts were made at the federal level for those for half of the fiscal year 21. And the all funds decrease was offset by an increased population growth due to COVID. One condition of the 6.2% federal match increase that the state is experiencing is that no one can be removed from Medicaid. And so we're going to see a greater population growth, both because of COVID, but also because of that situation. There is also an increase in the health insurance provider fees due to payments that were moved up to fiscal year 21 that offset that decrease. The state general fund decrease was largely driven by that 6.2% increase to the FMAP for quarters 1 through 3. And there's also increases to fee funds that we use to offset that SGF amount. In addition, the extension of the nursing facility provider assessment, which was originally supposed to sunset in July of 2020, but was extended to July of 2030. Helped that SGF decrease. For KDAD's non-KanCare estimate for fiscal year 21, 41.5 million all funds, and that includes 25.2 million from the SGF. This is a decrease of 21 million all funds and 10 million SGF. And that decrease is largely to decrease expenditures on retroactive fee-for-service payments and offset by increased expenditures for PACE or the Program for All-Inclusive Care for the Elderly. Moving on to fiscal year 22. Well, I'm sorry, I'll stop for questions if anyone has any questions about fiscal year 21.
Are there any questions on FY21? Representative Carpenter.
Thank you, Madam Chair. Megan's already testified before me and Legislative budget, so I'll spare you all my questions. So thank you.
I figured this was your expertise. I was going to let you lead on that. Any other questions from the folks on Zoom? Seeing none, proceed.
Okay. For fiscal year 22, the estimate for all human services caseloads is 4.3 billion, and that includes 1.4 billion SGF. This is an increase of 184 million all funds, and that includes 205 million from the state general fund. And these amounts are being compared to the fiscal year 21 revised estimates that I just counted. The TANF estimate for fiscal year 22 is 13.5 million, and that's all federal funds. That's a decrease of 600,000 below the fiscal year 21 revised estimate. The foster care estimate for fiscal year 22 is 269 million all funds. And that includes 186 million state general fund. That's an increase of 700,000, including 1.3 million SGF. The SGF increase was due to the termination of that 6.2% increase to the FMAP, because that ended, as it stands currently, the public health emergency is slated to expire in January. And so we continued it through March. So the increased 6.2% FMAP is not in effect for any fiscal year 22. The KanCare medical estimate for fiscal year 22 is 4 billion all funds. That's 1.2 billion SGF. That is an increase of 182 million all funds and 201 million SGF. And that's again above the 2021 revised estimate. The all funds increase is due to increased production projections for cost trends and member growth. That included a 3.2% increase for MCO rates. Also the higher than normal membership due to COVID. Although the restrictions on removing individuals due to the public health emergency will be, is anticipated to no longer be in effect for fiscal year 22, we do anticipate that there will be some lag in removing the population or removing members from Medicaid, just because we'll have to, there will be some time that will take to reinstate the determination process or the redetermination process. The SGF increase is due to that population increase again, but largely due to that 6.2% enhancement that is no longer in effect for fiscal year 22. The state general fund increase was offset by the elimination of the health insurance provider fee, which was repealed. It was also offset by a full year of dish reductions. Only half of fiscal year 2021 was included in that. And it was also, again, increased it was offset by the use of fee funds. The KDAP's non-KanCare estimate for fiscal year 22 is 43.4 million all funds, and that includes 27.5 million SGF. This is an increase of 1.9 million, including 2.3 million SGF above the fiscal year 2021 estimate. And this increase is again due to projections of member growth for police and increased expenditures on retroactive fees. I'm happy to see further questions.
Committee, are there questions? All right, seeing none, appreciate you being here. We try. Okay, next I have Denise Seisman, CEO of Community Care Network of Kansas. Welcome to the committee. Can you tell we're just going to do?
Yeah, and we will hope to do that as well. All right, throughout this. Chair Landwehr and committee members, I am Denise Seisman, CEO of Community Care Network of Kansas. And thank you for allowing Matthew Schmidt, Derek Peel, and me to present about a threat to the 340B drug pricing program. Derek is going to be participating virtually, and Matthew is in the audience. We asked this committee to make a recommendation to the 2021 legislature to take action on our proposed legislation, including offering hearings on the bill. As you know, Community Care Network of Kansas represents a network of clinics serving patients who are disproportionately representing the working poor, the uninsured, and Medicaid beneficiaries. Health centers provide a wide range of services, including pharmacy. In 1992, Congress passed legislation to create the 340B program, a program that has enjoyed long-standing bipartisan support. This highly successful program stretches federal resources at no cost to taxpayers. Pharmaceutical companies sell drugs at discounted prices to health centers, hospitals, and other eligible organizations. Community health centers also use the program to reach more patients and to provide services that are more comprehensive. In 2019, Kansas health centers dispensed almost 500,000 340B prescriptions. This program is under assault. In his testimony, Derek will outline how pharmacy benefit managers, or what we call PBMs, are forcing health centers into contracts that are jeopardizing the 340B program. So why is this important to you? Why is it important to KanCare? Every patient served by a health center will benefit from the 340B program. And that includes the 81,000 Medicaid enrollees who are served by our health centers. Matthew is going to provide some specific examples. But in short, by keeping patients healthy, out of the emergency room, out of the hospital, and reducing their need for specialty and complex care, healthcare costs can be better controlled, MCO performance measures can be met, and state health goals can be achieved. KanCare wins when the 340B program remains intact. With the support of the Kansas Hospital Association and the Kansas Pharmacists Association, we will seek passage of legislation to mitigate the PBM threat. With your permission, Madam Chair, I will call on Matthew Schmidt to provide his testimony. That's fine. Thank you.
Thank you, Madam Chair and Committee. It appears that we drew the prime slot right after consensus caseloads, right between lunch. So thank you very much. Appreciate that. That's great. As Denise noted, my name is Matthew Schmidt, and I am the CEO at Health Ministries Clinic, a community health center located in Harvey County. For context, we employ around 170 staff. Last year, we served around 15,000 patients and performed around 52,000 visits. As I observed in my written testimony, many things involving healthcare in general and 340B in particular can be complicated. It can be easy to allow ourselves to be distracted. At the clinic, I sometimes find it helpful to slow down, let the water settle, and remind myself of what our central goals are, what is most important. This clarity often points towards a more intentional response. In this case, we need to be clear about what is at stake. The relief we are seeking is legislation that would prohibit pharmacy benefit managers from engaging in actions that will reduce funding for your constituents' healthcare for their profit. Please note that this remedy does not require any additional spending by the state while providing substantial benefits to its residents. The 340B program allows entities like community health centers to do two very significant things. First and foremost, it gives us a mechanism to help ensure that our patients, who disproportionately include the uninsured, underinsured, and those with Medicaid, are able to obtain medications ordered by their physician. This eliminates our patients from having to make the all too real choice between filling their prescriptions or paying rent and buying groceries. This is a powerful resource that has a profound impact on the lives of those we serve. In addition, the 340B program allows us to benefit our patients in a second significant way. The payments for medications we do receive are cycled back into services designed to benefit all the patients we serve, including those with Medicaid. This helps support things like integrating primary care and behavioral health, case management, diabetes education, transportation, and other assistive services that help break down barriers to care, but often don't have a means for reimbursement. These services are a critical part of what allows us to be so effective. Make no mistake, if the 340B program is weakened, patients will be impacted. Our ability to ensure that they get their medications will be compromised. Our clinics, which employ around 1,900 people statewide, will have to lay staff off, many of whom provide assistive services designed to reduce barriers to care. Ultimately, this will also impact taxpayers who will be left holding the bag for all the downstream ramifications while others increase their profit margin. The Community Health Center program is one of the most widely bipartisan supported healthcare programs in the country. Why? Because it works. Community health centers consistently produce high quality outcomes and save the healthcare system money. The 340B program has served as a cornerstone of these efforts for 30 years. This program is now needlessly being placed at risk. We ask for your assistance in providing a legislative solution to allow community health centers to continue delivering on our mission to ensure that all Kansans have access to high quality health care. Madam Chair, with your consent, I would like to turn over the remaining time to Derek Peel, who is participating.
All right, Derek.
All right, can I get one of these? Can everybody hear me?
Yeah.
Okay. Thank you, Madam Chair and committee members. We greatly appreciate the time we've been given today. My name is Derek Peel, and I'm the Executive Director of Pharmacy Services at Salina Family Healthcare Center. We are a federally qualified health center that serves Salina and the surrounding area. My comments today will be intentionally brief to hopefully leave a little bit of time for answering some questions. The primary issue around 340B and the one before you today boils down to 340B discrimination by PBMs. PBMs are redirecting to themselves the 340B funds that since 1992 have been meant to help safety net pharmacies, health centers, and their patients. They do this through two mechanisms, either kicking safety net pharmacies out of their networks entirely or forcing them into contracts that reduce their reimbursement, which transfers the benefit of the 340B program to the PBM's bottom line. This practice is already happening, and the expectation is for it to grow, in part because of a tug of war between PBMs and drug manufacturers, with safety net clinics and their patients caught in the middle. Our safety net pharmacy has been forced into 3 contracts that lowered our reimbursement based solely on our participation in the 340B program. In order for our patients that have insurance companies using these 3 PBMs to continue receiving their medications from us, we had no choice but to sign these take it or leave it contracts. Our bill that will be introduced in 2021 will prevent discriminatory contracting based on 340B. It will give you the opportunity to join multiple states in putting an end to for-profit PBMs exploiting the 340B program for their own gain at the expense of 340B safety net providers like us, and most importantly, our patients who are also your constituents. With that, we thank you again and ask that you include a recommendation for action on our bill in your committee report.
Madam Chair, committee members, that concludes our remarks, and we're happy to stand for questions.
All right, thank you, Denise. Committee, are there questions?
Representative Landwehr, this is Representative Mernan.
Representative Mernan, go ahead.
Good morning. No questions, just full-hearted support for this program and what it does for individual patients. I will be happy to bring that recommendation and encourage those who will be holding committee meetings next year to hear about this. This has a serious issue at the national level. Our clinics are in jeopardy, but more importantly, individuals are in jeopardy. In the clinic system that serves our region, I believe firmly that thousands of people's lives are maintained and at a better quality because they have access to the medications they need through the 340B programs. This is simply a way for Big Pharma to get more money, but the worst thing about it, it's on the backs of people who have the least. So thanks for bringing it to our attention, and I'd be happy to bring that recommendation later today.
Right. Any further questions or comments? All right, seeing none, thank you very much. Appreciate it.
Thank you very much.
All right, committee, we're getting closer to getting caught up. So I believe lunch is out there. Is that correct, staff? So lunch is out there. Grab your lunch as quick as you can. Make a pit stop if you need to, and then we'll try to get back on.
Representative Landwehr?
I just now did get sound.
Thank you. We just got it. Thank you.
Sorry, we don't have sound again. Are you anybody talking?
Senator Petty, this is Merle Riedel with Legislative Research. Can you hear me?
Yes.
Yeah, I think we are still trying to get the audio back up in the room. So members in Zoom can hear each other right now, but we just can't hear from the podium and the committee members.
Gotcha. Thank you.
Thank you.
So can you tell me if we sign on to the other link instead of Zoom, will we be able to hear?
So you can click on the Harmony or the audio live stream from the legislature's website, and you would be able to hear. But if you watch the YouTube feed, which is based on this Zoom feed, you would not hear any audio. Does that help?
Yes, thank you.
If we go to those other feeds, but can we interact?
You cannot, Senator. So yeah, if you go to the Harmony, you're just hearing the audio, and the YouTube, you're just seeing the video. This is the only interface that you can actually communicate with them. And so they're aware in the room. They're probably hearing me talk right now.
Yes, they were shaking their heads. They did hear you.
Okay, moving on to slide 7. I think it's the last slide. The question was, will this be added to caseloads? How will it be funded? While the Appendix K amendment allowing for personal care services and specialized medical care, HCBS during remote learning is no longer moving forward, we do expect a pivot from the fee-for-service delivery system used by local education authorities, or LEAs, to the managed care system. Currently, LEAs bill KDHE directly for Medicaid-eligible services provided to students during school hours. LEAs bill only for services actually provided to students. Should a student need medically necessary supports during remote schooling, the managed care organizations would be responsible for authorizing service hours as required by the federal EPSDT mandate. These services would be billed for and paid through the managed care delivery system. Since payments in either delivery system are made to the provider or LEA for services actually furnished, there is no risk of duplication of payment for services. Further, it is expected that the funding associated with the pivot in service delivery can be managed within the Medicaid program. KDHE actuaries are aware of this issue and will be monitoring expenditures. What we expect to see is a decrease in LEA fee-for-service expenditures as students shift to remote learning, and then an increase in personal care services and specialized medical care as EPSDT services are delivered during remote learning. It should be noted that this situation is very fluid as each school district continuously monitors and adjusts its in-person versus remote learning schedule. That does conclude my prepared presentation. I'll stand for questions at the appropriate time.
Amy, can you stick with us through this section? Because what I'm kind of thinking is that everybody we have on this, if we hear from them, then we can ask questions, and more than likely it'll just be one person have to versus multiple. Is that good?
Yes.
All right, thank you.
Representative Landwehr?
Yes, Representative Mernan.
All of us on Zoom didn't hear what she said until the last minute or so. Any way we can get a short summary of the first few minutes?
Amy?
Yes.
We'll try to do that for you.
Yes, I can do a real quick recap. Essentially, we were asked about the Appendix K amendment that was submitted by the state to CMS that would have allowed for specialized medical care and personal care services to be provided during remote school hours to home and community-based service participants. In a nutshell, after discussions with CMS, it was determined that an Appendix K amendment was not necessary as we already had an avenue to address those service needs via the EPSDT mandate that is provided via the state plan. So in a nutshell, the Appendix K number 4 amendment has been withdrawn, and that's the short of it.
Representative Landwehr, may I continue? I want to make sure I heard, tying that to the last part, I just picked up when you said moving away from fee-for-service, non-MCO services for school districts. Mm-hmm. What were you saying there?
Yeah, so local education authorities, when they provide services to students, they will bill Medicaid or bill KDHE directly using kind of the old fee-for-service system. We are expecting that as the service pivots kind of from being provided by the local education authority to being provided remotely during remote school hours, that then the MCOs would need to authorize the service as required by EPSDT. Those payments then would be made via the managed care system. So we are expecting some shift between the fee-for-service system and the managed care delivery system. Ultimately, though, it is expected that the funding associated with this pivot in service delivery can be managed within the Medicaid program.
And Representative Landwehr, am I understanding that more people are speaking to this particular topic?
Yes, because we have some folks from Sparks, some folks from the Department of Education, and our 3 MCOs. So it may more sense. Let's hear from each one of those of what they may have to say different or add to what Amy has explained to us. And then I think it will help maybe either clarify some of our questions so we don't have to ask them, or it might even increase our questions on my side. You know, so.
Great, thanks for catching this up.
You're welcome. Thank you, Amy. Appreciate it. All right, next I have Bert Moore, Director of Special Ed from the Department of Education.
Yes, thank you, Madam Chair and committee. I appreciate this opportunity to visit with you. One of the things I'd like to talk about is the Individuals with Disabilities Education Act that we follow here in Kansas. It's across the country. We also have the Kansas Special Ed for Exceptional Children Act here in Kansas that we follow. And so what we do is provide the special education services and the supports that are needed by students that are enrolled in the public schools as well as private schools where appropriate. So one of the things I wanted to share with you is that during this COVID-19 time, we had several parents that were requesting their students remain in a remote service location, which required a pivoting on the part of the districts to determine what special education related services would be required during that time. Our parents were looking more for medical services, which was outside of our purview from a perspective of what we're allowed to bill for Medicaid, in that they wanted attendant care so that they could go to work, and they had other things that they felt were more critical for them, and they were afraid of losing their HCBS summer program services. And so we met with KDADS and we had a conversation about how we could work together to resolve some of these issues. School districts are required to provide the related services and the supportive services that a student requires within the IEP. So what we would do then, and what we had to do through our Navigating Change document, is work with school districts on what services we could provide within the remote setting, keeping in mind that we work with under a least restrictive environment opportunity to learn for all of our students with disabilities. The homebound program itself is a very restrictive program because it removes the child from peer group and also from opportunities for that association with other students within the school setting. So normally homebound is reserved for those medically fragile children that the IEP team, including the parents, and that IEP is individual education program team, would determine are necessary for that child to receive an education within a home environment. So we were well aware that we were looking at what services we could provide during this very unique situation with COVID-19 and the remote needs of our medically fragile students based upon a parent preference. So I wanted to share with the committee that there is no financial incentive that we can gain from this opportunity because we receive our payments based upon services provided. So our medical providers, those related service individuals like speech and language providers, audiologists, occupational therapists, physical therapists, social workers, nurses, and school psychologists who conduct evaluations are permitted to complete a fee-for-service billing to Medicaid whenever they provide an educational relevant related service. So those services are paid as they are billed through fee-for-service. We also have a system called personnel payment categorical aid personnel system, where we can pay on an individual based upon the time and effort log that they complete that shows that they have provided a service. So I wanted the committee to know that we can't duplicate a billing, because if we are providing the service, then we would be billing for that service, or we would be completing a time and effort log so that we could claim that service for a personnel payment. And when it's not provided by the school system, then it is not reimbursable. And that would fall to another venue for that payment. So I just wanted to share with the committee that if you have any questions related to this issue and your concerns over anything related to the education of students with disabilities, I'd be willing to answer any questions that you may have.
Okay, and keep with us during the duration so we can take questions at the end of everyone.
Of course.
All right, thank you very much, Bert. Now I have Kerrie Collins with Sparks, or excuse me, Director of, okay, with United Healthcare, I'm sorry. And then Kevin Sparks, I think, is also with us. Have we lost our Zoom folks again?
Can you hear me okay?
Is that Kevin?
Yes, can you guys hear me?
Yes.
I know that Amy had some Zoom volume issues. So we sent all of, Brenda, we sent all of our information to Amy so that when she gave her testimony, it would be accurate. And I think that would be the state's preference. And so unless there is something specific that you want from us at United, I think that Amy had any of those things set up from her perspective. I know we had a Zoom issue and some of the members did not hear that on the phone, but that's what we were going to talk about.
Okay, and I got this a little bit confused. Is that the reason that we had United and Aetna and Sunflower with us is to assist in the questions, not from a presentation perspective. So what I will do now is open up questions.
Okay, sorry about that.
No, Kevin, you're fine. I got it confused, so I called on you, so you're good. So
okay.
Members on Zoom and in the room, if you've got questions of Amy Bird, United, Aetna, or Sunflower, now is the time to ask the questions.
Representative Landwehr.
Representative Mernan.
Thank you. Okay, so I want to make sure I understand because unfortunately I totally understand every single word that Bert Moore just said. And that is a frightening place to be because Bert Moore knows more about special education than anybody in Kansas. So, but what I heard Amy say is that the state is moving towards doing LEA payments through the MCOs. But if I'm understanding correctly, where does KDH&E stand on that? Am I understanding correctly?
No, Amy's shaking her head no, as is the secretary, so I'm going to let Amy answer your question.
Okay, and I apologize for the confusion if I wasn't clear. Currently, LEAs do bill in a fee-for-service kind of system. That will continue. It is simply a matter of who is delivering the service, whether it be the school. If the school is delivering it, they bill through the fee-for-service to KDH&E for those services. During remote schooling, if a child needs support, during that time, the MCOs would pick up then and authorize service hours, at which point those services would be billed via the managed care system or the MCOs. So it really is a matter of who is providing the services as to which system would be billed. Does that help answer the question?
Yes, that is exactly what I wanted to know. And that's the way, in my opinion, it should work in order for a family to receive what they need, right? So the child is eligible under law to receive those services at school, right? And then also under the guidance and regulations of our state plan, they can receive services at home. It's just who pays for them, right? And ideally, as a Medicaid program, we are wrapping around a family. And so while it takes more coordination from the field, where the school district says, hey, this kid is a remote learner, and they also have some high needs, it can be worked out as long as we're not double billing and as long as there's a clear plan in place. And that takes a little work, but I'm glad to hear clarification and thanks for bringing this to our attention. It's a great way for the Medicaid program to truly wrap around some of our kids that have the highest needs as we deal with the pandemic.
Are there further questions? Yeah, I guess, and I don't know if this would be Amy or for Bert, but I'm still trying to wrap my arms around this process because we have all of these children are IEP students. Is that correct? Bert?
We're assuming that they are. There could be a potential for a medically fragile child that served in a private school that the parents have not requested any support. I have to bring that up as an option. We're assuming that they all have an IEP and are supported under an IEP, but that may not be the case. I'd have to look at each one by one to see if they're in our system and receiving the special education services that are delineated within our SPED Pro program.
So, okay, now you've raised a new question for me, Bert, are you saying then that it's possible in the private or the public sector that children without an IEP may be receiving this?
It's very doubtful, but again, I can't confirm that 100% because I would have to see the student list. It could be that a parent does not consent to IEP services. It could be that medical fragile need of the child is such that the child could be served in a regular education environment. However, they have a physical or emotional disability that prevents them at this point in time for the parent giving consent for them to attend school for fear of them contracting COVID, which seemed to have happened in August by a couple of calls that I received. Now, the ones I dealt with were the ones that the children did qualify for IEP services, but they did not have medical home-based services within their IEP, nor did they have attendant care so that a parent could go to work.
Okay, so we are actually crossing IEP services and then medical services, which we are saying that's what the HCBS waiver is covering.
We are saying that the Medicaid program would cover any medically necessary services for those students, whether that be through EPSDT or HCBS or a combination thereof, depending on the needs of the student. I think what's most important, though, is that the LEAs are billing for what they provide, and our Medicaid providers in the managed care field are billing for what they provide. Therefore, there's no duplication of payment.
Well, I think you guys probably have that down. And so I'm not quite as concerned there as the school finance formula is so complicated that you have to be careful if there's any extra funding that's going to one school district versus another school. And see, and this is where I'm getting confused. We're not going to run into that here at some point, Bert. And I guess I have to ask, okay, I understand the medical side with the HCBS, but then, Bert, who is providing IEP services for that remote student?
That would be the district of residence, or if they have a contracted arrangement, whomever that contractor is, but normally it is the district of residence, and they would be the responsible agent for providing all individual education program services that that child needs in order to access a free, appropriate public education in the least restrictive environment. And that's where this issue came into concern, is the least restrictive environment often would be the school setting. The Navigating Change document did allow for significant needs students with disabilities on an individual basis to be allowed to come to school for services if the school district felt like it was appropriate. So we had a lot of options open to our parents with IEPs. However, the parents were concerned that if their child came to the school, they may contract COVID. And therefore, the parents were saying, I'm going to have to quit my job if I have to stay home to care for my child and provide this remote learning and not go to work because I'm not receiving the medical services that my child needed that they received over the summer. So the school district is accountable for all of those related services that are medically oriented, which include the speech language, the OT, the PT, nursing services if it's in the IEP, as well as social worker services, audiology, and then evaluations. So those are the medically needed related services that the school district typically provides to a student when they're on site, and that is needed in order for that child to receive their free, appropriate public education. Again, when it's in this COVID atmosphere where the parent is requesting they be served remotely and that it's due to the medical nature, then the concern came up of, well, how do we meet that need when we're here to provide the educational support the child needs? So that's where we got into this quandary of how are we going to meet the needs of these children and these families? And that's when we met with Amy and her team and came up with this option that would provide for both the needs for education as well as the needs for the medical need of the family. But we're willing and able to provide all of the educational services that the child needs within that least restrictive environment Madam Chair. I think it comes down to what the parents are requesting as far as the service provision that they feel would meet the need of their child, and how we can work together in partnership to make that happen collaboratively.
Right. Okay. And I'm trying to understand I want kids to have their services and their education. And I'm just trying to follow the money.
And I agree with you. And I think that we don't get the money for the child unless we provide the services. And that's what I'm trying to say. If I do not have service providers that are actually providing the services, then I can't claim that time for reimbursement. And we do pay on a personnel in the state, not upon an IEP service delivery model that some states have, where it's based upon the severity of the disability or the number of minutes the child is served. We serve based upon the personnel that actually meet highly qualified definition and serve that child. And we can only then claim that for reimbursement through the state aid or through Medicaid when the service is provided, the fee for service is completed and submitted, and then must have all I dotted T's crossed, and then the payment occurs.
Okay, so when the child is in the building receiving medical services, the school district pays for that, correct?
Yes, it's part of the least restrictive environment of being in the building.
Okay, and then they also bill Medicaid for that.
If it's, we have permission from the parent to bill, and we have a script in some cases to provide that service, yes, then we're allowed to bill.
Okay, all right, so I've got that piece. Now, if we shift it over to where you're not able to do that because you have to be in the building in order to bill for those services. Now,
not necessarily. It's an IEP team decision. They decide what the least restrictive environment is. And for most of these students that we're talking about, their LRE would have been in the building. But due to the COVID-19 and the logistics, a lot of these parents decided to keep their children at home.
Right. No, I understand that. I'm not disputing what you're telling me. I'm trying to make sense in my mind what I'm dealing with. So I'm trying to follow this money. So now I'm going to go back to Amy. So now, being the school district's not able to do that, as you say, I get it to be the parent. So I'm not saying that schools chose this or whatever, but the situation is the child's not able to receive it at the building. So now we're bringing in the HCBS services for these kids.
Actually, the school is able to provide those medical related services. They can do it through teletherapy, or they can work with the family to provide it on site if the parent will allow it. Because if it's in the IEP, we receive no federal waivers. So that means that we had to provide the services in the IEP when that student's IEP was drafted. So we were ready, willing, and able to provide those related services, and we have provided those related services. But what these parents were asking for in particular was attendant care and the nursing services to be provided throughout the day. So in order, in some cases, for the parent to be able to work. And so we can remote in through teletherapy or whatever with the family to provide those supports and services. But again, it's done on an individual basis. So I don't want you to think that the schools weren't able to provide it or didn't want to provide it. This was a choice that parents were making to keep their students remote.
Right. No, and Bert, I understand that completely. And irregardless of whether the school chooses or it doesn't, my question is still relevant, and this comes back to Amy then, is the HCBS waiver then paying for the services for these kids, which I now understand also includes attendant care, which they were not getting in the building if they were there in an IEP setting, right?
They could have received paraprofessional services in the building if it was in the IEP, and that would be a para providing those educational support services. And I don't mean to interrupt, but I don't want you to think that attendant care and paraprofessional services, because we do have paras that provide the support, then engage the child and enable the child to be involved in their educational program at school. But attendant care in and of itself would be a setting where the attendant would be in the home, in which case the parent could go to work. Our paraprofessionals typically do not work independent of a professional, and therefore having them go into a parent's home, if it was allowed by the parent, would not be an option if they're there by themselves.
Right. No, I understand. I've got a pretty good understanding.
Okay.
Stuff works. I also know, there's just the issues with the funding. And maybe it's just me being dense in this, but I just want to make sure I know what pocket we're dealing with. That will come to my next question. So you are providing those for some of these kids. Then let's use the 40/60 number just because it's easier. Who's paying the SGF side of that waiver, which normally would have been paid for from the school if they were able to technically provide it? Or are these all kids that get this service in the summer?
These are kids that get the service in the summer. I mean, if they're an HCBS participant, I mean, that's kind of where we were running into the issues. It's how do we treat these children during breaks like spring break and Christmas break, summer break, and they're home and they're needing, those supports.
Okay, you hit on a question here. This is a system that we somewhat should have already had in place because of there's always Christmas break, there's always spring break, there's Thanksgiving break, and then there's summer. So are you saying that we've always provided them HCBS services during those times?
Yes. Yes, during breaks. I mean, the level of HCBS services and the types of services that are authorized, the number of hours is determined. The MCOs might be able to talk to that a little bit more in particular, but those are adjusted based on the schedule of the participant in the case of a child when they're going to be in school versus not. And so we would agree that when they're not in school, it would be HCBS or the Medicaid program, depending on the type of service.
Okay, so instead what we've done, instead of it just being those normal breaks in the summer, you guys have figured out how to handle it if the school is in school, but all of a sudden decides to go to remote, that they can receive. Okay, it was a long way for me to get there, but so they have to be HCBS qualified students already. This isn't like all of a sudden, all of the special education students out there were put onto an HCBS if they're being taught remote.
You're correct. These are kids that have already been there. We're just trying to make sure that their needs are covered based on their schedule, whether that be in school, in the building, or at home. So these are kids that they're already eligible. They're already on the waiver. They're already receiving waiver services.
Okay. Well, then I totally misunderstood it, I think, at our last meeting, because somehow I got it, we were doing this with all special ed students, and if they had an IEP, and I was like, whoa, wait a minute, how do we switch them over to, if they're already HCBS qualified students? They just may be getting more time because they can't be in the school building. Okay, hallelujah, I got there.
Hey, Representative Landwehr. And I think we can summarize by saying we're talking about a very small group of kids, right? As we come down. So this is a handful of kids, but again, they're the most needy kids. And so, it's a good conversation to have. And I think, a takeaway from this as our MCOs are listening in, reiterates the importance of these kids having case managers, and that the case manager is in constant contact with the school psychologist who is managing the kid's IEP. And I am sure Bert would be happy to connect with every school district in the state of Kansas to make those bridges. But that, at that ground level, that case manager working through these specifics, I think we could do a lot of good for kids.
Okay, yeah, I was just, I left with the wrong impression from our last meeting. And so now I've gotten it clarified into my head. So now it makes sense. We were always doing it. We're just doing it more frequently because of the unusual circumstances. Thank you. And the nodding of the secretary, I appreciate it. I don't know why I just didn't. I suppose you understood it too. No, because I know that things might come out of Barbara's mouth. Okay, committee, are there other questions of Amy or MCOs or Bert with the Department of Education? All right, seeing that, Amy, thank you very much. I don't know why I just was not following the money piece on that, so now all makes perfect sense. So I appreciate it. Thank you very much. Okay, let's do an update on KanCare Meaningful Measures Collaborative. Then we will have Anna Purcell, Associate Director of Business Process with United Healthcare. Anna?
Hi, I believe Kerrie's going to step in. Kerrie Wendell is going to step in and take this.
Oh, okay.
Good afternoon, and thank you, Madam Chairwoman and members of this committee for the opportunity to provide an update on the KanCare Meaningful Measures Collaborative, also known as the KMMC. I am Dr. Kerrie Wendell Hummel. I direct the Center for Research on Aging and Disability Options in the KU School of Social Welfare and have been an active participant in the KMMC effort. We decided that if we reduced it to just 2 speakers and have the others on standby to ask questions, we would make better use of your time today. Are you following along in the slides, or are those supposed to be shown on Zoom?
Everyone should have a copy of the slides as a committee member.
In front of them? Okay. All right. So slide 2 then. First, a few acknowledgements. Our work is supported by a grant from the Reach Healthcare Foundation, and that participating organizations, agencies, and individuals contribute their expertise, perspective, and time to this project as an in-kind donation, and it's facilitated by Kansas Health Institute. So the next slide will be slide 3. As we've shared previously, the KMMC is a coalition of KanCare consumers, stakeholders, researchers, and state staff whose goal is not to evaluate the KanCare program, but rather to establish consensus around which data and metrics are most needed to better understand the performance of the program. So slide 4, and our update to you in June. We're in cycle 1, so we provided an overview of the selected priority areas for the first cycle of our work, which culminated in recommendations in April around the topics of care coordination, network adequacy, pregnancy outcomes, and social determinants of health. Since, and our full set of recommendations then is available at the link on the slides. Since that update, we have released reports on these meaningful measures, with the exception of social determinants of health, as existing measures are not currently reported on that topic. So what I'm going to do next is just briefly highlight what you can expect to see in those reports for each topics, as well as our recommendations, and then I'll turn it over to Sydney for other updates. So slide 5, and I'm going to go through the first 2 rather quickly because I understand you've already received an update on network adequacy and pregnancy outcomes, and there is a sufficient time for questions at the end of the presentation. So in each report, you'll see a figure that looks like this, where we provide a high-level overview of recommendations for the given topic. In the first column, this is where we identify existing meaningful measures. This is data that is collected that stakeholders think is meaningful, and it is the data is already collected, and furthermore, it's already reported in existing public KanCare reports. So 2 examples for network adequacy are the percentage of members covered within the network adequacy standards by provider type, managed care organization, and geography. Another example is the percentage of KanCare respondents with a positive response to whether themselves or their child received care right away when they needed it. There are additional measures available that are reported, and those are described in more detail in the supplemental tables that there is a link there too. And then in the middle column, here we focus on new meaningful measures that KMMC members are interested in seeing, but they're not publicly available. So the data may be being collected, but it's not being reported out to the public. And then finally, in the third column, other recommendations, here's where we highlight other recommendations that KMMC could address. As in this case, members are interested in knowing more about methodology limitations and data and the process of monitoring network adequacy. In slide 6, this just shows one of the metrics. Again, there's more in public reports, and this is the one that KMMC pulled to focus on. So this answers that first question that we looked at. In the last 6 months, when you or your child needed care right away, how often did you or your child get care as soon as he or she needed? This comes from a CAPS measure, so it's data that's collected from adults, the general child population, and children with chronic conditions. So you can see they're represented there in different colors. And in this case, we also have some national averages that we can use to compare our performance compared to nationally. And those are also presented in the report whenever those national averages are available. All right, slide 7, turning to pregnancy outcomes. So again, we have a similar figure. In this case, KMMC only noted 2 existing meaningful measures of pregnancy outcomes. That is the timeliness of prenatal care and postpartum care. And because there are only 2 measures available, we identified multiple new measures that KMMC members would be interested in seeing in the future, including birth weight, gestational age, and infant mortality. Other recommendations would be to identify if disparities exist within these measures, as well as exploring other potential data sources so we can have more robust data on pregnancy outcomes that could include, for example, the PROMS data, Pregnancy Risk Assessment Monitoring System. And here again, looking at the timeliness of prenatal care, this is one of the results. So we can see that in 2018, the average percent of the Medicaid plans nationwide who received timely care was 81%. For KanCare, it was 75.5%. All right. And then care coordination. And I'm going to go over this one in just a little bit more detail because I do not believe it was presented before, and further, this is the one that I helped work on, although I also want to acknowledge Lynn Valdivia, Kansas Foundation for Medical Care, because she's really the one who did all the legwork on this and identified all the measures. Stakeholders are very interested in assessing the efficacy of care coordination. And in doing so, they define care coordination very broadly because it is a broad concept, coordinating care. To make that more manageable what we did at KMMC is that we kind of identified 3 different types of care coordination and look at those separately. So one is general care coordination for all KanCare consumers. For example, care that is coordinated by doctors and other medical providers. And then we also looked at care coordination for KanCare consumers who receive the home and community-based services. For example, the service officially known as care coordination provided by MCOs. And stakeholders are also interested in the targeted case management for KanCare consumers who receive the intellectual and developmental disability waiver services. So we looked at the data sources and we found that really there were a lot of measures available, and this just lists a couple of them. A lot of these measures coming from the CAPS survey, the Consumer Assessment of Healthcare Providers and Systems. And we see a couple examples here in column 1, existing measures that are reported out. Personal doctors seemed informed and up to date about your care or the care your child is receiving from other providers. Or the proportion of people who felt comfortable and supported enough to go home. after being discharged from the hospital or rehabilitation facility in the past year. Those are CAHPS measures. They are collected from the general adult population, general child, children with chronic conditions. We are also really excited about some new CAHPS measures that our state is now starting to collect that are specifically for HCBS populations. So that's in the middle column because that data is now beginning to be collected, but is pretty new, so it isn't in a lot of public reports yet. So those are some new CAHPS specific measures, HCBS specific measures from CAHPS. And that we're excited about that data set because it does ask some questions directly about experiences and satisfaction with care coordination as a service, as well as targeted case management for those who are on the IDD waiver. However, that is, a newer survey, so we have some recommendations around that. Currently, the sample size is meant to support looking at the HCBS experience as a whole group. It's not strong enough to support comparisons across the different waivers, and it's also not a big enough sample, therefore, to look at comparisons between care coordination and targeted case management. Also, the HCBS CAHPS is only for adults. So we also recommend that there be some type of similar data collected for youth who receive HCBS services, and specifically stakeholders are interested in knowing more about the experiences of members who receive SED services with care coordination. And there are also some HEDIS measures available on care coordination. And so slide 10 gives us an example of that. And here we are looking at follow-up after a hospitalization for mental illness. What percentage of KanCare members received a follow-up within 7 days of discharge? We can see that KanCare members are at 59% in 2017, which compares to a national average of 37%. And in sum, on the care coordination, there are several measures of care coordination available, and that they are reported in KFMC's evaluations. We are really enthusiastic about the new CAHPS measures for HCBS and look forward to seeing year-to-year trends and comparisons to national benchmarks as that data set grows. We do encourage the state to support larger HCBS CAHPS sample sizes to provide a fuller picture of care coordination effectiveness in the KanCare program, and also a need to collect member experiences regarding care coordination from youth HCBS waiver populations, including the SED waiver. And I'm going to turn it over to Sydney now to go over the last couple of slides and next steps for KMMC.
All right, welcome to Sydney.
Great. Thank you again, Madam Chairwoman and members of the committee for having us here today. My name is Sydney McClendon. I'm an analyst at the Kansas Health Institute and one of the staff at KHI that helps to support the work of the KMMC. So I'm going to be talking to you guys a little bit about consumer engagement, which, if you're following along in the slides, is slide 11. And since the start of KMMC, the group has wanted to have KanCare consumers engaged in the work of the collaborative, which has taken many forms over the last 2 years. Most recently, in October, the KMMC worked with partners around the state to understand the experiences that folks were having with behavioral health services provided via telehealth during COVID-19. And so the goal of that survey was just to get a snapshot of what some of those experiences with telehealth has been like during the pandemic, with the intent that KMMC will likely pursue additional work around telehealth measurement in the coming year. And so these findings were intended to help us with that, as well as just to be kind of an additional piece to help others around the state who have been trying to understand what's been happening over the last 8 months. So I will say at the outset, as I'm running through some of the findings on this slide, that these should not be considered generalizable or representative of the entire KanCare population. Again, this is really just a snapshot of some consumer experiences. So we surveyed approximately 700 consumers through partners. And in that survey, we found overall folks were generally having high levels of satisfaction with their behavioral health services provided via telehealth. And when asked what their preference was for receiving services following COVID-19, many consumers expressed an interest in some form of telehealth being available, often in conjunction with their in-person services as well. Some of the benefits that consumers highlighted in the survey was their ability to continue accessing services, which was really important, particularly during COVID-19. But we also heard about kind of the convenience of being able to receive services within their home, which for some consumers allowed them to have appointments more quickly or to work around school or work schedules more easily. Finally, we also saw many who commented on how telehealth helped to resolve issues related to transportation. This is particularly true for those without a car or a ride to appointments, as well as those who may otherwise have a really long drive time to get to their appointments. Some of the challenges that we heard about from consumers included some technical difficulties in setting up their telehealth service, some struggles unsurprisingly with devices or internet access consistently working in services. We also noted that some folks highlighted some issues around staying engaged during their sessions and not getting distracted. So one of the benefits is being at home, but sometimes we know there are more distractions at home as well. And then others described how they may have felt a slight lack of the personal connection during some of their telehealth services, particularly because you're losing some of that nonverbal communication like body language. So these were just some of our high-level findings from this work. Again, I know it's not representative of all consumer experiences, but really was our attempt to hear more from consumers to inform the KMMC's work on potential telehealth measures in this area. And I think you guys actually have another presentation following this one on telehealth survey work. So that brings us to slide 12, some of our next steps, which include continuing to analyze some of those consumer engagement results I just described. So the KMMC discussed some of these early findings in its November meeting, some of which I just highlighted for you. And the group is going to be updating that work with additional analysis in the coming weeks. And then as we move into 2021, I just wanted to highlight some of the potential new topics that the KMMC is considering, including behavioral health, communication, quality assurance, and telehealth. And the executive committee is going to be discussing which of those 4 topics to move forward in the next week or two. We would expect some of that work would be similar to what Kerrie presented to you earlier on some of our previous topics. And then finally, I just wanted to put a question to you all, either for today or if you guys have ideas moving forward, to see if there's anything that would be helpful for the committee from the KMMC moving forward as we're thinking about measurement and areas of stakeholder interest around KanCare measurement. So with that, on slide 13, I just wanted to say thank you again for having us today to provide you this update. We're happy to stand by for any questions. And as Kerrie mentioned, we have a couple of other KMMC members on the line today to also help answer any questions that you might have. And finally, we've included some ways to connect with the KMMC more later if you're interested. So with that, both Kerrie and I and others are happy to stand for any questions you might have.
Sydney, one question I have for you is on your slide 11. When you use the term behavioral health, does that include substance abuse and mental health?
Yes, we were taking a broad view of behavioral health, so it would include mental health and SUD. I will say I think a lot of the services were probably predominantly mental health, but it was a broad definition of behavioral health.
I asked that because through the Mental Health Modernization Committee, that's been, one of the discussions we've had is what's the one term that we define mental health and substance abuse with, so that they are interchangeable and it's not just focused on one. So thank you. Committee, other questions? Representative Carpenter.
Thank you, Madam Chair. This question is on, has to do with the pregnancy outcomes. We have presumed eligibility here. All the rest of our outcomes were higher than the national average except for this one. Is there any particular reason that anybody can think of that Kansas would be that low when it comes to pregnancy outcomes?
So this is, I will point out that these are based on NCQA NCQA HEDIS standards. It says 2018 at the bottom. That is 2017 calendar year. I do believe that as we look forward, we will see that these are increasing. There are some nuances to these measures, including things like when the eligibility is received, and making sure that the calculation pieces are clear and correct. But I do think that we'll see, at least for the MCO that I represent, we have increased focus on this, and I think you'll see these numbers coming up.
Very good. Thank you. Thank you, Madam Chair.
Any further questions? All right, seeing none, thank you very much. We appreciate the information on this. Okay, next we're going to have a report on provider survey on telemedicine. So I have David Jordan with United Methodist Health Ministry. I've been saying United Healthcare all morning, so I apologize. Big difference. Welcome to committee.
Madam Chair, thank you for having me today, and thank you to the members of the committee. My name is David Jordan. I'm the president and CEO of United Methodist Health Ministry Fund. We're a 35-year-old health foundation located in Hutchinson, Kansas. Our mission is to improve the health of Kansans, and we focus on 3 strategic funding areas: access to care, early childhood development, and healthy congregations. Today, we just wanted to spend a few minutes talking about some research that we were able to partner with a number of the state's provider groups on, the Kansas Medical Society, Kansas Hospital Association, the Association of Community Mental Health Centers, Community Care Network, the Family Physicians, the pediatricians, and the substance use providers, as well as the Osteopathic Association. We really appreciated the opportunity to partner with them. The goal of our partnership was to explore how the policy changes that went into effect shortly after the onset of the COVID-19 pandemic that related to telehealth had an impact on utilization, access to care for Kansans, and on providers. To understand how these changes impacted Kansans, we partnered with Dorothy Hughes from the University of Kansas Medical Center and the provider groups, as noted, to survey their members. The results that we got back matched previous research that showed that these changes resulted in increased access to care for both patients in urban and rural settings. It increased the continuity of care, decreased time away from work for families to see medical providers, and allowed patients to better contain and manage healthcare costs. Overall, telehealth providers provided both patients and healthcare providers with options that can positively impact outcomes. For example, helping patients better and providers better manage chronic disease is one example. We recognize that this research is just one study, and we wanted to understand how these policy changes impacted access to care for patients, particularly during the pandemic, but moving forward. We also recognize that telehealth is not intended to replace in-person care. However, as the committee and the legislature explore how to maintain expanded access to telehealth services to benefit in the long term from some of the items that I highlighted above, we recognize that parity in payment and payment in general are going to be central to sustaining these telehealth services. One piece of research that I'll pull out, and Dr. Hughes will follow me and provide an in-depth review of the research, really is just that parity in payment was central to both the ability to expand services as well as for providers recognizing it, that to help them cover their cost, which is why 61% of the providers surveyed highlighted that this is the top issue for them as they move forward and work to figure out sustainability of services. I just leave one quote in my testimony, and I think it's worth repeating here to just offer some perspective in what was shared. This was a quote from a provider. "I was totally against telehealth before COVID. I did not see a use for it in my practice. Now that I have tried it, my patients and I love it, I'm very afraid that reimbursement will be taken away and I will have to give it up." We recognize that this research is just one study, but it offered a real important snapshot into how telehealth policy changes impacted access to healthcare services and also the provision of services, and really help foreshadow what's going to be needed to think about sustaining some of these accesses, which can offer real positive benefits. Dorothy will cover some of the research findings more in depth. We also plan to complete additional provider research, doing in-depth interviews with providers, as well as, I think, consumer research. We plan to do a consumer survey statewide of at least 600 Kansans, as well as to do some in-depth focus group work with consumers. We hope to complete that in the spring, and we welcome the opportunity to share it. I'm happy to stand for questions or hold off until after Dr. Hughes is able to present. Again, I appreciate your time and consideration and look forward to partnering with you in the future.
Thank you. Now we'll recognize Dorothy Hughes, Assistant Professor of Population Health at the University of Kansas School of Medicine. There you are. I'm not always quite sure which way to look first.
So thank you, Madam Chairwoman, for having me. As David said, and you did,
if you feel comfortable with your mask off, that would be our preference, just because the clarity, but if not, you can continue where it's just better for the Zoom people.
Oh, I apologize. I'll make sure to stay close to the mic, but okay.
No, that's fine. You have to feel comfortable, yes.
Thank you, thank you. As David mentioned, this is just a snapshot of provider experiences. And we do want to acknowledge the wonderful partnership of the provider groups across the state who so willingly distributed the survey to their membership. We really appreciate their work on this as well. We had about 247 respondents and 231 who actually answered the majority of the questions. So that's what I'm going to be mostly covering today. The key takeaways from the study, the survey was answered mostly by outreach organizations, mainly primary care physicians. They indicated that they, as physicians, but then also NPs, PAs, and other behavioral health professionals are providing these telehealth services right now. Video conferencing is the most common modality, regardless of setting, so across inpatient and outpatient. Primary care, patient education, chronic care, and counseling and therapy are most commonly provided telehealth services. Respondents' top policy priority was payment parity. They did say that insurance coverage has become more prevalent from year over year, 19 to 20. And their perceptions of reimbursement have improved, become more positive over last year to this year. All the 2020 policy changes have been largely characterized as very positive or somewhat positive. And they perceive that their patients, their organizations, and they have all had pretty positive experiences using telehealth. This is a map of the state, obviously. So this is where our respondents are from, to give you a little bit of an idea. As you might imagine, there's clustering in the more urban areas, but we were glad to see it smattering across the rural areas of the state as well. This is a breakdown of our respondents by organization type. And so, as I mentioned, most of our respondents came from outpatient organizations. The types of professionals who answered the survey, again, most were physicians, and of those, most were primary care physicians. But we did have a smattering of other types of professionals as well, so we were glad to have that variation. I mentioned the most common modality used right now in telehealth is video conferencing. But phone, about 2/3 of our respondents were saying that they were using phone as well, and just under half using mobile devices. So there is a little bit of variation there as well. The service is being provided by telehealth. I mentioned in the key takeaways that mostly we're seeing primary care, but also I would highlight behavioral health services such as counseling, therapy, and psychiatry are also happening at pretty high rates. And I'm going to break out some of these data and highlight the responses of behavioral health professionals specifically, because I do think that it shows how different services are provided differently, and different aspects of telehealth matter to different kinds of patients. We asked them how they characterize reimbursement for telehealth before, in the before times, that's what I like to say. And most of them said that it did not cover the cost by a large margin. But you'll also note that 30% of them said unknown. And so that's something we want to follow up on in provider interviews to better understand, are the providers themselves involved in the billing process? And maybe that part of the reason that they didn't know is we were actually asking the wrong people, potentially. So we'll ask them who in their practice, is involved in the billing processes, and should we be talking to them about what reimbursement looks like. When we asked them how things have changed going from 19 to 20, they did say that they think insurance coverage has increased. But again, we have a pretty good chunk of unknown. So even with increased talk about this and sort of this being out there and just being talked about more because of all the changes this year, you still have almost a fifth of people saying unknown. But those who do know about coverage said that it has increased. Now we get into kind of ratings of policy impacts. So the policies that we asked about are listed across the bottom there: expanded reimbursement, decreased geographic restrictions, loosening of cross-state licensure requirements, broad reimbursement for phone visits, and then place of service changes. And as you can see, so the bars for somewhat positive and very positive are the highest across the board. And here's an area where I wanted to separate out our CMHCs and our behavioral health providers, and just note that for them, these couple policies, broader reimbursement for phone and place of service changes, such as allowing patients to be at home, were even more highly rated as very positive compared to the overall sample. And so this is an example of saying that the type of service does matter in terms of what kinds of policy solutions are best suited to which kind of practice, which kind of service. We then asked about policy priorities going forward. And so we asked them to consider payment parity, having a distant site be the patient's home, having a HIPAA work exclusion for non-video services, having the originating site be the provider's home, and then of course the options for do not answer or other. And payment parity came out on top. But again, if you segment out behavioral health providers, what you'll notice is there's a little bit more even distribution and importance across three of the policies: payment parity, having the distant site be the patient's home, and then the work exclusion for non-video. So again, you see this issue of phone services and the issue of patients being able to be at home popping out as especially important if we're talking about behavioral health services specifically. We asked whether they perceived that their patients were having difficulty accessing telehealth, and this was kind of an even split. Now, when we asked what kinds of difficulties, they said fairly evenly: insufficient access to devices, insufficient access to broadband, or difficulty using technology. And if we separate out just behavioral health, there's only a slight difference in terms of proportion of respondents who answered for each kind of potential barrier. Now, when we ask them though about concerns, so not difficulties or barriers, but just concerns using telehealth, that proportion of people who said yes was smaller. Only about a third said that their patients might have some concerns. And the types of those concerns, the most often cited, were that patients might be concerned they wouldn't get their health needs met, or concerned it's too impersonal. Now, again, if you separate out behavioral health, the most frequently cited concern was that it's too impersonal, which makes sense, if you think about the kinds of services that means. So lastly, I want to touch on this overall experience with telehealth. So most of our respondents said that either they were having somewhat positive or very positive experiences with telehealth. And they said that regardless of whether we meant, you yourself as an individual provider doing it, or whether you thought your organization as a whole. So I want to just briefly touch on the fact that we are doing these follow-up provider interviews. So doing in-depth interviews with them. We want to have a really wide variation in experiences that we ask people about. So we're going to use those who self-identified on our survey, but we want to make sure that they come from all of the professional organizations that have partnered with us, and that we get a few of every type of provider that answered the survey, so that it's not dominated by only physicians and primary care physicians as our survey respondents were. I wanted to give you a little bit of a sample of the types of questions that we might be asking them. And if you have ideas on what you want to know as well, and I would be more than happy to add to this list. But we want to ask what kinds of patient care or services are best suited, how they ensure the quality of care when delivered via telehealth, and make sure it's at least equal to the quality they deliver in person. We'll ask them about billing and reimbursement, of course, and then ask them about the future. Given everything that has happened this year and that we've learned, now that the cat's out of the bag, so to speak, on telehealth, where do they really think it's going? So those are the types of things we'll probably be asking. And I think that one of the messages that really comes out when you look at the priority of payment parity, and you look at some of the open-ended responses that I didn't highlight, what's pretty clear is that providers value their autonomy, right? And they want to be able to use their clinical judgment as opposed to have to make a decision between in-person or telehealth based on finances. And so that's something to think about going forward too, as we continue to talk to providers, is how are they making these decisions about how to offer their services? How are they maximizing access? And then what role does finances play in that, and policy and reimbursement? So with that, I will stand for questions if you have any. And my contact information is in the slides as well. And I would welcome you to contact me at any time if you have questions.
All right, committee questions?
Madam Chairman?
Yes.
This is Senator Petty. And Dr. Hughes, it's nice to see you. It's been a while since our paths crossed, starting here at the Capitol a few years ago. I wanted to ask you on the upcoming survey, as I looked at the questions, do you think you'll be able to perceive whether patients are having a preference towards telehealth medicine as opposed to in-person?
Sure. So, and David may want to chime in on that as well. But I believe in the patient survey that we anticipate doing in spring, that is something we'll probably want to touch on is preference. Not only things like, are they taking time away from work, and sort of convenience factor, what's going into their decision making. But yeah, sort of general preference, how comfortable they feel on telehealth. That's certainly the type of thing we want to better understand. Yeah.
And Madam Chair, just as a follow-up, I know we've repeatedly heard some concerns about billing. So will your follow-up give help to identify if there are billing issues when it comes to telehealth?
I sure hope so. So as I mentioned, one of the follow-up questions we want to make sure and ask providers is what their knowledge of billing practices is, and if they feel they're not knowledgeable, then we may even kind of branch out and talk to their practice managers and others who might be involved in the billing process to better understand what's going on there. And if that's an area of particular interest to the state and this committee, we would definitely add that.
Thank you.
Thanks, good to see you.
Are there further questions?
Look right, you didn't look left.
Well, it's happening. Representing from Canada. I'm sorry.
It's better you than even. Good to see you. I didn't recognize you with your mask on, and you cut your hair since I saw you last time.
I know hair is all we have to go on, isn't it? So.
I'm wondering if there's been any discussion on use or payment using telemedicine for second opinions.
Mm-hmm.
And I'll end the question there.
Sure. So where my brain goes when you say second opinions is specialty care as well. So is that what you kind of mean? Is if in one setting, or are you talking about specialty to specialty?
I'm talking about anything, but I kind of have something in my mind that that I can see a negative that could happen out of that. So why don't you go ahead and answer?
Well, so I have to say I am not knowledgeable about current reimbursement policies when it comes to second opinions, because that's, I mean, my brain might be going where yours is, where, you know, you could potentially have someone just saying, oh, well, I want to get another one and another one and another one. And, you know, if you keep paying for it, like what does that really mean? Where do you draw the line? So I think I would lean towards saying, I think we should ask providers what they think about the current state when it comes to that. And it's probably reasonable to treat telehealth, you know, a similar way we treat in person. That's kind of the messaging we're getting from providers already, is that like the difference is just modality in large part. There are certainly, we anticipate that there are some services or types of patient care that lend themselves better to one or the other. But I guess my answer there would be, I'd like to ask providers what they think about the current process, and then if they see it applying equally, I guess, to telehealth. Does that make sense?
Yes, it does, and that's why I wanted to bring it up. So that maybe that would be an interview question that you know, I just kind of had just an image of someone who does the emergency room doctor shopping, and instead of going to the emergency room, they're on the phone doing it. And so, yeah, thank you.
Of course. Committee, are there further questions? A couple is, I guess, and you know, we heard this earlier, is define payment parity.
Good question. So we did not give our respondents a definition when we fielded the survey. And that is certainly something we want to ask them on follow-up. Because as you well know, I suspect, you can interpret it a couple ways. Is it literally the same dollar amount coming back, you know, for an in-person versus telehealth? Or is it covering costs in the same way you are covering cost of in-person? And so the difference there would be, what is the cost difference to a provider to provide one kind of modality versus the other? I am not an expert in that area, but I certainly know that's part of the discussion here. You know, what do we consider cost to provide? Or are we looking at sheer dollar amounts kind of on the back end, if you will?
Well, because it's easy to do this survey and get this defined payment parity. And it's a can of worms that when you open it, it explodes in this building. So, you know, I think anyone that wants to help promote on this, I'm not discouraging, but they need to really do their homework and bring all the parties together, because it's just not going to be a slam dunk because a survey said.
Sure.
And so that, and I know we've been having some discussions on that in the Modernization Mental Health Task Force on, you know, what to do with telehealth. So we've been talking about, what was the term we used yesterday? It's basically on the end of like, okay, you've walked into a CMHC's office or a school's office or whatever, another building, and is there a connect fee for this over here to actually meet with this person here, because you're not using your own technology. You've got someone else that's providing the technology and stuff. So it's gotten really complicated. The good thing about the Modernization Committee is that we have experts in the field all across the state, and that includes some of our insurance companies, so that we can figure out what that balance of stuff is. So that's why I asked that question. And then, do you see, or your colleagues see, a difference between the terminology of telehealth versus telemedicine?
Yes, there is a difference in that definition. I honestly couldn't recite it off the top of my head. I believe the definition that we typically use for telehealth is the federal HRSA definition, Health Resources and Services Administration. Telehealth is considered more broad than telemedicine. So I mentioned that one of the commonly provided services is education, for example, patient education. Under a strict definition of telemedicine, that kind of thing probably wouldn't be included because it's not like very direct, you know, clinical care, actually administering of care. So yes, telehealth is a more broad term.
Well, because that's the other thing we're struggling with is, you know, what terms do we use for what, and getting those definitions defined as we're moving forward, because you're right. Well, you know, we talk about the negatives of COVID, but COVID has also advanced a lot of positives.
Yeah.
And telehealth happens to be one of them. That it was moving there, but it's escalated now. So how do we deal with that?
Yeah.
And what are those different terms? Because I've heard it both ways. And when I talk to some folks, they think telemedicine, now they're thinking more like their family physicians, more of the immediate care type stuff versus the mental health. And
right. Yeah.
That's why I asked.
If I may, yes. You know, I also teach in our Masters of Health Services Administration program, and we do an awful lot of talking with our students about where healthcare is going and how to be responsive to that. And as I'm sure you know, more and more, it's about what happens outside the four walls of any kind of healthcare organization. And at least I would argue the definition of telehealth encompasses more of what we know matters to health and how we go about addressing those factors so that long-term we are really promoting health and not just delivering services.
Representative Landwehr?
In the world of the telehealth is that we have, or with mental health is there's the current concern, especially with young people, you know, with the therapist not being able to, you know, see all of the body language that comes from a young person. But even with some of their older clients, they worry about not being able to see all of the body language. So I'm trying to be really careful as we advance on this here that we don't lose that in brick and mortar appointments because they're going to be necessary. And I think I would be concerned, and I'm not in the health field whatsoever, but I would be concerned if a therapist felt comfortable, or if I had a client that felt comfortable just never only doing it from their home and me never seeing them physically because there's something else going on. You know, what is that's going on? So there's a lot of, we make it sound simple, but it's not as simple as it appears. So. But I appreciate the information that you provided us today. Was there someone on a Zoom that had a question or a comment?
It was me, Monica. I believe that those definitions appear in the Telemedicine Act that we approved in 2016. Eileen's in the room there. She would know that for sure.
The telehealth legislation was passed in the 2016 session. Were you looking for a term?
No, I'm thinking the answer to the question you just asked is in that act, the definition of telemedicine versus telehealth.
Well, it may be Representative Murgan because one of the we're looking at, the modernization of mental health is we're pulling, you know, from back resources. We didn't go in and reinvent the wheel. And, you know, so we're putting together our recommendations and then we're going to start sitting down with that legislation from 2016 and figure out, you know, what tweaks that we need to make, not totally reinvent the wheel because we know it's a very sensitive topic. Yes, I am.
Thank you, Madam Chair. Just from a purely drafting standpoint, it almost doesn't matter what term we want to use because we're going to define the term however we want.
Right.
So you could say telemedicine or telehealth. We're going to use the, you know, we've already defined it for purposes of the legislation we used in 2016, but that definition is for the specifics of that act.
Right.
If you don't want to use that definition, we can use a different one for this one. It really confuse the heck out of people. But when we do that, our federal and state definitions conflict sometimes. Believe it or not, we do have different definitions for the same term in different chapters of statute sometimes, but long story short, we can define anything we want to be specific to the context in which we're using it. And it really doesn't, we can do whatever we need to make it work.
Right, we're just trying to figure out, you know, how do we carry this forward so we stay consistent and so that future legislators, et cetera, can grow with it. And so I'm actually driving legislative research crazy at this very moment with hey, they're handling it. I'm impressed. You know, with what I call a living document, because this will be a report that we will make it live so that every legislature is looking at it and advancing to hopefully the next 10 years.
I'm sorry, I'll just get into what I would do is err on the side of common sense, which sometimes is greatly lacking in legislation. I'm not, I'm not pointing too many fingers, so my hands are kind of clenched. But err on the side of common sense and do what you want to do to make it, user friendly, and that'll be the easiest way to make that able to, be amended logically as as the need.
That's why I speak in layman terms.
Well, right.
Yeah. Okay. Are there any further questions? All right. Seeing none. Thank you very much for being here. All right. Now we're ready for KDHE. And I just can't get off that 30-minute behind work I've been trying all morning. I don't know who's presenting or what they're going on because they wanted to do it strictly by Zoom rather than here in the building. Who's that first?
This is Dr. Lee Norman. I'm the secretary of KDHE, and I'll be starting. Thank you, Madam Chair and committee members. Madam Chair, do you have the handout in front of you that looks like this?
Yes.
Very good. Okay, so the first slide is just a cover slide. Please turn to slide number 2, which is the agenda. This is how we would like to present to you today, and thank you for the invitation to testify. I'll open up with some comments, and then we'll turn to Sarah Fertig, the State Medicaid Director, and then Christine Schwartz will talk about Medicaid operations, including eligibility. So next slide, please. Slide number 3 that says update from the Secretary. I wanted to talk about a few high-level comments because needless to say, with as much activity as there's been with COVID-19 in the state of Kansas, lots of interplay with the Medicaid program. First, I wanted to talk about infection control and prevention in beneficiaries and caregivers. One of the things that was top of mind during this whole pandemic to date, and we still have a long ways to go, is what can we do that minimizes the risk to patients and their families, especially those that are the most vulnerable ones, and also minimize risk to caregivers. So that goes both ways. And I'd like to give a lot of credit to the 3 MCOs and to our beneficiaries for that matter, and the caregivers, because of some of what you just heard about, there had to be lots of innovative approaches and new ways of doing things to allow people to stay out of harm's way. And the telemedicine applications, psychiatry, if you will, allowed a lot of fine tuning, and the caregivers would go to, for example, homebound individuals, caregivers would go there if, as a result of a telemedicine visit, they had reasons to concern. And Madam Chair, for exactly the reasons that you said earlier, and I think it's very insightful, you can't always tell everything over a telephone. And watching somebody visually on a screen gives you a whole lot more. But if you don't feel comfortable with being able to do a full assessment, then you have to see the person in person, and there's no substitute for that. So I think you're going to hear more from the MCOs later about the innovation and creativity that was done, but I think they did to this point, have done a really good job innovating and being creative about that. Next thing I wanted to talk about briefly was vaccine delivery and use, COVID-19 and influenza. I'll just touch briefly on influenza. We're having a mild influenza year this year. We thought we would quite likely have a mild year because we usually follow the Southern Hemisphere. When the Southern Hemisphere has their season first, we oftentimes follow suit. There's been a tradition for decades. And this was no exception. But also this year has been an unusual year because of the fact that we're doing these other anti-contagion measures. People don't go out as much, they don't congregate as much. They've had smaller family gatherings, mask wearing and the like. So I think I think we're going to be blessed this year to have less influenza. It's but we still need to encourage influenza vaccination. And one of the reasons, of course, is that we always, every year, have influenza-related hospitalizations. And this would not be a year that we would want to have that. Our hospitals are to the brim already and throughout our state. So we're pushing very hard again and have had a very aggressive campaign for encouraging influenza vaccine. And I think it's working. COVID-19, we are just getting ready. We're on the precipice of opening up a big new can of worms with the COVID-19 vaccine. And I will say that we have and if you look at our website, we have the plan. It's on the second page of our website that you can go through and read the plan, CDC and Operation Warp Speed approved, because we're next week are going to get our first shipment of COVID-19 vaccines. It could come even toward the end of this week. And it looks like, one, it's the same story that we've had throughout this pandemic and have wrestled with, and that is shortages of everything. You'll recall the last time we met, we talked a lot about PPE shortages, and that is not as big of a problem now as still potentially could be. Testing was very much in short supply early on. So in the continuing theme of shortages, we will not have the vaccine that we would like to have in vaccinating every Kansan, or at least every Kansan who chooses to be vaccinated. Our first one is going to be Pfizer, which is the one that requires ultra cold storage, which is a 70 below 0 centigrade transport, which is very, very challenging. We are ready. We have pre-positioned locations. They meaning the federal government, in the process of shipping that out. We will have probably right about 24,000 doses in the first shipment that comes to us. By the end of the month, we hope to have about 150,000 doses of vaccine, both the Pfizer and then the next one that on the heels that should be approved, the Moderna vaccine. The Moderna is going to be a lot easier for us to work with because it can ship directly to the people who are going to do the vaccinating, and it doesn't require anything other than routine freezer storage. I was on a call very early this morning with the White House team, who is starting to sound optimistic for the third and fourth ones. The AstraZeneca one developed with Oxford University in England, and then on its heels, Johnson & Johnson vaccine. The AstraZeneca is, again, just like the other two I mentioned, is a 2-dose series, 3 or 4 weeks apart. The Johnson & Johnson, if it goes through the rigorous review process and approval, is a 1-dose vaccine. So one of the challenges is if somebody gets dose 1 of one vaccine, they have to get the second dose. The booster dose has to be the same one. And that provides some challenges, but I think we're going to be able to navigate that. The thing that I think that we can, we feel, of course, is that people are wondering what phase of the sequencing of this and that we're going to give people. Where do they fit in? We don't have the final word from the Advisory Committee of Immunization or Advisory Council of Immunization Practices of the CDC. They'll have a lot to say. We can fine tune that at the state level. But I think pretty clearly phase 1 are going to be healthcare workers that regularly work with COVID-19 patients. We will also in that first phase have nursing home residents, skilled nursing, group and congregate living settings and the like, a most vulnerable population, because again, the goal is to not only immunize the people that are the most likely to become ill, but also the most likely to require hospitalization and death, and then those who are taking care of those individuals. And then also in phase 1, which by the way, will take us probably into mid-January, depending on the supply chain that comes to us, healthcare workers that are maybe not on the front lines with specifically COVID-19 patients, but healthcare workers in general. So that will be there's not much controversy about who will really be in that first group. The second phase will likely be the essential workers. And we're working through that now. Who are the essential personnel? Who are mission critical personnel? Will be there. And then in subsequent phases that will probably take into the spring and summer will be people that are older than, for example, 55 and older, particularly those with chronic underlying conditions. People that are older in the next one without underlying conditions, and then finally the general public. So in summary on the vaccine, we're geared up for receiving and then distributing through, in some cases, our own personnel out to the people who are registered to vaccine. We also will have a very tight partnership, and this is especially true with the skilled nursing and the nursing facilities with two industry partners, and this is a nationwide agreement with Walgreens and CVS. So that'll be something that bears watching. A lot of the people on Medicaid, on the KanCare program, of course, have underlying medical conditions and will be some of the earlier on in terms of the sequence and priority. Third thing I wanted to mention, and this has been a continuous emphasis of ours, is the COVID-19 testing expansion and management of the results. We've fortunately, I'm sure you've been watching the news, we've gotten CARES Act money come through the Spark committee and have now a very aggressive process in place. And I'm going to show you or talk about a slide in just a minute, but not quite yet, that we brought on contractors and that will help us to distribute throughout the state. NIC USA, which is a Kansas company, Well Health. We have added on since the 4th of December until tomorrow, actually, I think 17 or 18 new testing sites. We already had about 50 testing sites around the state. We're going to be adding another probably 15 in next week. And then by the end of the month, hopefully to have 50, because of this additional enhanced testing that we're putting out there, testing sites, about 55 more. It's been a real challenge because this involves places where people go to have the sample procured, and then the samples have to be shipped to labs. Again, the goal is to shorten, not only to broaden our testing, so certainly that everybody that has symptoms can be tested the same day as they find themselves having symptoms, but also to shorten the testing turnaround time on the testing. It was getting, as you know, to 5 to 7 days out there. We would like to optimally have it 24 to 36 hours as the maximum. We are working with schools and some other settings with the rapid point of care test, which is the antigen test in the nose or occasionally in the mouth. And so it's a real assortment of ways that we're procuring the samples and how they are interpreted. And we try whatever we can do to keep it from getting confusing. We've had to develop a website actually to where people can they can sign on, put in their zip code and find out where testing sites are. And in some situations, we've been building this so quickly. I mean, adding 55 new testing sites has not been easy. And a good example is Crawford County. Yesterday, the testing site was there before people even, the local health department and the county leaders knew and could guide the populace as to how to access that, because the pop-up site that this particular contractor of ours did, Well Health, just they got ahead of the promotion of it. So we're trying to build it as quickly as we can, and I think it's actually going quite well, and is being very productive. The numbers are going up dramatically in terms of number of people being tested. Point number 4, and by the way, each of these is an hour-long presentation. I'm trying to keep it as short as I can, Madam Chair. Novel therapeutics. Suffice it to say that the remdesivir, which is an antiviral, we've gotten that well in hand. It's out there in every hospital and clinic that wants it. You remember hearing about the antibodies, Bamlam, Inivab, and as well as the antibody cocktails are the Regeneron, like the president got when he was hospitalized. We now have those coming in and are pushed out, high utilization of those. One is to prevent people from being hospitalized One is to treat people that are hospitalized in order to hopefully prevent worsening. I was on yesterday, 2 days ago with the hospitals, and they're content with where they are in terms of the novel therapeutics. And this morning I was on the early call with the doctors that run the critical care. I think we're in pretty good shape there. Hospital capacity management. Again, I was on with big hospitals and health systems yesterday. And I think overall, everybody's holding their breath. We've seen an uptick after the Thanksgiving holidays like we predicted. And hospitals, you hear the term kind of overrun. Most of the hospitals are pretty steady right now and saying we're managing what we have, but we're not, if we had to increase by 10% of a surge, we'd be really struggling. And the last time we got together, we talked about the need to build tents or solid walled facilities, and we decided not to. And the reason was that beds weren't the limiting factor. Staffing, we predicted, was the limiting factor, and that has become true. Staffing has been the limiting factor, so we've done everything we can to augment that through temporary staffing agencies, through the emergency operations centers and the like, but we're competing with everybody in the country because everybody has the same problem we do about that. But to get at that, I'd like to move on to my final point, and that is mission control. Much like what you heard from Dr. Hughes and from Mr. Jordan, one of the things that we look at this pandemic and say, what can we learn and what can we build that will be lasting and improve things even after we get through the other side of this. And one of the things we've done, there's a Cheyenne Mountain Software is a company we've worked with. They're not new to Kansas. And mission control is their application. One of the problems that particularly the rural hospitals and critical access hospitals have had is when they get somebody that needs to be transferred, I call it dialing for dollars. They get on and find themselves making 8, 9, 10 phone calls to try to find a bed someplace in the state for that patient. The mission control that's a trade name, by the way. They had a minor presence in the state of Kansas. We have gone into an agreement with them to provide their services to every hospital in the state of Kansas. So in rather short order, they've increased and onboarded 80 plus hospitals now, and we'll get to 135, hopefully within the next couple weeks, where people do exactly that. And imagine the ease if you're an emergency department nurse, for example, in Colby or Norton or wherever, to make one phone call to mission control. You get a live breathing person on the other end who says, what does the patient need? And they get the essential information. After they find the bed that meets that patient's needs. They arrange transportation, which is, by the way, the local transport companies. We're not trying to skirt around local EMS, whether it's ground or air ambulance. And it has been a godsend for the people because that way the emergency department physician or nurse can go back to their work rather than having to spend 6, 8 hours or even having a patient die in their emergency department awaiting transfer. They're very enthusiastic. I'll have a meeting with the smaller hospitals next week again to hear how it's going. This will remain. This mission control, it is really about how do we transport patients that need typically a higher level of care. Final comment, back to my earlier comment about finding enough beds and staff. Also, the same mission control can repatriate those patients. One of the characteristics of COVID-19 patients is that they have long hospital lengths of stay, but they always, oftentimes they don't need to have critical care for the entire length of stay, but might have 6 or 8 more hospital days where really all they need is basic nursing care and oxygen treatment, for example. And they can go back to their referring hospital or to a skilled nursing in their same area or to a different hospital, but getting them closer to home. But it also decompresses the tertiary care and referral centers so that they get more of an opportunity to free up those beds and to utilize their staff better. In other words, load leveling across the state. And it's also, to be honest with you, it's a good source because a lot of these hospitals aren't full and they've got enough staff. They just don't have the right kind of patient because they can't take care of those critically ill COVID-19, or not even just COVID-19, but cancer or heart disease or trauma patients as well. Last thing I'll leave you with, and I'll open up for questions if that's what you'd like to do, Madam Chair, is I do worry, and I'm working with our trauma committee. We are experiencing blood shortages and and a little bit of concern about the trauma critical care, just because those beds are being filled up with COVID-19 patients, but most acute is, and we need to push on, is to try to increase the amount of blood donations in the state. So some of this comment, not specifically Medicaid related, but I think a lot of the Medicaid patients are some of our most vulnerable populations, so I think fit into all these concerns that we have. So with that, next, oh, I have one more slide to show you this for fun. And that's slide number 4. It's the colorful one that has the state of Kansas map. Some of these names will not be familiar to you, some will. In order to increase our testing, we've gone into, when you see vendor, the NIC USA and Well Health are the ones that are providing the most number of new testing sites. Clinical Reference Lab is a lab that we, in Kansas, Lenexa, they've been here a long time, very large capacity. Wichita State, we've helped them not only with their equipment platforms, but to increase the amount of samples that come to them. One of the things we found is that we've had a lot of lab capacity, but sampling the patient themselves and then couriering, taking the samples to the labs has been a real challenge. Sinochips is a local company that sprung up out of the KU health system, and MAWD, M-A-W-D, is a clinical reference lab also in Kansas City on the Kansas side. So we've tried to favor the local businesses, I'm sorry, the local laboratories, but the NIC USA and Well Health were some of the things that help move the samples, to sample and move those samples around the state. That's my last comment, Madam Chair. Happy to answer any questions or if you wish.
Committee questions?
Madam Chair, this is Senator Petty.
Go ahead, Senator Petty.
Dr. Norman, thank you for being here. I just want to make sure I understand. So when I see on these on the slide 4, when it says pooled and then it says unpooled, does that, could you confirm what pooled and unpooled means?
Yes, that's a good question. Pooled versus unpooled. In low risk settings, and a great example was when KU or K-State students came back, if the likelihood of being positive is low, what we will do is have saliva from 5 different people in one test tube, and it's tested, and if it's negative, all 5 people are negative. If it's positive, then they just go back to the original 5 samples to test each of the 5 to find out which one or more of those were. It's just a more efficient way of testing a broad group of people. For example, you can test 25,000 people a whole lot easier when you're doing pooled samples. If somebody's symptomatic, we would never do a pooled sample. It would just test one person,
and
just for efficiency.
Thank you. And is that more likely that would be used as the example you gave us, when you have a group, a younger group that's not as likely to have pre-existing conditions?
It would be mostly about the incidence or prevalence of that group. If they're fairly low risk, we would do that. Anytime there's symptoms involved, we test that person individually. It's for screening populations that are at low risk.
Thank you.
Representative Carpenter.
Thank you, Madam Chair. Dr. Norman, thanks for being here. Good talking to you again. My question revolves around testing and whether you're able to tell how long ago they've had the COVID, the virus. Are these testings all new cases, or someone had COVID back March, May, April, whenever? They're still going to test positive for the disease, is that right?
Yeah, I might have missed a little bit of that, Representative Carpenter, but I think I know what you're asking. People that have the disease will eventually test negative, but on the back end, after they're clinically resolved, they can still have viral particles in their nostrils for a number of weeks. We have probably the best study has shown that they can even be up to 30 to 60 days. They're not felt to be infectious at that time. We don't recommend that after a person is clinically better from COVID-19 to even bother testing, because the PCR testing, depending on what the cycle threshold and whatnot, they'll pick up the viral particles for quite a period of time. Related question is, we are starting to see some people that are clearly infected a second time, but usually that's by quite some number of months with an intervening period of normalcy.
Okay, very good, thank you.
Any further questions? All right, seeing none, I guess we're ready for the members up next.
Yes, moving on to Sarah Fertig. Thank you, ma'am.
Thank you, Dr. Norman, and thank you, Madam Chair. Sarah Fertig, State Medicaid Director, KDHE. My portion of the presentation starts on slide 5 of our slide deck, which provides kind of a roadmap to the topics that I'm going to be addressing. The first of those is the update on the Healthcare Access Improvement Panel, or HCAP for short. And on that slide, I provided a little bit of background information in case you'd forgotten it. But in 2019, KDHE submitted an 1115 waiver amendment proposal to CMS that would have increased that provider assessment to 3% and would have expanded the scope of the assessment to include outpatient services. We found out in May of 2020 that CMS would not be approving that proposal. So after that, we were trying to figure out next steps. What can we do? And we've had a number of meetings with Kansas Hospital Association, and they put us in contact with some outside experts to help us decide next steps. And those are listed as number 1 and number 2 on the slide. Essentially, the step 1 would be to ask for CMS to make a technical correction to our budget neutrality calculation, which we believe currently underestimates our budget neutrality limit by about $395 million. And then if CMS approves that, then we would circle back with KHA and figure out what percentage increase to the HCAP we could possibly afford. And then we would circle back with CMS and ask for approval for that percent increase. We submitted our technical correction proposal at the end of September, and we heard in early November that CMS was reviewing the proposal. I don't know yet if it has been approved, but we did have a brief conversation with CMS about it, and it was a very positive conversation. And my other update on HCAP is just that we continue to monitor the program. And Madam Chair, if there's any questions about HCAP in particular, I'd be happy to stand for them.
I think go ahead and go through your presentation and then we'll come in the end, please.
Will do, thank you. So moving on to the following slide, that would be slide 7. I alluded to this earlier this morning in our issues log update. This relates to the regulations related to the protected income limit. Earlier this morning, I received confirmation from the Secretary of State's office that our regulation would be published in the December 17th edition of the Kansas Register. It will take effect 15 days after publication, so we are on track for an effective date of January 1, 2021. So we will have changed that so that the protected income limit for HCBS consumers will be $1,177 a month. Moving on to slide 8, our update for KanCare Kansas. So as of December 1st, we had almost 900 members enrolled. We have 37 providers who are participating in the program. We have 581 members who are enrolled as part of the asthma population, and a little over 300 members enrolled as part of the SMI population. And we've begun our 6-month audit process. These were audits that we're required to conduct in accordance with Senate Bill 66, which requires us to measure outcomes and effectiveness of the health homes program known as KanCare Kansas. And in response to one of the questions we received in September, we included a link to the audit tool itself. It's publicly posted on our KanCare website, so anybody can see what we're auditing for there. And essentially, we're looking at the program structure, whether care guidelines are evidence-based, whether staffing is sufficient, that sort of thing. Pretty common audit issues to look at. And we've been doing monthly provider implementation calls. So far, everything has been very well received from our KanCare Kansas partners, and we're continuing to engage with them to figure out ways to increase our program population and participation in this program. So those efforts are ongoing. Moving on to slide number 9. Slide number 9 and slide number 10 are updates on our Disability and Behavioral Health Employment Support Pilot Program. Slide number 9 mostly includes background just for your information. This was a program that was included in our 1115 special terms and conditions. And the waiver or the pilot will operate for this entire waiver period, which is calendar year 2019 through the end of calendar year 2023. There were some delays in implementing the program as we've discussed in prior Bethel committees, but we're moving forward with this. We work with an advisory board to provide guidance on program design and implementation. And moving on to slide 10, here's our updates since September. As I mentioned earlier this morning, we're in the process of recruiting 2 new benefits specialist positions who will support the pilot, and also a program manager to help make sure that the program is running smoothly. We've executed a contract with a subject matter expert to help us with an implementation plan. And the contractor will also help us write a program manual so that when our go live in July 2021 is here, that we'll be able to hit the ground running with this program. And our contractor began work in November. At our last advisory board meeting in October, the group decided to break out into smaller work groups to assist on some particular projects, such as an assessment tool for the program, outreach strategies to try and identify individuals who might be interested in the program, and that sort of thing. See, moving on to slide number 11. These are some recent highlights. This is where we begin our section on the COVID-19 update specific to KanCare. And this slide focuses on some recent highlights. And we were pleased to find out that we received Spark funding approval to continue providing coverage for CHIP and M-CHIP beneficiaries who age out of the program during the pandemic. For those programs, aging out means that you turn 19. So we received approval a couple days after the last Bethel committee to use Spark funding for that. So that was exciting news for us. We have been receiving a lot of questions on Medicaid coverage for COVID testing and for COVID vaccination. So we have some information here. COVID-19 testing is covered by Medicaid as long as we have an order from a qualified provider. And we provided a link to the bulletin that outlines that coverage on this slide. And the COVID-19 vaccines, when they do become available for our beneficiaries, they will be covered by Medicaid. There is some question as to how we will cover it. Typically, our vaccine reimbursement structure is that we pay the vaccine administrator for the cost of the vaccine and an administration fee to go along with it. There has been some talk on the federal level about the feds possibly providing these vaccines at no cost to the states. And if that's the case, then the cost of the vaccine will be zero for the provider, and we'll reimburse them for the administration fee. So that's kind of TBD, but we will be covering it. Other important news is that U.S. Health and Human Services Secretary Alex Azar extended the public health emergency through January 21st, 2021. This is very important from a Medicaid standpoint because under the Families First Coronavirus Response Act, we are eligible for an increased 6.2% federal matching funds for Medicaid through the end of the quarter in which the public health emergency ends. So currently, we are eligible for that increased 6.2% federal funding through the end of March 2021. And we don't know if the public health emergency, or PHE as we refer to it, if that's going to be extended beyond January 21st, 2021. If it is, and if it extends past March 31st, then Kansas will continue to be eligible for that increased federal financial participation through the end of the fiscal year. And I can tell you in our supplemental response document that we provided to the committee, we were asked to provide some numbers for what that has meant for Kansas so far. And it is pretty substantial. Through the end of calendar year 2020, the projected SGF savings due to this enhanced federal financial participation is about $255 million. that is that much fewer SGF that we are spending because of this increased federal participation. And currently our estimates through the end of March, when currently we're scheduled to stop receiving that increased federal money, our estimates are roughly $325 million that are projected to be SGF savings through then. So this has been a tremendous boon for the state. Now, in exchange for that increased federal financial participation, the state was prohibited from discontinuing eligibility for Medicaid beneficiaries, except in basically 3 circumstances. If the beneficiary voluntarily asks for their eligibility to be terminated, if they cease to be a resident of the state, or if they become deceased, which is essentially another way that you cease to be a resident of the state. So there is a cost associated with that. And I think Chris later on will talk about how our enrollment numbers have fluctuated because of that maintenance of effort requirement. But the amount of money we're drawing down from the feds as part of the increased federal financial participation far outweighs what we're spending to maintain those beneficiaries. So this has been a big net boon for the state. And then the last bullet on this slide just relates to our ongoing discussions about telehealth. I really appreciated David Jordan's testimony earlier and their efforts to help us figure out the telehealth puzzle, but I would echo his comments that we've received very positive feedback from providers and from advocacy groups and from the MCOs on the utility of telehealth. So I think that has been an exciting development in Medicaid and one that perhaps wouldn't have moved this quickly if it weren't for the pandemic. Let's see, moving on to the next slide, slide 12. A lot of this is basically the same information that we provided in September. We're providing it for historical context and to give you a full picture of everything that KDHE and KDADS have done since the pandemic start to make sure that Medicaid keeps functioning and that our beneficiaries are able to receive the services that they need. And then moving on to slide number 13, these are some of the additional special authorities that were exercised. The last bullet on that slide involves the additive appendix K, number 4. Amy Penrod provided you an update on that, so I won't belabor that point. But yeah, CMS essentially confirmed that these were services that we were within the scope of our state plan under EPSDT, and an appendix K isn't necessary. So we continue to work with CMS to figure out what we would need to confirm and solidify their approval of that. Moving on to slide 14. This is, again, mostly just information that we provided from the last time. Again, just to provide you a complete historical overview of what we've done. I will add on the first bullet that CMS issued a new rule in October that allows states certain flexibilities when it comes to the maintenance of effort requirement. And these new flexibilities, we plan on implementing them, but they're not going to make a tremendous amount of difference on our enrollment numbers. For instance, starting in late October, we are allowed to discontinue eligibility for a beneficiary who is convicted of Medicaid fraud. That had been left out of the Families First Coronavirus Response Act. And as CMS put it, these are kind of common sense things that state Medicaid programs should be allowed to do. So they agreed with us that that was something that was consistent with the FFCRA. So there are some new flexibilities that we have, but we don't expect that to make a tremendous impact on our enrollment list. Slides 15, 16, and 17 are screenshots of our KMAP website that lists all of the bulletins that we've issued since the pandemic began. On slide 16, I would note that bulletin number 20088, reimbursement to providers and facilities serving the uninsured. That is a new bulletin since September. So this is something we continue to update. And then moving on to slide 18, some analytics and performance metrics. The first slide, slide 19, shows enrollment by plan. Now these are numbers as of October. So showing that from October 2019, we had about 385,000 Medicaid beneficiaries and Medicaid and enrolled in a MCO. In 2020, in October, that number had increased by about 20,000. So that shows the effect of the maintenance of effort requirement. It's now closer to about 425,000. So our numbers do continue to go up. And the distribution across the plans has remained pretty steady over the last 2 years. On slide 20, this shows the claims processed and the amount of claims that have been denied across the 3 MCOs. And one thing that's notable here over September is that the percentage of pharmacy claims that have been denied has increased slightly over this time last year. However, I would also note that due to the dip in in-person services that we saw in the spring of 2020, pharmacy claims are now making up a larger share of the claims themselves. So that could have something to do with it, but those numbers are otherwise staying pretty steady. Slide 21 shows total year-to-date claims compared to year-to-date denied claims. And these numbers, again, have remained pretty steady over the years. Pharmacy is consistently the highest category of denied claims, and that's because it's a point of sale service. And sometimes it takes a little while for eligibility information to push out to those systems. So that's not a surprise to us. And as is typical, inpatient claims are the least, have the least amount of denied claims. Slide number 22, we talk about clean claims processed within 30 days. Our contract requires the MCOs to process 100% of clean claims within 30 days. And you can see from the calendar year 2019 information, between that and calendar year 2020 information, Aetna has made a huge improvement on their clean claims processing. So that's very good news for us. And all of the MCOs are almost, if they're not at 100% on this measure, they're very close to it. So that's good. Slide number 23 shows the percentage of all claims processed between 60 and 90 days. And you can see that Aetna is making progress on the 60 days, and all the MCOs are either at or near 100% compliance for 90 days. So we're doing pretty well on that. Slide 24 concerns member grievances. And these are the resolved member grievances to date, well, through the end of the third quarter. You'll notice that in the second quarter, there were fewer member grievances resolved, in part because we had fewer member grievances received. We saw a dip in a lot of activity in the second quarter of 2020. That was when a lot of people weren't doing very much and a lot of in-person services were suspended. So that's not a surprise to us. And you'll see similar information on slide 25. These are the member appeals, and you'll also see that dip in the second quarter. Again, that's not surprising to us. There were fewer appeals filed in the second quarter, so this isn't a tremendous surprise. And the top categories of member appeals these are also, again, fairly consistent. Criteria not met for pharmacy. That's, for example, are cases when a prior authorization for a non-PDL drug is denied, something like that. So this is all pretty consistent. And then moving on to slide number 26, these are the provider appeals. And we ask that these be resolved within 30 calendar days. And you can see that we're doing pretty well on that. We had a little bit of a dip with Aetna in the third quarter, but that's something that we will work with them on. And resolved within 60 calendar days, all of the MCOs hit 100% for the second quarter of 2020. So that's good to see. On slide 26, this is where we have our customer service center data showing members' experience with customer service center. One thing that stands out to me is the low rate of call abandonment, which suggests that members are not getting frustrated and hanging up rather than continuing to wait. So those rates are very, very low, and they're consistent. And on slide 28, we see similar results for the provider experience for the call centers. Again, a very low average call abandonment rate. And these numbers have been pretty consistent across the MCOs as well. Finally, the last slide for me before I turn it over to Chris Swartz is slide number 29, where we show the MCO profit and loss per the NAICS filings. And you can see that the average third quarter profit across the 3 MCOs is about 2.9%, which is about where we thought it was going to be, given the dip in some of the service delivery that we saw in the spring of 2020. And Madam Chair, I'm happy to stand for any questions. Otherwise, if you'd like to turn it over to Chris Swartz, it looks like she's ready to go.
All right, Committee, are there questions? Representative Carpenter.
Thank you, Madam Chair, Director. Thank you for being here. Quick question, just to refresh my memory. Waivers are not included, HCBS waivers are not included in the 6.2%.
No, they are.
They are?
They are. Yes, they are.
So this also covers waivers for the
Yes, we're receiving 6.2% federal medical assistance percentage, FMAP. That does include the HCBS waivers. And although I may have neglected to mention it, there's also a secondary effect, which is that our increased reimbursement rate for CHIP is also up by 4.34%. So we're drawing down a tremendous amount of federal money and avoiding spending SGF, thanks to the provisions of the FFCRA.
Thank you.
You bet.
Any further questions? All right, seeing none, thank you very much, Sarah. It looks like we're ready for chair. Christine, excuse me.
Madam Chair, members of the committee, good afternoon. I'm Chris Swartz, and I will thank you for having me. My updates are going to focus on 4 different areas, and my presentation starts on page 30 of the KanCare update for December 2020. The 4 areas are the Medicaid eligibility application status, the federal facilitated market open enrollment status, the transition of the Medicaid application eligibility processing of elderly, disabled, and long-term care application to the state, a status on this, and that will probably be kind of the last status update on this since it completed and we are at the end of the year now. And finally, status on the clearinghouse RFP and new contract. So starting with the Medicaid eligibility applications, I must say that I have really good news. We have 4,546 applications in-house currently. Only 89 of those applications are over 45 days. Of those 89, we can only work 31 of these. The other 58 applications are pending some kind of information needed either from the beneficiaries or a bank or some medical representative. So we are in a really good place for the application processing, and we are definitely meeting the federal requirements of processing within 45 days, and we do not have a backlog in that area. Now, this is pretty impressive considering that from the federally facilitated market open enrollment to date, we have received, and it started November 1st of 2020, will end in December, on December 15th. To date, we'll receive 9,730 applications from the market. And on the slide, that is slide 32, there is a breakdown of the kind of composition of these applications. So about 5,700 are in the family medical area, 2,800 are into the elderly and disabled, and very few, 196 of them are in the long-term care area. 887 have not been registered yet, and we do not know in which category they will be filling, because that's what happens at the time of registration. It is interesting to note that these numbers represent about 73% of what we had received last year at this time from the market. So there's about a 37% downturn and we don't know what the reason is. It could be that we're not discontinuing people because of the other requirement of in order to qualify for the 6.2%, we have to continue carrying people Medicaid eligibility. So there may be less people applying at the market that may have dropped, naturally if they were under other circumstances. So it's just interesting. We're monitoring it, but it also is not the end of it. And sometimes you have a lot of people applying at the last minute. So we're just kind of holding our breath and just monitoring the issue. Next, my updates are going to be on the transition of the workload of the processing of application for elderly, disabled, and long-term care to the state. So we completed the transition of training and quality functions in July of 2019. And so we've operated more than a year now with the training and the quality being under the responsibility of the state. And that is training and quality across the board, not just for elderly and disabled. The state wanted to take control of the policy training on all applications. Then there was a transition of the responsibility of the determination of eligibility for elderly, disabled, and long-term care that was completed in January of last year. And we committed to report on that area for another year to see how things were going. And I'm pleased to report that it's going very well. We're at the end of the first year now, and our numbers are looking really, really good. Our staff continues to answer the phone, answer the eligibility questions, and we're continuing bi-monthly meeting with the Nursing Facility Association stakeholders to continue, communication in that area and to make sure that if there were anything or any red flags, that they would be escalated to the state, immediately. And then we would use these meetings to find solutions to the issue that would have been raised. The table under is just kind of basically a list of the different timeline at which point the programs were transferred during the time that ended to the final transition in January of 2020. So I won't spend a lot of time there. We'll give you a quick status update on page 30, slide 34 on the status of the staffing at the clearinghouse. Our target, ideal staffing, is 313 people split into the different areas. We do have 55 vacancies, and we're continuing to be very diligent in trying to get some qualified people to do the processing of the applications. In addition to the 55 current vacancies, I also have at any point in time about 30 staffs that are out for COVID-related issues. Either they are in a quarantine, or they are themselves sick, or they have some childcare issues. And on top of that, of course, I would have the regular, people that are on vacations and, regular sick leave and all of this. So all in all, we're operating at about 29% lost capacity. But we've put some mitigation processes in place, and we've been able to sustain the requirements of processing everything on time and not creating backlog and a burden on providers. So that's my update on the staffing. And then if you may indulge me, I would like to just have a big shout out to my eligibility staff for the extraordinary efforts that they made. They put up with long days, long weekends, frequent and last minute changes to their schedule in order to maintain this level of production, and at the same time make sure that the state would qualify for the $315 million that we're going to be receiving by not discontinuing people. Now, it looks simple to not discontinue people. However, you need to understand that our systems are made for program integrity, and they're made to actually get the people that are no longer eligible for things discontinued. So every month, they have to actually go and fool the system to make sure that these people that under normal circumstances would have been terminated have to actually continue. So a huge shout out to them. Also, I'd like to give a big shout out to the rest of my staff and Sarah's staff that are continuing to monitor the ever-changing directives that we're receiving from CMS and the new opportunities that are offered. They're performing analysis to identify if it's applicable in Kansas, And then they're securing the necessary approvals to make sure that we get permission to actually implement in Kansas if we deem it to be beneficial to Kansas. So all in all, I would say that we have a very dedicated staff that have the interest of all of the stakeholders, providers and beneficiaries at heart, and have all risen to the occasion to effectively support the program in very difficult times and have been very successful at it. Then I will continue with an update on the clearinghouse contract. As you know, I reported last time that a new contract was issued after the competitive procurement that we issued fall of 2019. The new contractor is Conduent, and the contract was awarded in August of 2020. And since then, it has been a sprint to try to get this all implemented in 3 or 4 months. The contract was awarded in August, but the time to protest the award didn't expire until middle of September. So work couldn't really go full blast until starting the middle of September. The new contractor will begin processing family medical applications at the start January 1st of 2021. Now I want to emphasize that this is just the family medical applications. I have had a lot of questions about whether or not we were contracting out again processing of applications for elderly and disabled, and if that contractor was involved in this. The answer is no. Processing of the elderly, disabled, and long-term care application remains the responsibility of the state. We've worked really hard. The legislature gave us some funding to do this and be successful. We have been successful, and we have no intention of dismantling something that is super successful right now, unless we're told otherwise and asked otherwise. But that is not the plan at this point in time. So Conduent will be processing a family medical application beginning of January. The delays in the contract, most of them have been mitigated. The two big at-risk area are facility setup, because it requires, remodeling permits and executing the work after you get the permit and all kinds of different things. We have a mitigation plan for that. We found some office space at the state that we could loan to the contractor until their facility was ready to be ready for their staff. They also have some of the most seasoned staff, because they are pulling from the Maximus pool on recruitment, work remotely. And those staffs are already used to working remotely, because that's how the current contractor has part of their staff working. And then the other big focus concern is staffing and hitting target staffing for January of 2021. So it looks like at this point in time, we're going to be about 17 to 20% lower than the target capacity. So we're targeting about 307 staff, and we think we're going to have only about 250 and 255 if the recruiting processes remain, the same as what we've experienced up to now, but it may change, with more people being out of work, or anything like this. So we're just monitoring that very carefully. We're working very closely with Conduent. They have been very engaged in multiple planning for this transition. Maximus has been extremely engaged too, and very helpful in suggesting, certain areas that we may want to pay attention, and because they were part of the transition earlier and are sharing their experience, and lesson learned from that. So everybody is on a really collaborative level at all levels, the state and the two contractors at this point in time. So things are going really well in that area, but I am expecting a rocky start for the new contractor. And we have mitigation plans in place where for a period of time, the state will be kind of stepping in certain areas so that applications don't get too backlogged and everything else remains on a steady path. And I think this is the end of my presentation, and I will stand at the appropriate time for questions.
Questions, Representative Carpenter.
Thank you, Madam Chair. Chris, thanks for being here. Chris, you know, many of us at this table here went through quite a deal with Maximus and underperformance. Are you comfortable with Conduit as a new contractor? And what kind, I think furthermore, what kind of remedies do you have in your contract for non-performance?
So at this point in time, and I've been working with them since September, I'm very confident with their ability to respond to our request and work with us on finding solutions and coming up with resolution on a lot of the issues that have been raised and the challenges that we have to surmount because of that very tight transition period. It is a lot to transition in 3 months. In the contract, we have some performance service level agreement is what we call them, where they are required to maintain certain level of production. We have reporting processes in place that actually helps us monitor that to make sure that we're not falling behind. We actually will be monitoring this daily. I have a little group that is already set up to actually look at that and daily monitor where we're at so that we can plug the holes whenever we can start seeing a gap, going in or discussing with the contractor. As far as starting to put liquidated damages or anything like this, they are in a contract. However, and they're there and we will apply them as appropriate. But I think we need to give them a chance for the couple 2 or 3 months to show that they can function and they will function. I think you're not going to get more production with a stick. I think you'll probably be better off with helping them out being successful, which will help everybody being successful. The state, the providers will benefit out of it, and the beneficiaries definitely. So that's the approach that we're going to be taking.
Well, thank you for that. And I look forward to working with them and making sure they do what they say they're going to do. So that's all I can say. Thank you.
You're welcome.
Any further questions? Seeing none, thank you, Christi. Appreciate it.
You're very welcome. Thank you.
Is that it from KDHE, I believe? All right. So now we're up to KDABs, and we'll start off with Secretary Howard.
Thank you. Thank you, Madam Chair and members of the committee. I'm just going to make a few opening comments here, and I apologize in advance. I need to step out for a few minutes at 3:30, and then hopefully I'll be back before we do the presentation. But I think as you've already heard, even earlier today, obviously COVID and its impact across our service delivery systems. Some areas very hard hit. Obviously, particularly within the nursing facility. Oh, sorry, I didn't have the mic on. Thanks, Amy. But it has continued to be, I think, a heavy lift for us as an agency. And I think one of the things that I'm proud of is really the balancing of the management of the COVID, with also continuing to move forward in terms of the delivery of services going forward. But continuing to execute the needed flexibilities during COVID. You saw the so-called super chart this morning from Deputy Secretary DeBoer that showed you a bit about the level of financial PPE and other resources going out to nursing facilities. We've also been a recipient of additional Spark dollars, which we're very thankful to the Legislature for. It's also allowed us to get grants out to community mental health centers and SUV providers. I think in total as an agency, we've distributed across all of our service areas more than $80 million in the Spark CARES dollars. So big lift from a contracting granting side, big lift from a payment side. So both lot of efforts on all parts, and so much needed support to keep providers moving, and again, to make sure, particularly for the most vulnerable populations, that we're doing all that we can do as a state to support that. I also wanted to just mention briefly, and Deputy Secretary Bruner will talk about this sooner. I think a few months ago, I was able to stand in front of you and talk about our state hospitals and talk about those as being entities that COVID really hadn't touched. But frankly, as the community spread has happened, and I think Larned was, the last hospital that began to get hit, and we're managing an outbreak at Larned now. Not as large as it could be, knock on wood, and I think our staff are doing a very good job, but we do currently have an outbreak at Larned. I think actually on this cluster list, I think 2 of our state hospitals may show up, but again, I think we're doing a very good job to identify it and contain it as it enters into those doors. And again, I think Deputy Secretary Bruner will talk more about that. You know, and I think partly, I just wanted to just say to this committee that, you know, our regular business is also going on. You know, we're continuing to, move waivers forward. Commissioner Penrod will talk to you about approvals on waivers, new amendments that are out there. Some of the initiatives that were very important to this legislature last year and to the governor relating to, for example, lifting the moratorium of sodomy. We're making progress in those areas, and you'll hear about that. And I felt like for about 3 months, it was COVID, and it's still COVID, but now it's COVID, and let's move forward the business. And I hope you'll hear that as you hear through the presentations today. I'm really proud of the work that people are doing to balance both of those things, while at the same time, frankly, managing our own outbreaks in our own central office workforce from time to time, and with really our teams continuing to work remotely. So I think really very effective work in progress. You'll hear a lot of details from my team, but I really just wanted to kind of make those comments to you and assure you that as you come into this legislative session, I mean, you'll see that, the progress made that you were really expecting to see made from the agency and in those key initiatives. So again, I'd be happy to stand for any questions now or later on at the end of the presentation.
Anyone have questions for the Secretary? I have a comment. It's actually a compliment because you don't always get this. It's like any other business. You always hear the complaint. But this report that Janice, kind of showed us earlier today, and she's taken back some recommended changes that we had, and we're real impressed with this. And then I believe there's another population that will get this same, similar type of report. This stuff is very helpful. I think Will Carpenter was pretty impressed with it as well. He's not paying attention.
I think it just got even to us as a point where it was so critical for us to know where the different resources were going. And especially like in the long-term care area, when you have so many different types of facilities, you have federally licensed, you have state licensed, you have some people getting federal testing supplies, others not. You have different pots of resources, and we just felt like it was just really critical that folks be able to see that facility by facility. So thank you so much for that feedback.
Well, they're going to probably get other questions again today because of the calls that we've been receiving, and hopefully most of those have been resolved, but it's also part of our job. But I just wanted to share that with you. So, he does listen to me every once in a while.
All right. Well, I think Deputy Secretary DeBoer will kick off the next part of the presentation.
All right. Thank you, Secretary. I didn't say that just for your benefit.
Well, honestly, a lot of thanks go to Georgiana Krell. I think you may remember she was our budget director for a while and moved around the agency a bit. So we asked her if she could help us with this. She said, sure, we have since named it the Super Tracker. So she's done a great job, let me tell you. So I only have one slide. I will be quick. It's slide number 5 on receiverships. I already shared this with you this morning. We are down one facility, which again, we are celebrating that. Good news. That one facility is Providence here in Topeka. So it will be our only remaining facility under the Secretary's receivership. If all goes well in late December, we will sell another facility in the next few weeks. But that's all for me. I will pass this on to Amy Kimmerer. Commissioner.
Okay. Before I ask for questions from the committee, and I asked you earlier this morning if we had any more come in, or looking at having any more come in, because some of the things I'm hearing from some of the facilities is that they've been made aware that there's lawsuits about ready to be filed because they didn't have the protection they probably should have had in 2016. So that's a concern that we're going to have to keep our eye on everything about.
Madam Chair, I just want to say, I know how it started, and it seems like once it started, it won't be fit. So I hope this is long-lived, but it sounds like maybe somebody is coming in. But it was amazing that we were able to really sell those, especially at a time when the market was up and down and up and down. I just want to say, he was out there hustling, I don't know, but I do want to say thank you, because that really saves the state from having to go into the real estate business. You know, and we do have a couple of hustlers. But I just want to but I just wanted to say that. I know it's an oxymoron, but that was good. That's really good. And sometimes, because when you don't do something, we're gonna let you know about it. So we're gonna also let you know when you do something well, and so we want to say thank you. That's quite a job. Thank you. Thank you.
And who do we have? Oh, we got Amy back. All right, welcome back to the video.
Thank you. My presentation will start on slide 7. And it starts with the HCBS waiver enrollment numbers as of October of 2020. The key points of the intellectual and developmental disability waiver is serving 9,102 individuals, while we have a wait list of 4,394. The physical disability waiver is serving 6,107 individuals, and we currently have a wait list of 1,872. Moving on to slide 8, I wanted to give you a little bit of information about where we're at with our waiver renewals and amendments and such. The physical disability, I think the last time we met, the physical disability and frail elderly waivers were still under consideration by CMS. Those were approved on October 26th. Each are authorized for a 5-year period with an effective date retro to January 1, 2020. Since the PD and FE waivers have been approved, we've been able to shift our focus to submitting some amendments to CMS to a few of our waivers that have been kind of a long time coming. First couple are CMS requested. One is unbundling assistive services. I talked about this the last meeting. This would take a single service and break it into 3 separate. So instead of billing assistive services, we'll have providers bill DME, home modification, or vehicle modification. We are also updating our HCMS waiver performance measures, lifting cap on specialized medical care, and addressing our provisional plan of care creation process. Those are things that are already in place. We just needed to get them added to our waiver. So for the above, for these amendments, KDOTS did begin a public comment period for these on October 15th. That comment period ran through the 30th, and we are currently evaluating those comments, and we'll be providing a response. And that response will be submitted with our amendments to CMS. Moving on to slide 9. This is the promised update on the community-based service final settings rule. I will say that Since our last conversation, we have moved all, I believe, of our settings, the 2,813 sites that submitted self-assessments have been reviewed by our team, and they have entered what we're calling the remediation phase. Providers that have areas of non-compliance will require remediation, and we are working with those providers to bring them into compliance. That will run, from we started in October, and the final rule is the deadline is March of 2023. On the slide, I noted that as of December 2nd, we had 50 settings deemed compliant. I would say as of yesterday morning, we had 60 settings deemed compliant. So they really are kind of snowballing and growing at almost daily. We're getting more settings and more settings approved. So I'm really pleased with the progress that has been made on that. On slide 10, you heard a little bit this morning from Leslie Anderson about administrative case management. I would just point out from the chart above, you can see that the administrative case management program is progressively serving more and more individuals, assisting them with completing applications and turning in appropriate documentation so that the eligibility workers will be able to process those in a more timely fashion. And then my last two slides are regarding the program of all-inclusive care for the elderly, or PACE. I gave you the current enrollment numbers. We currently have 696 individuals total in the state enrolled with the PACE program. And then the final slide just gives you the counties in which each of our 3 PACE providers are operating. That concludes my section of the presentation. I'll stand for questions.
Committee, are there questions of any? Pause for this. All right, seeing none, thank you, Amy. We appreciate it. Looks like Andrew Brown is up next. Welcome to committee.
Thank you, Madam Chair.
How long has he been on Zoom?
I don't know. Good morning. We'll see you on Zoom tomorrow the next day too. So I'm Commissioner Andrew Brown with KDADS and Behavioral Health, and I'm just going to provide you sort of a quick update. I know you've heard a lot already about our COVID-19 response, and a lot of this information is similar to the information that we presented at the last Bethell. I do want to just point out that we are continuing to work with SAMHSA and CMS at the federal level to try to hang on to those telemedicine flexibilities as much as we can. I think that's important for both the consumers and the providers of the services. So, and then on the next page, PRTF treatment facilities. So this is our regular update. Highlights are that currently on the wait list, we're at 108 individuals. That's down a bit from our last report. And 14 of those 108 were foster care, and that's down from 24 in the previous report. And our exciting news is that we've increased the number of beds by about 50 beds since our last report. So we've gone from 336 in June to 386 this month. And we anticipate those increases will further reduce the waiting list in the coming weeks. So hopefully by next month, I'll be talking about numbers that are going to increase.
Okay, I have to ask, where did you put these 50 beds?
They're in Kansas City. But I do, and I apologize that I didn't put a bullet point on the slide, but the Secretary did want me to talk about what we're trying to do on the case with the hospital. So We've been in discussions with 2 separate vendors to try and get our RFP sort of aligned and finalized and ready to go. We've sent that over to DFA just within the last week for them to give their initial review and feedback to us about what we need to make changes to. So my hope is that RFP will be on the street soon, possibly in the next few weeks. And then hopefully we'll be able to make an award by March. Both of the vendors that I've talked to and had lengthy discussions with have looked at the possibility of either including additional beds in that facility beyond what is required by the bill, or maybe adding on additional care beds as well. So I think there will be some expansion that will happen as a result of that funding. So I'm excited about that.
Well, that's good news to hear. So I just want to make sure that section out there in the Northwest wasn't being overlooked. And I know it's not something that could be solved on a.
Yeah. And we're also still looking in Bethell to see if we can get them licensed for 12 beds on the western half of the state. Still, what most people would refer to as simple Kansas, I think, but we are working on that. So we can part.
And I don't. You may not know the answer to this. Is do we have any idea how many of the beds are being utilized for KBC? Which is not strong.
I think right now it's about 30 out of 50.
Representative Carpenter.
Just a quick question. Isn't that what got us in trouble out there in Western Kansas? Was those beds together anyway in the start?
Yeah, well, so it does get a little tricky, but yes, like the issue that CMS had 3 or 4 years ago when their site visit was that there was intermingling patients between the hospital beds and the KRTF beds. In this case, we'd be talking about separate and distinct wings of the state facility. So it wouldn't be a problem with CMS.
Okay, thank you.
Yeah, CMS came in, opened up a can of worms, we're fixing that.
Yeah, we're doing our best.
That's great. Well, I'm glad to hear that. So you may continue.
All right. Well, I think that might be all I have for today. Yeah. I'm happy to take questions.
There's got to be someone up there.
Well, I don't know. You can see what I can do.
Okay.
Go for it. Reverend Carpenter.
Yeah, session's coming up.
We need to eat later.
Yeah.
Okay. Are there any questions with our folks out there on Zoom? All right, seeing them, thank you, Andy, and I appreciate to hear that we've got more beds. I'm going to follow up. Just one. Okay, when you say KCK, are you talking KCK or are you talking just in the Kansas City area?
Yeah, I would say it's the Kansas City area.
Okay. Is there a location? Is there a town?
It's Prairie Village.
Okay.
So Johnson County.
All right. That's a difference.
It is. All right.
Did KBC do those beds?
No, the beds are with TLC kids. Yeah, they bought a property that was adjacent to theirs.
Okay, I'm just curious. I mean, it didn't make any difference. No, yeah, she just couldn't do it.
I've seen that one. Does that mean that there's substantial growth or numbers in not being able to serve people or need more services that we need at?
So these are going to be additional beds. They were just new beds that were added to the system. So we should have increased accessibility as a result. So does that answer your question?
Yes, it does.
Okay, all right.
Thank you, Andy. Appreciate it.
Thank you.
Okay, so next up, it looks like we have Scott Bruner. And Scott, I thought you were zooming in.
Not today, Madam Chair. I asked about it for next week.
Oh, next week. Okay. Well, see, I don't always hear everything staff tells me. That's why they repeated it to me next week.
They have a lot of things going on, so I don't.
They do. No. Thank you all. Welcome. And thank you for
Happy to be here. My name is Scott Burner. I'm the Deputy Secretary of Hospitals and Facilities at KDADS. And my part of the presentation starts, I guess, on page 17. There's a couple of standing items that we report on to you regularly. And the first is on antipsychotic drug use and inappropriate antipsychotic drug use in nursing facilities. The chart that's on slide 17 is one we've seen the last 2 or 3 times since I've been doing this, because it's a national data set and it shows kind of the trend over time. But that isn't updated on a regular basis, and particularly now. So what I started doing at the last time that you all met on slide 18 is try to show you the pay for performance measure that the managed care organizations are working with or against or towards in their contracts, because we made this one of the performance measures in the MCO contracts for this round. So every quarter we capture this information, get it back to the MCOs to look at and gather, let them kind of measure their performance. So the quarter 3 row there in the table is new data since the last time you saw this report. And you can see there's movement around, it's in the same kind of ballpark of rates, but that's at least more current data on our current Kansas population than the national data source provides. Last time, I won't say month, but time is very relevant. The last time you all met, I also asked the MCOs to give me a little bit of an update on what they're doing, what initiatives they have in place. I didn't do that this time, mostly because it was late when I thought about doing it, and I didn't want to put them in a bad spot. And I don't think a lot of those initiatives have changed. There were kind of things that were in place, but we'd be happy to share that with you again if you think that detail is necessary. On slide 19, I want to give you, in the category of the agenda, it's updates on where we are, priorities and issues in long-term care. So I want to start on that theme with our survey activity and what we're working on. I don't want you to think that we're waiting for anything to happen because we're not. From a survey and regulation perspective, the environment's changed a lot with COVID. We talked about this over time. So I kind of want to give you a status of where we are today. And so what CMS, when they direct our activities, particularly on the nursing facility side, they've been fairly prescriptive in the activities that we can do for survey. And so in the QSO memo that we mentioned there, and QSO memos are the directives that come from CMS that tell state survey agencies what to do. What we're being directed to do is primarily perform on-site surveys in facilities within 3 to 5 days of identification of any nursing home that's got an outbreak on these 3 or more new COVID confirmed or suspected cases that comes across on a report that nursing facilities submit to through the CDC. That's what NHSN looks like. So that means when CMS tells us, CMS looks at the data that they're receiving from nursing facilities, identifies facilities that have these new outbreaks, and they give us a list then of facilities we need to go do an on-site inspection. And then we're also doing complaint surveys and some of the other regular activities, and I'll talk more about that in just a second. But I did want to call out those 3 to 5 day re-reviews as taking a significant amount of time, given the number of outbreaks that there are. So if you look at the chart that's on slide 19, this goes back to July, and then the blue bars are the number of federal infection control surveys that were assigned to do by CMS, and those are those re-reviews that I just mentioned. And the orange bars are an IJ complaint, so an immediate jeopardy level complaint. So something that we were told about that is something that puts a nursing home resident in immediate jeopardy. So we do go out and physically do a complaint survey around those. So you can see back in July, I mean, the bars were pretty small. A lot of our activity was because of COVID. But in the last month or so through November, the number of those 3 to 5 day re-reviews has just really shot up as the case rate has gone up across the state, across the country, almost every state seeing similar trends like this. So if you look at like the week of November the 23rd, that's either 70 or 71 re-review or 3 to 5 day surveys that we had to do. We get the list on Friday and we have to complete them by the following Friday, I assume within that next week. So we schedule the work, the surveyors work based on the list we get on Friday, and they start on Monday looking through that list. So it was 70 and then 63 and then 59. I don't know that this trend is going to, I don't know that it's a trend. I don't think the number is going to go down, but that drives a lot of work for our surveyors to do, taking away from other things that they could be doing, but it is a priority by CMS, and it is an important thing to do. So we're doing our best to keep up with those. The other comment about those 3 to 5 day reviews, that's the number that they provide us, or CMS gives us the list. We do check it to make sure we haven't been in there recently or within the prior week, so we're not going out. I won't say we're not going out to the same facility every other week, but we do try to make sure we're using our time efficiently. We're not retracing our steps too many times that more than is necessary. If you go to the next page, slide number 20, on the same kind of theme of what we're working on. So as of September 23rd, we completed all of the infection control surveys that we were required to do in adult care homes, both under House Bill 2019. So we required us to go out and do an inspection on infection control practices in every nursing home. And we did that. We also did infection control surveys in every state licensed facility as well. So that was complete in September. And so now our goal, or what we're looking towards, is when will our regular activities start to return in terms of doing annual reviews and things like that. So right now we're doing these 3 to 5 day re-reviews. We're working on immediate jeopardy complaints and doing those investigations in some special focus. We are trying to reprioritize facilities that are near their re-review deadline, so they're close to their year or so, where it's been over 15 months. So we're trying to catch those up as well. But COVID still looms large in the work that the surveyors do, but we are trying to get back to some sense of normalcy. On slide 21, the same kind of couple of bullet points for the state licensed facilities, and we're focused on annual licensure surveys, complaint investigations, revisits that are necessary. And we do have some new facilities that are coming on, so we're trying to make sure we don't hold that process up in the meantime. From there, I wanted to transition to talk a little bit about testing, and then that's on slide 22. Realize this is also the topic you asked me to talk about next week. And so I'll maybe walk a fine line of either saying the same thing that I'm going to say next Tuesday, or give you the report I've got in here and see what other questions you have so I can answer those next Tuesday. Happy to do either one. I kind of took some of the detail out of these slides just to speed them along. But so for testing machines in nursing facilities. So we talked, I think the last time, I think this had already happened by the time, last time we met as the Oversight Committee. Health and Human Services had sent testing instruments, we shouldn't call them machines, they're instruments, to nursing facilities of 2 different types. As long as that nursing facility had a CLIA waiver or had a certificate that showed they were qualified to do testing in their facility. There were 3 waves where those were delivered. It was kind of announced earlier in July or maybe in June, and then they were shipped after that. So I put the 3 waves of delivery there. We know that in the first couple of waves, there were some facilities that weren't included. And so there was a process to kind of appeal those for facilities that thought they should have gotten a machine that didn't. So that's the later November timeframe that's there. They were free to the facilities, and the final count of facilities that received them were 319 nursing facilities as of November 19th. We get a weekly report from HHS, CMS, and the White House on showing these reports. So I pulled this from the last one that I had. And that 319 should match the super tracker sheet. Although on the super tracker, we put the number of test kits that each facility received. So if you got one of these instruments, you needed the supplies and the kits to run through it to actually run the test. So that's the number that's on each facility is how many kits they got with their machine. But because they got kits, they also got a machine. So that would get to 319 facilities. That was a very long explanation for a relatively simple concept. So I apologize for that. I hadn't said it out loud before, so I worked through it on my own. So that's testing machines. Slide 23. So the problem with the testing machines were that not every facility got it, or nursing facilities did, but not other congregate settings. That was a problem. Other problem was that these were devices that were available, but their testing supplies and kits that you need to run the tests were in short supply, and you could only order replacements from the manufacturer, and they had backlog. So many facilities had an instrument to do testing, but no things to do the testing with the instrument. To help address that, the White House and Health and Human Services announced that they were buying a supply of what are known as Abbott Binax Now cards, which is a rapid antigen test, and buying those up and distributing them out to nursing facilities, assisted living facilities to kind of fill in the gap, bridge the gap. The other thing that was happening at the same time was the announcement of a testing mandate in CMS certified facilities that staff had to be tested on a frequency up to every twice a week. And so to allow facilities to do that testing, they needed the supplies and capacity and devices. So that these Abbott cards were part of that mix. So those started to be shipped. They're still shipped every week to a list of facilities. We get a report from HHS, the White House, and CMS saying how many Binax cards were actually shipped to each facility. And so the last bullet point there, 113,000 have been distributed to assisted living facilities. I got the number wrong on the slide. It's 135 assisted living facilities, and a little over 500,000 test cards were sent to 318 nursing facilities. That number moves a little bit. That still isn't getting a test kit to every facility that KDADS licenses. So there's still a little bit of a gap, but if we think of a universe of 700 or 720 facilities, this is getting out to 450 or so that are getting federally supplied, federally paid for testing materials through these two processes.
If I might. And I think you answered in your last comment. Okay, when you say 319 nursing facilities, that doesn't necessarily mean our assisted livings or any of those facilities. We don't know if they've gotten their kits, their machines to get the kits.
So the Abbott cards, the Abbott Binax cards are kind of a standalone. You get a box of them in the mail. Each one is individually foil wrapped. You open the pack. There's a swab and like a credit card. Well, there's a picture of it on the slide. You can see what so that opens up. You do the swab, a nasal swab to collect the sample. The nasal could kind of only use a sample from your nose. If you put the swab in this card, opens up, folds up, it opens up on a fold. You put the swab inside the card, fold it shut, drop a reagent on the card, and then it generates a test result that's a little bar that would be like a test. So you don't need a machine, you just need these cards. And so that was the benefit of a rapid test that was easy to distribute. And to your other question, the assisted living facilities are getting these cards. Those assisted livings that are getting the Binax cards also have to have a CLIA waiver to be able to use them. So that's not all assisted living facilities. They have a CLIA waiver, they're able to do testing. They have a certification that says they're able to perform testing in their facility.
But my understanding is that these are 50-50 on that.
They're more so. In the whole discussion of testing, where I try to stay in my lane is supplying and counting, and I stay out of the microbiology and epidemiology. So I try to follow it. I get confused, and so I stay focused on what I need to focus on. I know there are some current concerns about reliability, and CMS had said, if you use one of these cards to meet the testing requirement for your staff, and you get a positive in one of these antigen tests, you need to confirm that with the more definitive viral, what's called a PCR test. You need to confirm that positive result. You shouldn't make a decision just based on the test result from one of these cards on its own.
Okay, and that makes sense. But what if you're false negative And I think that's, and I mean, I understand trying to stay in your money, Scott, but I think, I think Janice is sitting back there. It's just something everybody needs to, be aware of, and maybe it's a conversation with KBHE, and we can also have this conversation next week on Tuesday, is with the false negative, then you'll work at the problem that we have right now is not so much the people that know they have symptoms are out running around, it's people without the symptoms.
Sure, absolutely.
So you give take a negative on one of these rapid tests and you're out running around, and guess what? You're positive. I think the saliva test is a whole lot easier, and most of our labs can turn that around within hours.
It is easier, and I won't argue the merits of one test or another. The problem with any kind of testing is that you've got to have enough time from your exposure to the virus to develop a response that one of these tests can detect. So there's no guarantee that on the day that I use one of these cards to test myself, that I wasn't exposed the day before and there's no evidence of it, and it won't be for 4 to 5 to 7 days after that exposure. So I would have missed the ability to test my infection because of the exposure date, unless I was going to test myself every day. And it's a question. That's a huge resource constraint if you want to do that. Not to mention the burden. These are not deep nasopharyngeal swabs. These are just inside the nose, but still right.
Well, I'm just, I'm concerned. Again, we'll have a conversation next week, because I'm just concerned with the facilities that still don't have the machines and the testing that they need to have better reliability. Could very easily be the ones that are sitting ready, that are going to be soon. And next thing you know, guess what? We've got some facilities on our hand as a state.
So the receivership. So I didn't address it in here, but just another part of the testing work that I'm the liaison for long-term care is the state testing strategy and the 7 labs that I think Dr. Monger talked about that are providing testing around the state. Long-term care as a group is prioritized as a target population. We've spent a lot of time communicating with nursing, with all the types of facilities that we license, all adult care homes, that these 7 labs that serve across the state are available. They can contract with them, they can work with them to get testing, PCR testing, viral testing performed. It's paid for by Spark. And to use that, if you don't have any other form of testing, you can use these labs, MOD, WSU, USA. If you have a testing instrument or access to Binex cards and you want to be able to get that confirmational test, you can use these labs really to fill in that gap that you identified in the testing, in the range of testing across the state. So
does the lab wait to be paid, or does the facility have to pay and then get reimbursed?
The labs are paid directly by KBHE, so there shouldn't. I have heard, and I haven't gotten a clear answer, but I will for Tuesday, that there's some administration fee if somebody else is collecting the sample. I haven't been able to track that down. And some facilities are charged something, but the cost of the testing itself is provided through Spark.
I think we need to be very careful with that, because I know with the saliva test, you don't have to be a medical image. They're out there training individuals of, how do you get it? How do you give the consent? How do you sign on to the portal so that you can get your results, spit in this tube, put it in the bag, and then take those to the lab.
And there's a lot of variety with those 7 labs. They'll ship a testing kit. I don't need to keep using the same terminology. I don't want to confuse you, but they'll send you a box from the lab of all the things you need to do tests on 50 people. You do the swabs, collect the saliva, whatever it is, put it back in the box, and FedEx, UPS, Postal Service, ship it back to the lab. So that where either you've got a medical person or somebody who can be trained to collect the samples and that's an option that those labs have.
Right, thank you. Other questions on this paper? Representing KanCare.
I'm just going to ask you whether it's here or KBHE, I need to ask this question to. Who makes the decision on how many times a week a facility needs to test? Like if you're a red zone, you test twice a week. Does that come from you guys?
CMS issued that guidance for nursing facilities, so that's where the testing frequency comes from. It's if your county's test positivity rate, so the percentage of tests of PCR tests, viral tests that come back positive, divided by the number of people or number of those tests that are performed. That's over 10%.
Yeah, that's what I have a problem with, is that methodology, because if you have people who have already taken a test from a card and showed positive, then there's a better chance that that person is going to test positive. And
so we can ask that question too.
It doesn't.
So when we talked to KDHE about that, because we shifted, there's a federal data source that produces that county positivity rate that CMS provides. We knew that KDHE could also produce the same number based on a similar methodology, and we were KDHE and KDAD were wanting to use the KDHE collected data in the state because it's faster and it's updated more frequently than the CMS data. So we thought that would be a benefit. So as we were talking about that, we said, well, we need to know, because people ask very intelligent questions, just like we did, of how those things fit together. And KDHE said in their epidemiology system, it looks at the individual and testing results for that individual. So if you use one of these antigen tests and you have the card and you get a positive, that gets reported to KDHE. And then when you do the follow-up PCR test, that also gets reported to KDHE, but they net it out to one result. So there should be very little or no duplication of those positives because it's netted out at the individual level.
Right. I understand that there's no duplication, but there's a higher probability.
Because there be another test done. Sure. That was a concern as well. And
well, what it does is discourage people from testing. Because if you're doing the antigen test, then, you know, it's held against your county or to require more testing. Am I making sense?
I think so, and I understand the concern. The bottom line is that the mandate is on testing, so the testing is going to happen with staff either way. So I don't know that it matters where we get to the positive result. We're not generating more cases because of testing. We're identifying cases because of testing. So, and it's not every county, but there's only 3 or 4 that aren't at twice a week or over 10% now. Anyway, but so I understand the concern, and from a methodology perspective, that falls loosely in the area of counting, but it's not the counting that I'm doing. So that would probably be a better methodology question for
well, I understand that you're not creating cases. I do understand that, and I understand testing. I just think that methodology creates a higher probability of it being positive when reported. So anyway, I'll quit beating up on it.
No, we have it next Tuesday to do that too. Oh, because we actually get to dive in a little bit deeper onto this nursing home stuff next Tuesday, because it is a big topic. So you can proceed.
I thought Representative Carpenter was going to ask a question, so I was pausing, but I apologize.
No, Representative Ballard thought about it, and I said that.
So I think that gets me to slide 24. I'm going to talk a little bit about visitation as well. So we've again, I believe we talked about this a lot the last time we were here. So CMS early on in the pandemic said facilities need to be closed to visitors and outside folks. They lifted or made that a little bit easier in September to make it a little easier to have visitors in, created some more conditions and gatekeeping around that. The important part of that guidance, just to comment on, is that it really emphasized the importance and the recognition that by having residents in long-term care facilities not seeing their family members, people that they're used to seeing and need the support from, was really having a detrimental effect. And so it's good for them to acknowledge that same concern that we've heard. The guidance talked about that nursing facilities should actively promote visitation as long as the community spread of COVID is low. They've got good infection control practices and social distancing inside the facilities. They're doing testing of their staff, which this is all kind of tied around the same time. And visitors can follow facility guidelines. We issued from KDADS a similar guidance document that had those general criteria apply to all adult care homes to have kind of everything on the same playing field. What's changed probably since the last time you all met and since we did that guidance in October is that the case positivity rates just gone through the roof. So I think a facility doing all the right things would probably still have a good case to make that they can't allow visitors in because of spread inside their facility or control, or they don't have the staff anymore to adequately facilitate visitation. But the framework's there, and we think the framework is a good place to start. And then as things calm down, there was some money identified too in both of those, in the CMS document and what we did that Janice talked about this morning. And I've got another slide. I apologize. I put some of the numbers on each of these slides, and then I have a table on slide 26 that has all the numbers of all of that. On slide 25, the visitation guidance that we put out, the other comment we wanted to make was about compassionate care visits. So even if it's hard to do visitation inside your facility, facilities still need to promote what CMS defined or called compassionate care visits, where a resident is really struggling with the transition of moving into a nursing home or failing or they're near end of life. And CMS wanted that to be a very broad definition of what compassionate care would be, so it can be permissive. So that still needs to happen, and that's probably where most facilities are actually focusing their efforts right now on those compassionate care visits. Slide.
Scott.
Oh, sorry. Go ahead. Sorry.
Because of the spike that we've seen in the red zones and green and whatever else we're working with out there, is if a facility has not tried to make the effort, whether it's with plexiglass or with some, I mean, really some way, somehow, how can, is there anything that your agency can help with on that, to maybe contact them and find out, are they short something that's not allowed? Do they not have the machines? Because this is just so huge. I mean, it just broke my heart on an acquaintance of mine that, had a husband for the last 10 years with Alzheimer's, and the last few months, as soon as the feds changed the guidelines, they got excited and finally got to see each other. That's, and then he dies, and you're like, okay, what did we do? And I think we've got people in these facilities that the loneliness is going to kill them. They're not worried about the COVID. Now, I understand we have to also protect staff. It's not just about the patient, but.
So what we, and that's a great question. We hear those not stories, we observe it when we're on survey. I don't go outside, it would be helpful. Our surveyors go out there, they're seeing this as well. And so we tried to figure out what to do about that. So in our guidance that we issued on October 19th, we directed facilities to include in their care planning document for each resident, documentation of a discussion with that resident about what kind of visitation they would like to have, what capabilities the facility had to make that visitation happen, and then some documentation of what the negotiation was from there. So the visitor or the resident, they wanted to have, I want my family member in here every day for every meal, including weekends. And the facility can say, we can't staff that, we can't test them frequently enough, and then negotiate to a meal a week or 1 day a week, and have some documentation of that discussion happening, just so we could see, because I mean, we can't physically go into, well, are going into many of them, but we can't go and check every single one of those cases. So we said, let's require that as part of the care planning documentation process, so that there's a focused discussion about visitation. And part of that was also talking about compassionate care visits. If there was something that needed to be identified that was missed somewhere that a resident would want to raise or a family member would want to raise, use of televideo or other kinds of technology? Are they getting those visits, outside visits through the window? So document that process. So we set a target of facilities having all of those discussions in all of the adult care homes by the end of January, because we needed to, this was in October, and we would give some time to have that. So we're optimistic that those discussions will kind of promote the thinking about it, the understanding of it. That was kind of also at the same time as this kind of rapid acceleration and spread. So I don't know how actively it's happening, but we also, in CMS and the survey guidance, has created or authorized a survey citation about visitation if the facility is not doing what it can do to promote visitation. So that's something we can check on survey during an inspection.
So they'd be best to call long-term care ombudsman, and then they can talk to you about it, or where's the best place for?
They can call our adult care hotline and file a complaint or issue a complaint. In the guidance or in some other communication around that, we really recommended family members, loved ones, people who want to visit, to call the facility and talk to them about it, because that should be the first step. So I didn't want to forget that, but absolutely call our adult care hotline.
I'm not saying it's a random thing. Okay.
It's a difficult thing for facilities too. I think we want to recognize the challenge. Okay. On slide 27 is kind of the visitation funds that we got to either do the devices or plexiglass or dividers. I'm kind of documenting that. So this goes to Janice's spreadsheet. What's our spreadsheet? That's Janice's portal line. So the Janice's spreadsheet, what we paid and what's been approved. You asked about what the totals were. So we'll map this back to that spreadsheet, so it's all in one place for you. With that, I'm going to transition to the state hospitals and just maybe just a couple of points and see what questions you have. I know time is getting short. On the two topics you asked us to talk about are recruiting and retaining staff at Larned, and the status of looking at the moratorium of Waterloo. For Larned, there's still, they've got a lot going on. That's a hospital that is working hard on COVID prevention, but also working hard on recruiting staff. And so we've got on slide 29, the staff vacancy rates, and you can see the November 25th results for security and for the mental health tech positions. That's moving in the right direction. And so that's very, very positive. It's a challenge. The challenges are ones you're all aware of, but it's certainly moving in the right direction. And, on slides 30 and 31, just listing some of the initiatives that the hospital is working on to recruit and retain staff. The one that some of you may see is they've got an advertising partnership with KSN on television and radio, and we've got a couple of commercials promoting working at Larned, and that's they've seen some good take-up from those commercials being seen. On slide 31, we tried to get a little description of what our COVID preparations are. We do have designated isolation units. Those are in use for the most part. We've had that moves around quite a bit, has moved around as the number of cases among patients has increased in the last couple of weeks. But we're doing a good job of maintaining and managing the spread, particularly at Larned. And then on slide 32, the other thing that kind of gives us some optimism about recruiting and retaining staff is the number of mandates. So where we require somebody to stay on for the next shift. And it's a little hard to, so this plots the number of those over the days, number of holdovers by day. And it's hard to see, but there's a dotted line in there that shows the trend, and the trend is sloping downward, which is what we would like to see. It hasn't really gotten significantly worse with our COVID outages over the last couple of months. So again, I think we're in a good spot looking forward to a non-COVID time period. On slide 33, looking more toward Osawatomie, similar information from the last time that we talked about what was in the approved budget. We are moving forward with The remodeling in the Bethell building that would give us some additional certified bed space. We're also using that building as an isolation quarantine unit. So we're kind of kicking the tires on the building before we can jump in and substantially remodel it. But that's going to give you something to kind of see what other work we can do as we move forward with the renovations. On slide 35 is kind of
just put it there before you continue on this while. Wouldn't that 5 million in new spending? I thought the government allotted all new spending, but not that project. No. Everything but that.
I can't say everything about that. Okay. That was huge. So on slide 35, we are interviewing contractors to do the remodeling work that we need in Bethell for that additional certified space. Talking about design and what the treatment model will look like. So that's a good sign that we're moving forward. I think we're still on the right timeline for having that ready to go. Recruiting staff and retaining staff at Oswego is a similar concern. On the last slide of mine on 36, we gave you the vacancy rates, and for the direct care staff, it's just tough. It's a tough environment. That's something that we're going to need to address. Also, kind of aligning some notion responsibilities to get that to fit. But we've got the time to do that. I think with the ramp up as we get up and running. It's a good time as well to recruit staff, bring them on, get them trained in the existing units. And happy to answer more questions about that. The remainder of the presentation are just our data points that you asked us to do regular updates on. I don't know that I'll talk too much about that. The secretary did open the door for me to talk about the state hospitals and just take a minute. We do have active cases among the staff at every hospital. We've got either positive residents or patients at all of the hospitals. It has ebbed and flowed a little bit over time. We haven't lost any. We haven't lost a staff member at Larned, but otherwise, many people have gotten COVID, recovered, and are back at work kind of at that time frame. So the team is working really hard. Superintendents are just, the amount of effort that goes into it is monumental, and we can see that when one of our infection control nurses or a director of nursing is the one that gets COVID, and you can see where there's really not a lapse in treatment or the reporting or follow-up, that there's somebody there to pick up and move on. And I think, that probably runs its course at some point, but it's really a testament to the teams that are out in Warren, SWAT, and Parsons, and Parents Peak at. Just the dedication to the people that we serve has just been really inspirational to me, and really point of some pride of what we've been able to accomplish in a very tough environment. And with that, I think I'll see what other questions you might have. And
many other further questions for Scott today, we will have next Tuesday. All right, thank you very much, Scott. We appreciate you being here today, and we'll look forward to seeing you on Zoom. And I know that our IT people are really working hard to make this work. We had some hiccups this morning. So thank you, sir. I think that's all we had from KDADS and committee. If you look at your agenda, we have presentations from our NCOs behind them. And in lieu of the time issue, I have asked them if they would just add their presentation to next Tuesday, because we do have time in there for them on Tuesday, so we moved them to Tuesday. You also see on your agenda that we have a discussion for recommendations on the report. If you've got some recommendations that you'd like to make tonight, that's fine. You can take and do some of those. We will also have another opportunity on Tuesday, but if you can put those down in writing, that really helps the staff. If we can hand them something in writing, but also knows we're working through things that sometimes it just hits us, oh, I meant to add that, to my list of recommendations, and that will be acceptable. It won't, be taboo. Then we have approval of the September 28th minutes. I have a motion. Motion by Representative Buchanan, seconded by Representative Ballard. All those in favor signify by saying aye. No? Guys appear to have it. Ayes do have it. Motion passes. So are there any, does anyone have recommendations ready tonight, either on Zoom or here in the committee, that they would like to share to go into the committee report? Because next Tuesday will be the last KanCare meeting for 2020. Representative Carpenter.
Thank you, Madam Chair. I don't have these written out. I've just scratching down. One of the things that I've worked on for a number of years, and I'd like to see this committee get behind it, is taking a look at how we estimate our caseloads. I don't know that it'll change anything, but sometimes there may be a better way out there if we have others look at other states and try to nail down the process of caseloads. That's one. The other one is SGF funding of KTRAS. We have struggled with how to fund KTRAS for a number of years. It has saved us millions of dollars in behavioral health and drug rehabilitation over the period of time that it's been in force. And I think that anybody could argue the fact that the whole state benefits from the decrease in drug use and that kind of stuff. So that would be another one. The other one, obviously, I'm sure there's a bunch of people working on it, nursing home liability, included, you know, in the same liabilities that we included in 2016 for nursing homes. And the other thing, and you know, today it's, you know, I feel like sometimes I might as well go over and hit myself against the wall on the head, but you know, we continue to hear about the direct care workforce. I mean, it is, we've heard it today, it's a steady drumbeat of direct care workforce. And, you know, last year I kind of kicked out that meeting, and the NCOs were gracious enough to donate their money. But at some point in time, this is going to become critical. And I've been saying this a long time, and I'll probably be saying it for a lot longer, but we've got, and I don't have the answers, but we've got to take a hard look at our direct care workforce before we don't have any. I mean, it's that simple. So anyway, I'll stop there. At least those are items that are just front and center right now, and I'll certainly answer any questions that the committee might have or anything like that.
Representative Carpenter, I think what I would add on the workforce issue, because I know that several different groups have been trying to look at that, and we've kind of started down that path when we reduced some of our clinical hours here a while back on social workers. Because I think the first place is to look at our education process and see if there's any reductions that can be done there that would help to expedite it, or is there some alternatives to give a person a step in the door to where we can kind of like start growing our own, if we convince individuals to go into maybe a 2-year certification program that then would lead them into that next door, but at least start building some of these healthcare workers in the fasting.
I think that's part of it. I think part of it is just, quite frankly, money. I mean, it's that simple. When they can go down to work at McDonald's or a hamburger place and not have all the stress of worrying about, you know, somebody taking care of biting you, or, you know, I mean, just all those kind of things. I mean, that's extreme, but that's the truth. That's what these folks deal with. And we're paying them $10 an hour to do that, and then go make more than that with no hassle whatsoever. So down the street. And so I think it's the whole concept, it's a multifaceted approach to direct care. But at some point in time, we're just not going to compete. I mean, nursing homes now, you've heard today, we hear constantly about, and you can't, I mean, you can't blame them. Who wants to get tested twice a week and work in that kind of environment for $10 an hour? Are you kidding me? You know, I mean, I'm not being condescending. I'm just talking about reality.
No, it's real, and I don't think people realize how, you know, mentally and physically stressful that job is. You know, so, right. Representing Ballard, representing KanCare, that's fine.
Thank you, Madam Chair. I just was going to follow up on that and say we had a lot of discussion about workforce and the interim committee, special committee on foster care oversight. And that a recommendation was made, was asked for us to take a look at maybe having a task force work on it. And, you know, sometimes I think about that, it's just more talk, but, you know, it would be a concerted effort to sit down and look at some solution and kind of have some hope that maybe an increase in the unemployment rate might help us. Yes. Thank you, Madam Chair.
Representative Ballard.
One I brought up this morning when we were talking about the staffing agencies, but the quadruple of charges for nurses and nurses aides. If there's any way we can look at the charges and how difficult it is in order to even get staff. Is there anything else that we can do about the tremendous increases from agencies?
You know, Representative, I'm not sure that we can, because it's, you know, being a free market system, it's what the market will bear. And because of this workforce shortage, guess what? Supply and demand. No.
Look at that, because it is creating a problem for hospitals. Everyone, they just don't have enough money. What do we do?
Well, it doesn't mean we can't look at it. I'm not telling you no. I'm just saying that I don't see how we can, from a legislative perspective, deal with it. But, you know, it can be looked at, and we can talk about it, but, you know, it's where the supply is, and we're just not yet convincing enough individuals that. And healthcare is really tough, because I think it really requires a passion for that area. I don't think you can say, oh, gee, I just want to go be this for a while. I think it becomes your career.
I don't know. I don't think we can't do it, but we can make a statement or something on to realize that that is creating a difficult time for agencies.
Representative Landwehr?
Yes, Representative Murnan.
Thank you. I have two recommendations ready to go that are pretty simple, and then I've forwarded on to staff if you're ready.
Okay, let me see where Representative Ballard's at.
Oh, I'm sorry.
You got it. Have you already got your recommendations? Or? No. Oh, okay. Just that was a thought. Okay.
That's what we talked about. But I just want to listen. I don't know if we can frame it any kind of way. We can look at it. Well, we know there's nothing to do that, but I'm trying to address it.
Okay. I think our staff can come up with some wording that, you know, that you brought up this concern, and, you know, they question this or something that you can do with it. Okay, that's fine. I can put that in the report. Representative Murnan.
Thanks. Sorry, I didn't mean to interrupt. I can't hear Representative Ballard. I apologize. Okay, so here's my simple one to follow up on conversation from this morning. I recommend hearings be held. Just one moment. I recommend hearings be held in the House Health and Human Service Committee and the Senate Public Health Committee within the first 30 days of the session on the subject of 340B pharmacy.
Yeah, and Representative Murnan, under normal circumstances, meaning non-COVID, I probably wouldn't have a problem with that, but we still do not know how our session is going to run.
I understand.
But you can, you know, so if you want to take and remove your time constraints and say, I, you know, would like to have it happen, but it should happen next year, I'm fine with that. Does that make sense?
Yes. I just really want it to happen. So would you be comfortable the first 60?
That's possible. That might be doable. I've got no words or anything from my leadership team. They're all still trying to work on how the session's going to go, and how our committees and
sure.
Everything.
I would be open to 60 days.
Okay. So representing KanCare, so I think she's upset with you now.
I'm sorry, I didn't hear what you said.
You're still representing KanCare's recommendations, so I think she's upset with you now.
Well, sorry. Maybe she might second my motion so it could move forward. That would be even better.
I don't think we have to do motions on what goes into our reports, do we? Right?
We voted last time, I think.
Pass, go ahead. So you make the motion, Representative Buchanan seconds it. All those in favor signify by saying aye. Aye. Opposed, no. Ayes appear to have it, ayes do have it, motion carries.
Okay, and I have one more that's along the same line, very simple. I recommend informational hearings be held in the House Health and Human Service Committee and the Senate Public Health Committee within the first 60 days of the session regarding the efforts of Oral Health Kansas.
All right, is there discussion? Seeing none, we have a motion by Representative Vernon, a second by Representative Ballard. All those in favor signify by saying aye.
Aye.
All opposed, no. The ayes appear to have it. The ayes do have it. Motion carries.
That's all I have.
We got Tuesday to make recommendations. So, Representative Carpenter.
Representative Vernon, do you have something against Social Services Budget Committee having hearings on things like that? You were a former member, maybe you know something I don't.
No.
Shit, it was healthy.
Are you asking? I'm sorry, I didn't understand the question. Are you asking why Health and Human Service?
I was just joking. I said, you have something against Social Services Budget Committee.
Well, yeah, you know that.
I know.
You know that. You know what I do love about Social Services budget? Always ends at 5. You. I'm sure that wherever this is heard would be great.
As a recommendation, last year it was in our budget and was in, but it was the bill fund IDD. It was what, the $9 million that brought down the increase. I think that's very important to get back on that track. We had a lot of discussion. We heard a lot of discussion this morning about the IDD wait list. But the fact of the matter is that a lot of people don't realize that even if we started taking people off that wait list, they would not have a place to go. We have got to build the capacity first so that we can offer slots and find out what kind of services. It took me a while to come out. For a number of years, I worked on that. Well, let's just take them off the wait list. And finally, the provider's like, don't you get it? We can't take another person. We don't have the staffing. We don't have the infrastructure. We don't have the capacity to take anybody off the wait list. What are we taking 150 a year off the wait list? Maybe. And so that is why that is so critical that we get those folks up to speed so they can build capacity and actually take people off the wait list. Then we can start going to the wait list and see what services those folks need. At this point in time, we couldn't take it.
There was a bill introduced?
Well, yeah, we held hearings on it, but it could not go anywhere because of that expansion. I would.
So what was its bill number?
It's 2510. I'll verify that, but I have the bill on my desk.
The language of House Bill 2510.
Yeah, and I need to check it. It's on my desk. That would be great.
All right. Second by Representative Ballard. Discussion. Representative Buchanan.
I just wanted to add that I think it would,
who testified this morning about creating a list of what the needs are from that waiting list? I think the birds, that's right. I think that would be an important part of that.
And it is part of that. And I'll just,
because I think that helps develop what capacity you need.
Right. And what a lot of people don't realize is that when you go off that wait list, there are 7 services underneath the IDD. You have to take all 7. You may only need 2. And in Louisiana, that's how they did away with their wait list. Was they had separate waivers. They applied for separate waivers for 2 and 3 and 4, and they can take those folks off their wait list. We can't do it until we can provide all 7. So there's a lot of people on there. I would venture to say half those people probably only need 2 services or 3, but we have to wait until we can provide all 7 for them. So that's why our wait list is how it is. So,
but Representative, are we okay? And I do not know the answer to this, but are we sure that we don't already have the data out there and we just haven't collected it and compiled it?
Yeah, 25. I wouldn't swear to that. I'm not.
Okay. I think what I'd like to do is, if we finish up his motion, which is 2550 instead of 2510, and then we'll come back to yours and make a recommendation on that.
Chair, I don't have a recommendation. They just shared with us that they're working on the list and they should have it done within the next few months.
And so if that's the case, then what the process would be is we would have to apply for waivers for that number of services. For instance, if it was 2 or 3 or something. Keep in mind, 67% of these folks are already receiving Medicaid. So there are 67% of them are already on Medicaid for medical.
Thank you, Madam Chair. For clarification purposes, may I ask, the version of House Bill 2550, is that as amended by House Committee? So the most final version?
Yes. Yeah, is it 15?
2550.
2550.
Okay, yeah.
She's just confirming that once you worked it and added amendments, that you want that version, not the one you opened up with.
Right. Thank you. Sorry about that. I didn't remember amending it.
Well, we do a lot of stuff. Anything further, committee, for today? All right, then we will go ahead and adjourn until December 15th. Tomorrow.
Well, I was, but they said 3 o'clock. I said, no, already.
We'll know. Yeah, no.
So now, well, tonight you can always
Okay, all right. Yeah, I have it written down.